morning, ladies and gentlemen. Welcome to the second day of our seminar. We have again very busy schedule. There are 5 presentations this morning, and I have a feeling the first one might be a little bit more entertaining than usually. So without further ado, I'll give a word to the moderators, Jessica Davis from Indiana and David Papke from Harvard, Boston. Thank you.
Test, test. Good morning, everybody. Thank you all so much for the invite. It's lovely to be here. Really appreciate Dr. Michal and Dr. Michal for throwing this party. This is an amazing setting. I'm Michael Kallen. I'm thrilled to be here. Today we're going to be talking about hematolymphoid neoplasms 101 for BST pathologists. I flew a long way to be here. I crossed the Gulf of America, and then I crossed the American Ocean, all to be here with you guys. Sorry, the Ocean of America. I no longer know what to call the Atlantic. Okay. I have a wee bit of declarations to make. None of these affect this lecture, of course, but I figured I'd declare anyway. Okay. An alternate title for today's, it's not a lecture without a frog meme. An alternate title for today's talk could be How to Catch Lymphomas and Stay Out of Pathology Jail. So today's objectives, we're going to do a practical refresh on heme tumors which are confusable for sarcomas. It is my goal to give you confidence and also to give you hope and also to give you IHC panel recommendations so that you know how to approach some of these lymphomas. I am not going to show you a ton of DLBCLs and a ton of classic Hodgkin lymphomas. Number one, I only have 20 minutes, but number two, I don't think people miss those. The stuff we see in consult that gets missed, most of the time people see sheets of aggressive-looking, angry-looking B cells and get that right, and don't confuse those for sarcomas. Occasionally, Hodgkin is a problem, but people know about CD30 and about, and those present with lymphadenopathy and systemic symptoms. It's not a huge pitfall. Instead, we're going to focus on some other stuff which gets missed. We cannot entirely forget about heme here in bone and soft tissue land because leukemias and lymphomas are a challenging mimic of sarcomas. The classification is distinct. It uses totally different workups and antibodies from everything else we do in SurgPath. Importantly, the treatment for lymphoma is not surgery, and therefore a miss can lead to serious patient harm. There's nothing sadder than getting a resection after you signed out your needle biopsy and they did a big cancer resection, and it's a lymphoma. That's not a great feeling. The situation for this is most dire on small biopsies, in which missing a lymphoma could trigger a resection. And so at my hospital, and maybe some of yours, our first crack at mesenchymal tumors is actually by FNA through the cytology service, which is a choice, which makes it even harder. So limited material. On a biopsy of a brand new lesion, we start with a broad approach. First question, tumor versus no. Second question, benign or malignant if it's tumor. Third question, can we categorize this? But I am out here to pump the message that on a small biopsy, which is being shown to the sarcoma service, do not forget about lymphoma. Job number one, remove things from the differential which are non-operative. This is a completely different management. You do not want to miss lymphoma, and it's tricky in small tissue. So if I can't exclude lymphoma with 100% certainty, I shamelessly ask for more tissue. If I am not 100% sure it's not a lymphoma, I'm asking for more. Yeah, okay. So here's my little mental algorithm. It's a neoplasm. Could it secretly be hematopoietic? Maybe. Here are some things that we're going to think about and work up because they can mimic sarcomas. If there's no chance it's heme, then we go down the pathway of carcinoma, melanoma, germ cell tumor mets, sarcomas, and things which are not, everything else. Okay. So for case number one, this is an adult with a lytic lesion of the humerus. The imaging shows diffuse lytic lesions, and the lab workup shows anemia and hypercalcemia. So already we're thinking, and this is also a heme lecture, so already we're thinking, could this be myeloma? So here's what looks to my eye like bone marrow. It's very bone marrow. You got hematopoietic cells in there. I see a MEG, I'm going to try this fancy trick everybody does. Ooh. There it is. That's a MEG. So all of these things to my eye look myeloid. Those look like neutrophil precursors to me, which shows you how hard this is. I run into this all the time. I don't know how anybody made the diagnosis of myeloma in the time before IHC and the time before flow, because that, to me, that looks like bone marrow. Call me crazy. Anyway, here's another slide which looks even more like bone marrow, except for one dysplastic MEG, which is another clue that something bad is happening in here. It's also a little bit cellular, but these are reamings. The surgeon pinned it and reamed it out. He's sending us reamings. Here's an aspirate smear in case anybody here is cytology inclined. And again, this does not scream plasma cell neoplasm to me. I see some plasma cells, like that one. And I mean, there's a couple swimming around in here, but the vast majority of these, this is not sheets of plasma cells. And another pitfall, osteoblasts. Osteoblasts in aspirates look just like plasma cells, and they're CD56 positive. So if you throw a CD56 down, you will stain all of the osteoblasts in your sample. So that won't bail you out either. Okay, so have we ruled out a plasmacytoma here? Unfortunately not, because here's the CD138, right? Nobody saw that coming. I didn't see that coming. I use CD138 liberally. If it might be a myeloma and it looks like bone marrow with a ton of myeloids in there, just slap on a CD138. And problem, CD138 stains other things which are not, it's very nonspecific. It stains carcinomas. It stains metastatic prostate adenocarcinoma, which has been miscalled myeloma before to devastating effect. And so I'm a big believer in MUM1. MUM1 is a nuclear marker. We like nuclear markers. Get a MUM1. If it's 138 positive and the patient's got a history of prostate cancer, it could also be a carcinoma. Don't just roll with CD138. Okay. I also use kappa and lambda. These are hard to read. IHC are difficult to read. On your left is kappa, on your right is lambda, and you can see cytoplasmic lambda staining. It's kind of got this dirty granular staining pattern. And so this is lambda light chain restricted in this example, but it's hard, right? There's always, lambda is a better stain than kappa in most people's labs, but this is hard. I showed another case which is slightly easier to make everyone feel better about their lives, but here kappa has stronger staining and lambda is dead negative. So this is very clearly monotypic. We lean heavily on monotypic light chain expressions to call this a tumor. Because why couldn't the patient have polytypic plasmacytosis, which they often have in bone marrows, especially when there's some systemic inflammatory thing going on, like a lot of our sick patients in the hospital have. So anyway, this one's a little bit easier. They are not always this easy. And it's particularly challenging if you've got like 10% plasma cells in the field that you're looking at, and it looks like an even mix or a 2-to-1 mix of kappa to lambda. There could still be a clone in there, just a little one, and an equal amount of reactive plasma cells in the background. And so other things that we do, okay, for some problems. Plasma cell neoplasms can be very patchy with sparse disease in some areas and sheets in others. These are liquid tumors. They settle as they will. You can get hot spots and cold spots in marrow reamings. Plasma cells look like myeloid precursors on H&E, at least they do to me. I spend long hours gazing endlessly, deeply into their eyes. They just look like myeloid precursors on H&E. H&E is not a great stain for this. CD138, very nonspecific. Also, plasma cells, next time you get an immunostain and there's plasma cells in your biopsy, notice that it can label the cytoplasm of your plasma. There's nonspecific staining in plasma cells that's full of immunoglobulins. And so it makes sense that various IHC stains can label the cytoplasm of plasma cells nonspecifically. So that's a pitfall. Flow can miss these because plasma cells are weird. They survive forever after chemotherapy. They're the last man standing in the bone marrow. They live forever in a bone marrow. They're like cockroaches. They never die. But in flow, they're snowflake. They die first. So it is not uncommon to look at a bone marrow that's been chemoed to death and it's only got plasma cells. We're like, myeloma? What could this be? And then we look at the flow And there's no plasma cells at all. There's poor recovery. So these things don't do well. They don't hang out for a long time in flow. So that's a pitfall also. These things get missed on flow. They really need us to make this diagnosis in the biopsy. And then the last pitfall is that other lymphomas can produce clonal plasma cells. We see a lot of LPL, we see a lot of marginal zone lymphoma with plasmacytic diff, and we see a lot of plasmablastic lymphoma. Okay, how do I advance? Oh yeah. So solving the problem, what am I supposed to do about it? Let me give you some solutions. MUM1. MUM1 is a big solution. It's nuclear. It's not ultimately specific for plasma cells. It also labels post-germinal center B cells and some T-cell lymphomas and some other stuff. But it doesn't miss myeloma. If you throw a MUM1 down and it's not impressive, it's probably not a plasmacytoma. This is a good marker. Other useful stains, we use kappa and lambda. I prefer ISH. I prefer in situ hybridization because it's better for plasma cells. IHC is better for B cells. ISH is better for plasma cells. The problem here is that if your bone marrow is decaled, it can screw up, it can degrade the signal of the ISH stain. So if you're looking at decal tissue, which many people in this room obviously do, the ISH may be completely weak or just negative. Check your controls. Check your positive control, make sure it worked. Other stains we use are markers that are aberrantly or the expression in the plasma cells is abnormal. So we use 56, 117, cyclin D1, 79A, 2019, and heavy chains. These are the other tricks we have up our sleeve to determine that a plasma cell population is clonal if the flow doesn't work. So with 56, a subset are positive in normal plasma cells, that's fine. But if they're all CD56 positive, that's a tumor. That's a tumor. CD117 is the same thing, except it'll pick up your mast cells, of which there are often a lot in soft tissue and bone. So be sure that what you're looking at are plasma cells and not mast cells. I like to match it to the CD138 or the MUM1. Make sure it's the same pattern of distribution. Cyclin D1 likes to label histiocytes, but it's positive in plasma cells with T1114, and even worse, those plasma cells look small and like B cells, and so those will mimic lymphomas. So we use cyclin D1, and then you get abnormal expression of other B cell markers in the plasma cells, and we can try heavy chain IHC if we're looking for a restricted pattern but can't find one. Anyway, that's how we solve this. Here's my recommended panel. The bottom line. You worried about missing a myeloma, and you should have a high index of suspicion in a patient like this. Get a 138. I encourage you to get a MUM1 if you've got one. It's great. Kappa lambda, I prefer ISH for plasma cell stuff. And then if you still have unstained left over, try 56 and 117. Also, check electrophoresis, SPEP and UPEP, on every patient with an unexplained lytic lesion, and you're not giving them a better answer. It can be subtle. They can have smoldering disease. There are various categories of plasma cell neoplasms which are not straight up myeloma. There are precursor lesions, and then it's 1% per year after the age of 50 of people who will pop a little M spike in their blood. And so these are relatively common. You will see these. Everybody misses these sometimes. Okay, so that's plasma cells, and I'm not completely out of time. That's good. All right. So now we're going to move on to case 2. Oh, this is a doozy. This is a 50-year-old patient with a large chest wall soft tissue mass, and you can hear them in the OR, and they're sharpening their knives to cut out this soft tissue mass. They're ready. They bring their A game. Thank God, so do we. Okay, so obviously a tumor, obviously sheets, obviously blue. So already sort of in heme land. When you look at it, we don't see normal lymph nodal architecture. It's effacing. They've got this kind of, I don't know, I don't think the cells are all that big. I try and compare them to background normal lymphs. I don't see a whole lot of background normal lymphs in this case, which makes it hard. But, you know, these do not strike me as gigantic, just the cytology of them. I see vesicular chromatin, I see little pinpoint, or sometimes not so pinpoint, distinct nucleoli. And there's actually a moderate amount of cytoplasm. They look a little discohesive, they're forming sheets, and there's a little bit of pleomorphism in here. And so here it is at higher power. You can see some of them have a little cytoplasmic clearing, and I see a few giant nucleoli in here. And so somebody went through, before sending it in, somebody went through their panel with a couple of keratins, a couple of melanoma markers, a Desmond, a CD34, all this good stuff on their beginning WTF panel. And what we have here is nice positive CAM 5.2, okay? And here's EMA also positive. So we're gonna call this thing a carcinoma, and we're moving on. Refer it to a surgeonc. And here's MUM1. They sent us a MUM1. Is this an anaplastic myeloma? Of course, I wouldn't be showing it if it was routine or simple or easy. But the key most important stain in this entity is CD30. It's every cell, it's membranous, and it's Golgi. This is a required marker in this diagnosis. It's every single cell. It's also ALK positive, diffusely strongly ALK positive. And so I hear some people mumbling the correct answer. Don't be shy. Yes, I heard it. So this is ALCL, and it's the ALK positive subtype. This is a CD30 positive mature T-cell lymphoma with frequent extranodal involvement, and particularly in the soft tissue, and sometimes we see it in the bone. Most cases are very pleomorphic with hallmark cells, which to me look like little horseshoes. They can mimic pleomorphic sarcomas. I think probably half the ALCLs I see could be easily screwed up and called UPS, no problem, if you don't think about it. So there is danger here. And in lymph nodes, it loves to have this sinusoidal growth pattern, and it gets sent in with a diagnosis of metastatic carcinoma, and you can get them to stain with keratin sometimes. So, yeah, not a surgical disease. Here's a picture from the big book, the blue book, the WHO, which I'm showing you this because I think it looks like a UPS. I could easily get on board with the pleomorphic sarcoma. I don't know. This is another one from the book, which to me, this shows you the many faces of UPS. This to me looks very histiocytic. If you told me this is a histiocytic sarcoma just off the H&E, I believe you. This is the lymphohistiocytic pattern. There are several patterns of ALCL. Anyway, tips and tricks. CD30 is a must. If you can't get it to stain strongly and convincingly for CD30, it's not ALCL. So I throw around a lot of ALCL on things which ultimately get called UPS. I'm not shy with this antibody. And it's good if it has membranous and Golgi staining patterns, but it's got to at least be membranous. Cytoplasmic doesn't really count. If you've got weak, wimpy cytoplasmic only CD30, and you know your antibody is good, that's not ALCL. It's got an ALK positive and ALK negative subtype, but importantly, the ALK positive, the small cell pattern, which is the case I showed you, that's a small cell pattern of it. I think it's ironic that a large cell lymphoma has a small cell subtype. But the small cell variant of ALCL is always ALK positive. So if it's ALK negative, you don't have to worry about that. Here's the trap in this diagnosis. There's something called the null phenotype. Many cases, in fact, most cases we see of ALCL are negative for your T-cell markers. CD3, dead negative. CD45, dead negative. You can't use 45. People have this basic heme panel they use where they get a 45, a 20, and a 3. That will miss this every time. Because they're supposed to be 45 negative, and something like 75 or 80% of them are CD3 negative. And so this is the null pattern, the null phenotype for ALCL. They will still express cytotoxic T-cell markers. So if you have those, you can try them. And they should have clonal TCR. So if your lab does TCR, you can do that and prove it. Do not screen with 45. Feel free to please screen with CD30. And CD43, if you're looking for a marker that stains primitive hematopoietic stuff reliably, and you've just heard me, insult CD45, use CD43. It's a better marker. That should label these, and MUM1 works here too. MUM1 is a magic marker. You can get it to stain whatever you need. If you need a marker to highlight something, you don't know what it is, get a MUM1, it'll work. Okay. Always in the differential with this is classic Hodgkin. I use 15, if you have heme, turf to heme. If your group has heme, just get rid of it, that's a great option. But not everybody here has a lymphomaniac in their group. So exclude with CD15, PAX5, Eber-ish. If it's EBER positive, it's not ALCL. There was never an ALCL in history which was EBER. I won't say never. It's not a thing. We do not call it ALCL if the big cells are EBER positive. CD45, no bueno, and you can try monoclonality testing to prove it. If it really is a null cell thing and you cannot get it to declare itself Hodgkin versus ALCL, we sometimes do rearrangement testing. But anyway, that's ALCL. I might be out of time here in a minute. So the takeaway points, we already did this. In my last case, in my remaining 30 seconds, this is a skin. A lot of people in here see derm. It's very blue, it's very infiltrative, it's very monotonous. The cells are big, they're ugly, they're pleomorphic, they got big nucleoli. This is CD56, dead positive. There's CD123, diffuse sheets. This one had TDT, thank God, makes it easier. In our differential, should be heme stuff. I could see a big blue Goomba in the dermis like this. I could see a lot of different non-heme tumors being in the differential. This is a blastic plasmacytoid dendritic cell neoplasm. Why am I showing this? A lot of derm people have heard of this and know about this and think about this, but a lot of surge path are unfamiliar with it because it's rare. It presents in the skin and then they disseminate systemically. If you need a mnemonic device, I like 1, 2, 3, 4, 5, 6, CD123, CD4, CD56. And then, let's see, the challenging separation is from a monocytic AML. A lot of monocytic AMLs can express 1, 2, 3, 4, 5, 6 and have a completely different prognosis and treatment. This is a nasty disease. This is a bad disease. And so we do more, if we're in this trap, we do more markers. You can't just slam bang something out as BPDCN anymore because it could be a monocytic myeloid sarcoma. Anyway, I think I'm out of time. Here's another case I brought of it. Do I have a last slide? Take home points. Here are my minimalist recommended panels. And thank you, everybody. Here's my dog. I'll be happy to take questions. I think we have time for just one question. I stunned everybody into silence. Yeah. We got one in the back there.
Thank you for this nice presentation, and I know that it was impossible to cover everything, but I think there is a entity which is quite rare, but for soft tissue tumors it can be a diagnostic pitfall, and I'm interested if what is your experience with it. This is the sclerotizing extramedullary hematopoietic tumor, which is an extramedullary manifestation of myeloproliferative disease, usually myelofibrosis, and it's indeed looks like as a burnout myelofibrosis with many fibrosis and dysplastic megakaryocytes. So it can mimic usually liposarcoma, but so for the soft tissue tumors, I think it can be a very challenging entity, and I'm interested, what's your experience with it?
Great question. Thank you for that. Yes, we sometimes see extramedullary presentations of MPNs. It's a thing. We see CML, CMML, and then we see MPNs which go bump in the night and go by. The WHO and the ICC are currently beefing over this topic on what to call. This is the most complicated area of disagreement, of conflict between the two competing heme systems is MDS-MPN. And so I unfortunately make 3 diagnoses on every report now, old WHO, new WHO, ICC. It's great for my turnaround time. And if we think that's what's going on in the soft tissue, it usually requires NGS with the myeloid panel to support that, and the patient will usually have weird cytopenias or cytoses. That's a hard thing to do by just H&E. You need lots of support. Great point. That's a complicated area. Yeah. Okay, thank you, Michael.
Okay, thank you. So I'm going to talk today about mesenchymal tumors of the GI tract and also myxoid inflammatory myofibroblastic sarcoma, or I'll say myxoid IMS for short. So we'll start with mesenchymal tumors of the GI tract. So there are many different mesenchymal tumor types that can occur in the GI tract, and clearly we don't have time today to go through all of them or even most of them. So I decided to focus on a few. I think we need to talk about GIST. It's the most commonly encountered mesenchymal tumor type in the GI tract, so you'll see them even in general practice settings with some frequency. Then I'll also touch on glomus tumor and synovial sarcoma, where there have been some recent updates, and I'll touch on IMT as well. So GISTs. So GISTs are by far the most common clinically significant mesenchymal tumor type that you'll encounter in the GI tract. Therefore, you should really consider always excluding this diagnosis when you encounter mesenchymal neoplasm in the GI tract, especially if you don't encounter these very often in your practice. And fortunately, immunohistochemistry is very useful in this regard, as we'll discuss. I'm going to focus on gastric GISTs because these are some of the more challenging ones. There are different genetic subtypes and different morphologic patterns. So 70% of gastric GISTs are purely spindled. About 20% are purely epithelioid. 10% show mixed spindle cell and epithelioid morphology. And then rarely you can encounter pleomorphic GIST or dedifferentiated GIST. The reason we care about these morphologies is that they correlate with the underlying genetics. So spindle cell GISTs in the stomach are almost all KIT mutant. Epithelioid GISTs are sort of an even split between PDGFRA mutant and SDH deficient. The mixed ones tend to be KIT mutant as well. And this is important for therapeutic purposes and even for prognostic purposes in the case of the SDH deficient GISTs. So we'll go through these different genetic types. So KIT mutant GISTs, these are mural masses. They tend to occur in the submucosa or the muscularis propria or even the subserosa. Classically, they are fascicular spindle cell neoplasms, as you can see here with these sort of intersecting fascicles. Some of them have a looser sort of growth pattern and stroma. In these cases, the stroma looks a bit fibrillary. So this is a KIT mutant mixed epithelioid and spindle cell GIST. One of the best clues to the diagnosis is a monomorphic cytomorphology. So the cells all sort of look the same. They have these elongated tapered nuclei, syncytial growth, and this sort of fibrillary looking cytoplasm. A helpful clue when present are the paranuclear vacuoles, but it should be noted that these can also sometimes be seen in schwannomas and leiomyomas, so they're not entirely specific, but they're a helpful clue when they're present. So PDGFRA mutant GISTs look different. These are entirely epithelioid, and let's see if I can get this to work. Yes. And they commonly have this hyaline or myxohyaline stroma, which is a useful feature when present. It's fairly specific for PDGFRA mutant GISTs. The cytomorphology is again very bland, so these have pretty uniform ovoid nuclei. These can show either syncytial growth or sometimes more distinct cell borders. SDH deficient GISTs have a very characteristic low power look. So they have this multilobular growth, which is very specific for SDH deficiency among GISTs. So if you see this growth pattern in a GIST, it's almost certainly SDH deficient. Within the lobules, these tumors are usually epithelioid or sometimes even a bit rhabdoid, like we're seeing in this case. SDH deficient GIST show some uncommon features, or they would be uncommon in other genetic GIST types. They commonly show lymphovascular invasion, and they also commonly give rise to lymph node metastases. So it's pretty easy to diagnose these. So we use SDHB immunohistochemistry as a screen. So SDHB is part of the succinate dehydrogenase complex. There are 4 subunits, A, B, C, and D, all of which can be inactivated in these SDH deficient GISTs. If any of those are inactivated, then expression of SDHB is lost. So here we're looking at an SDHA mutant GIST, and you can see on the right that there is loss of SDHB, and on the left, there's also loss of SDHA, which is specific for SDHA mutations. So if you diagnose one of these, you're not done. These patients should be referred for germline genetic testing because they have a high probability of having an underlying cancer predisposition syndrome. So we're all familiar with the prognostic scheme developed by Drs. Lasota and Miettinen at the NIH. I'm bringing this up now because we don't use this for SDH-deficient GISTs. So SDH-deficient GISTs have a unique biology. They're slowly but surely progressive. They recur locally, which is unusual for other GIST types. They give rise to lymph node metastases. So risk stratification does not work on these tumors. To round out the other types, so pleomorphic GISTs, these are very uncommon. And historically, we didn't really know what to do with these. A couple of my colleagues at Brigham, Drs. Isidro and Hornick, recently looked into this and found that actually pleomorphism has no independent prognostic value. So if you just risk stratify these like normal, that'll predict the outcomes. In contrast, dedifferentiated GISTs are very bad actors. So here we have a PDGFRA mutant GIST. You can see it on the right. And then there's a sharp transition to basically high-grade pleomorphic sarcoma NOS, which didn't stain for KIT or DOG1 or anything. So these can be very hard to diagnose. You often just need to also have the differentiated component to make the diagnosis. And these do very poorly. So these are high-grade sarcomas. They're very aggressive, and they often don't respond to targeted therapy either. So how do we diagnose GISTs in general? So KIT is one of the stains that we use. So KIT has these different staining patterns, cytoplasmic, membranous, and Golgi dot-like, but they all count as positivity. And KIT is very sensitive and specific for GIST. We also have DOG1, which is also known as anoctamin 1. It's a chloride channel expressed in the interstitial cells of Cajal. It's, again, very sensitive and specific for GIST. So if you use both of these markers, you'll be left with just under 3% of GISTs that lack expression of both KIT and DOG1. And these are almost entirely epithelioid PDGFRA mutant GISTs. Here's an example of one of those. So this is a PDGFRA mutant GIST. It's negative for KIT, negative for DOG1. And in this scenario, you can use immunohistochemistry for PDGFRA, which is diffusely positive in this case. So we use this occasionally as a diagnostic marker. We also use it as a predictive marker for underlying PDGFRA mutations. But you do have to be a little bit careful and use it the right way because it's not the most specific marker. So here's a schematic of how we use it. So if we suspect the diagnosis of epithelioid GIST, we'll run DOG1 and KIT. Usually they'll be positive and you'll get your diagnosis. And then in that case, you'll want to run SDHB and PDGFRA to try to figure out if it's PDGFRA mutant or SDH deficient. If DOG1 and KIT are negative and you still very strongly suspect it's an epithelioid GIST, then you can use PDGFRA as a diagnostic marker and then render the diagnosis of a likely PDGFRA mutant GIST. So we've talked about the workup. I'll just mention that KIT and DOG1 are very good markers to exclude other entities in the differential diagnosis, like schwannoma, leiomyoma, glomus tumor, et cetera. Okay, now we'll move on to glomus tumor. So glomus tumors are most common in the distal extremity in the nail bed. These are rare in the GI tract, but when they do occur there, they have a predilection for the stomach. These occur across a wide age range, and they tend to be centered in the muscularis propria. And we know now that most of these have gene fusions involving Notch2 and this cardiac microRNA cluster, Carmin, in up to 90% of cases. So here's sort of a prototypic example. These are multilobulated tumors. You can see these lobules infiltrating through the muscularis propria. One of the differential considerations at low power would actually be an SDH deficient GIST. But these within the lobules look quite different. They often have prominent vessels, as you can see here. And the cytomorphology is different. These have very uniform cells with round nuclei, pale eosinophilic to cleared out cytoplasm. And you can appreciate, if you look around, that there are distinct cell borders between the cells. So this is a very characteristic cytomorphology. If you look at the periphery of these tumors, you often find perivascular proliferation of tumor cells, which is another nice diagnostic clue. Sometimes this can take the form of little lobules of tumor cells that bulge into vascular lumina. This is a common feature in glomus tumor. This has no prognostic significance. This is not lymphovascular invasion. It just reflects the perivascular nature of these tumors. So SMA is essentially always positive, and it usually has this unique staining pattern where it highlights the membranous contours of the cells, the shapes of the cells. So it's sort of a specific SMA staining pattern. Kel-Desmond is usually positive as well. One pitfall to be aware of in the stomach is that synaptophysin is positive in 70% of gastric glomus tumors. And this presents a major pitfall for misdiagnosing a well-differentiated neuroendocrine tumor, which is one of the main differential diagnostic considerations on H&E. If you're considering diagnosing a well-differentiated neuroendocrine tumor and keratins are negative, you need to take a step back and think about glomus tumor. Well-differentiated neuroendocrine tumors are essentially always keratin positive. So historically, gastric glomus tumors were thought to be unpredictable. We recently re-examined this in our own institutional cohort, and we actually found that you could use criteria similar to those used at soft tissue sites. So we found that if the tumors are either large or if they have nuclear typia with at least 2/10 mitotic index, that separated our cohort into benign tumors and malignant ones. The benign tumors didn't do anything. They didn't recur or metastasize. The malignant ones metastasized about 70% of the time, and those gave 5 of those patients actually died of their metastatic disease. So these were aggressive malignancies in the metastatic setting. One interesting thing that came out of our study, we found some genetic differences between the benign and malignant glomus tumors. So both benign and malignant glomus tumors have Notch2 fusions that had already been well established. But we found that the benign tumors basically had the Notch2 fusion and nothing else. They had these very flat copy number profiles, whereas the malignant ones had these complex copy number alterations, including loss of tumor suppressor genes. So the Notch2 fusions are probably insufficient to drive malignancy on their own, and you need additional hits with tumor suppressor losses. So copy number analysis could be useful in borderline cases, we think. So we've talked about the workup. One other differential diagnostic consideration is epithelioid leiomyosarcoma for malignant glomus tumors. Epithelioid leiomyosarcomas are exceedingly rare outside of the uterus. If you're thinking about diagnosing one in the stomach, you really need to take a step back and think about malignant glomus tumor. Actually, in our series, a couple of those cases had been misdiagnosed as leiomyosarcomas, and on sequencing, we found the Notch2 fusions. Okay, synovial sarcoma. So this is an aggressive malignancy, 50% metastasize. Like glomus tumors, these are rare in the GI tract, but they have a predilection for the stomach when they do occur there. There are different variants, monophasic, biphasic, and poorly differentiated. And these have gene fusions between SS18 genes and SSX1, 2, and 4, which we'll come back to. So here's an example of a gastric monophasic synovial sarcoma. You can see it's a mural mass. It's very infiltrative in the muscularis propria. It's a fascicular spindle cell neoplasm, and it's very cellular. In fact, it's so cellular that even in a 4-micron section, the nuclei overlap with one another. And that's one of the helpful diagnostic clues, the overlapping nuclei. Another clue is this wiry collagen. So there are thin strands of collagen that are running the lengths of some of these fascicles here. And these often have prominent staghorn vessels, as Christina Antonescu showed yesterday, which is a helpful clue particularly for the poorly differentiated synovial sarcomas. A third of synovial sarcomas show dystrophic calcification. Sometimes this can even be pseumomatous. So for IHC, EMA is positive in most cases, and keratins are positive in most cases as well. But now we have these new markers, which we're using routinely at Brigham, and I hope I can convince you guys to start using them too, because they're very nice. It makes it easy to diagnose synovial sarcoma. So these markers were developed by some of my colleagues, and they leverage the fact that the SSX1 and SSX2 fusions both have the same protein sequence at the fusion site. So they developed an antibody against that specific protein sequence. They also developed an antibody against a C-terminal sequence in SSX, which is conserved in all of the SSX genes. And so here's what those antibodies look like. SS18 SSX is 100% specific for that fusion sequence, but it misses the SSX4 fusions. The SSX antibody is 100% sensitive. It picks up all of the SSX fusions, but it's not 100% specific. It can occasionally stain other tumor types. So the way we use these is, if SS18 SSX is positive, you're done. It's a synovial sarcoma, end of story. If SSX is negative, it's not a synovial sarcoma. You need to think about other things. And then if you get an intermediate result, that's when we consider doing molecular testing. Just to round out the different patterns, so biphasic synovial sarcomas show gland formation. It's a helpful clue when it's focal, but it can actually be very deceptive. So this is a biphasic synovial sarcoma that's dominated by the glands. You can see there are some small foci of spindle cell morphology, which was a clue to the diagnosis in this case. But of course, in the stomach, this would be a major pitfall for misdiagnosing an adenocarcinoma. But if you think of the right stain, if you think of synovial sarcoma, you can prove it with the antibodies or with molecular testing. Poorly differentiated also can present some pitfalls. The key to this are the branching vessels, which are very unusual in carcinomas. If you look on higher power, you see that this does, on a cytomorphologic level, resemble a high-grade neuroendocrine carcinoma. These usually have keratin expression. They can show expression of synaptophysin as well. So that's a major pitfall, but the vessels should give you some pause. And again, if you sort of think of the diagnosis and do the right stains, you'll get there. So I've talked about the workup. SS18, SSX, and SSX antibodies have changed the way that we approach synovial sarcoma. And in the interest of time, so I don't run out, I'm just going to move to my take-home points for mesenchymal tumor types of the luminal GI tract. So you have to exclude GIST, especially if you don't encounter these tumors very often. There's no shame in just doing a kit and a dog one if you encounter a mesenchymal tumor type, even if you think it's probably not a GIST, just to be safe, because they're so much more common than other mesenchymal tumor types. And immunohistochemistry in general is very useful for mesenchymal tumor types of the luminal GI tract. Okay, so in the last few minutes, I'm going to talk about myxoid inflammatory myofibroblastic sarcoma, or myxoid IMS. I'll set the stage by just talking briefly about IMT. So IMT is a rarely metastasizing tumor, so it's sort of intermediate biologic potential. When these occur in the limbs, they basically don't metastasize. The ones that rarely do metastasize occur in the lung or in the abdominal organs or cavity. IMTs usually harbor receptor tyrosine kinase fusions, most commonly in ALK, but also in ROS1 and other receptor tyrosine kinase proteins. The RTK fused tumors tend to occur in younger patients. And the metastases tend to be in older patients and in ALK negative tumors, which is interesting and I think something that we might consider revisiting now in the modern molecular era. So here's a typical IMT at low power. They look very blue, very inflamed. Here's another IMT, and you can see, again, it looks sort of blue and inflamed. It is infiltrative. You can see it's infiltrating some fat here. But you can kind of draw a line around the tumor. These sort of grow as one sort of mass. If we look closer, you can see it's a fascicular spindle cell neoplasm. It's inflamed. These often have stromal collagen, which is a nice clue. It's present just in general in a lot of myofibroblastic tumor types. And these have myofibroblastic cytomorphology with vesicular nuclei and small distinct nucleoli. So these express SMA in most cases. ALK expression correlates with the underlying fusions. ROS1 expression correlates with the underlying fusions. And really, I just wanted to present this sort of as a springboard to talk about epithelioid IMS and then myxoid IMS. So just very briefly, epithelioid IMS is a sort of variant of IMT. These sometimes can be quite hypocellular, as in this example. They're often myxoid. And the cytomorphology of these is different from regular IMT. So these have big ganglion-like neoplastic cells with big nuclei, stellate shapes to the cells, and they have these very prominent nucleoli. So these have a specific ALK fusion involving this nuclear binding protein, RAMB2, which leads to nuclear membranous expression of ALK. And so, these have a sort of specific clinical context. They tend to occur in the abdomen in males, and these are very aggressive. So we want to specifically recognize them to potentially triage patients to targeted therapy. Okay, so myxoid IMS, I think in some ways is analogous. It has significant morphologic overlap with regular IMT, but there are some recurrent differences. These have bland cytomorphology, but that's sort of deceptive. They give rise to distant metastases or peritoneal dissemination in 40% of cases. And in our series, 30% of patients died of disease. So this is definitely more aggressive than regular IMTs. Here's the age and sex distribution. So they occur sort of equally in males and females, and they occur across a wide age range. And if we look at the body site distribution, you'll see that there's this predilection for the peritoneum. And those tumors in green were multifocal at presentation. which again would be unusual for regular IMT. So these half the time present with multifocal peritoneal disease when they present in the peritoneum. Here's what they look like. So these are multilobular tumors. You'll see these myxoid lobules that are infiltrating native tissue. Here's another example. This is a different tumor. This one is infiltrating the diaphragm. Again, it's myxoid, multilobulated. This one had a PDGFRA fusion. Here's another example. This tumor is just plowing right through the omentum. Again, you can see that there are lobules as a component of the tumor. This one had a PDGFRB fusion. Yet another example. This one is, again, plowing through the omentum. There are even little nodules out here. Looks just the same as the other ones. And this one had a hotspot KRAS mutation. If you look at the lobules, these are very myxoid. They have sort of discrete foci of inflammation. They're not as uniformly inflamed as regular IMT. And these have delicate branching vesicles in most cases. So actually the most commonly suggested diagnosis was myxoid liposarcoma from referring pathologists. But the cytomorphology is different. So these look myofibroblastic. They can have spindle-shaped cells or stellate-shaped shells, and they don't look like myxoid liposarcoma. One last feature, a few of these tumors had these funny organoid aggregates of tumor cells. This tumor had a different PDGFRB fusion. So we think that this is sort of in the IMT family. It's related to IMT, but these behave significantly more aggressively. So we think it's worth sort of recognizing them for that reason, to potentially triage patients to treatment. Here's just a summary of the genetics of these tumors. I think I'm out of time. I'll just mention that one of the PDGFRA, the PDGFRA rearranged tumor in the series was treated with TKI therapy and responded quite well. So, okay, on that note, I will end. I'd be happy to take questions if there's time. Thank you.
I think unfortunately, for the sake of time, we're going to have David take questions at the break. I'm going to go ahead and introduce the next speaker as David comes back to his seat. The next speaker is Carina Dehner. Carina is both a dermatopathologist and a bone and soft tissue pathologist at Indiana University. Thank you very much for the kind introduction. Yeah, so let's get started. I'll be giving you an update on cutaneous mesenchymal tumors. And just a brief outline. So we'll first be talking about cutaneous fusion-driven neoplasms with melanocytic differentiation. So specifically those with CRTC1 TRIM11 fusion. Then there are two clear cell cutaneous tumors with actin MITF and MITF CREM fusions. And then very recently there was a fusion-driven tumor described that has a MET15 ATF1 fusion. Then we'll move on and talk about some of the superficial neurocrystic tumors with PHAT fusions. And lastly, I will touch on some, not all, but some of the superficial tumors with ALK fusions, some of the more novel or emerging entities. So let's get started. So first, the cutaneous fusion-driven neoplasms with melanocytic differentiation. And I think the probably more commonly known tumor in this category is the cutaneous tumor with CRTC1 TRIM11 fusion. It's relatively recently described, I believe in 2018, and by now there are about 50 cases reported. And the best study, if you are interested, I highly recommend the paper by Hannah and colleagues that have a large series, about 40 cases. So overall, there's no clear gender preference, a pretty wide age range, and a wide anatomic range. Morphologically, and I'll show you photographs, but they're usually most commonly purely dermal-based, nested proliferations of spindled and epithelioid cells. There have been some rare cases with focal epidermal involvement. And then generally speaking, melanin pigment is uncommon if absent, and tumor giant cells are also extremely uncommon. By immunohistochemistry, the best marker is really SOX10, so SOX10 has been strongly positive in all cases. And then S100, Melanase, HMB45, and MITF are more focally positive. Interestingly, some of the cases also have shown pan-TRAC expression, and this was mostly because by morphology, they have a somewhat spitzoid morphology, so pan-TRAC was done to exclude an NTRAC-fused spitzoid neoplasms, and interestingly, pan-TRAC was positive. However, by molecular testing, these do not have any NTRAC rearrangements. So if you do molecular testing, these will have CRTC1 exon 1 or 2, with TRIM11 exon 2 to 6 fusions. Now, these tumors are recently described, but have been around obviously for a longer time, so most likely these are cases that have been previously thought to be a dermal clear cell sarcoma or primary dermal melanoma or melanocytoma. Now, the initial studies suggested an indolent behavior, but to date, 6 of the 50 reported cases have shown adverse outcome with either local recurrence and/or regional or distant metastasis to lymph node and lungs. So let me just show you some photographs. You can see on the upper left, these are most commonly, as mentioned, dermal-based. You can see on the right that they're very monomorphous, very nested and spindled. And then you can see that the SOX10 is really the most helpful stain. It's strongly and diffusely positive, and the S100 is often more patchy. These are just some more low-power photographs of the study by Hannah and colleagues in HASP. You can see all of them are relatively well circumscribed and dermal-based proliferation. So the lower power impression can be very, very helpful for these tumors. Some more photographs you can see again on the left, very well circumscribed. And if you look at high power, this example had a little bit more epithelial morphology, but again, very monotonous. And then by immunohistochemistry, you can see SOX10 really strongly and diffusely positive. This example had a little bit more S100 expression. And then you can see how minimal the melanA and the HMB45 can be. That study also did a nice overview just to show you the classic immunohistochemical profile again, showing that the SOX10 is really the best marker for them. And these authors had also done a TRIM11 stain and to use it as a surrogate for the fusion, and it seems to be possibly a really good marker to test for the fusion or for this entity. As you can see, about 50% of cases showed pan-Trk expression. Now, as mentioned, not all of the cases are indolent. So this was a very recent case report in JCP, which showed a 75-year-old man. He presented with a two-month lesion on the toe that showed this ulcerating lesion. And if you look then further on resection specimen, you can see there, it almost looks like epidermal involvement. That's because the tumor was very proliferative and led to even superficial ulceration. If you look on the bottom picture, you can see this example shows a little bit more increased cellularity and definitely some cytologic atypia. And then in the resection specimen, you could see that some of the tumor was also involving the lymphovascular spaces. And then 18 months later, first the lymph node biopsy was performed, which showed the nested and spindled proliferation within the lymph node. And you can also see on the SOX10 stain that clearly this tumor metastasized to the lymph node. So generally speaking, possibly more indolent, but I think the more cases we're gathering, we're understanding that definitely a subset of them has a poor outcome. Moving on to the clear cell tumors with melanocytic differentiation, ACTA and MITF fusion. So far, there have been 9 cases reported, and these usually present as single cutaneous nodules with a preference for the distal extremities and trunk. There seems to be a really strong female predilection, with 8 cases being female so far. Median age has been about 40 years. And morphologically, they're usually solid sheets of large epithelioid cells with clear cytoplasm. Usually there's variably prominent nucleoli. And then what can be very helpful is this, what we call checkerboard pattern, where you can see that the clear cells are really intimately associated with these hydronized bundles of collagen. So most cases really lack cytologic atypia, mitotic activity, or necrosis. And by immunohistochemistry, they're variably positive for S100, HMB45, and melanA, but the MITF is really strongly and diffusely positive, which makes sense since these cases harbor an MITF fusion. Interestingly, SOX10 seems to be negative. Only 2 cases that have been reported have been tested, and then I'm aware of 2 more where also these also lacked SOX10 expression, so that can be another helpful clue. And then SMA, EMA, keratins are negative because cutaneous sarcoma would certainly be something that would come to mind as a differential diagnosis. Now, by molecular testing, they most commonly harbor this ACTG1 MITF fusion, or less commonly the ACTB MITF fusion. And so far, most cases seem to show an indolent behavior. However, there was this very recent case report which showed this clinically really more aggressively behaving lesion. I think it grew from 4 to 13 centimeters within only a half a year. And if you can see here on the right, morphologically, this is still a clear cell neoplasm, but certainly if we look at the outline on picture C, there's definitely some increased cytologic atypia and prominent nucleoli. This case was diffusely positive for MITF, and it did show some Desmond staining, which some of the prior reported cases also showed. It did have some HMB45 staining. And interestingly, this one lacked S100, which all the other previously reported cases showed some S100. So, one could consider, could this maybe be rather a malignant cutaneous pecoma? The authors pursued cathepsin K staining, which was negative, but I personally still think it is an interesting question, and I think it has to be still determined if these are truly unique tumors or if they represent a cutaneous variant of pecoma. And moving on to the next clear cell tumor with melanocytic differentiation, these harbor an MITF-CREM fusion, and there have been only 3 cases reported to date. Also all present as single cutaneous nodules with a possible preference for the scalp. We just have too few cases to really tell. 2 of the cases were in female patients. The third one was unknown. And the age range is also variable with just 3 cases, probably also too difficult to tell. Now, this one is called clear cell tumor, but it's important to say that the ones with MITF-CREM fusion usually are kind of variably, it's more of an admixture with focal clear cell areas and areas that are less clear cell morphology, as you can see on picture C, for example. Now, in contrast to the actin MITF-fused ones, these tend to show more atypical cytomorphology. They show frequent mitoses, and they show perineural invasion. By immunohistochemistry, they're usually positive for S100 and SOX and MITF, given the fusion, but HMB45 and MART1 or melan-A are usually or not frequently positive. All 3 cases to date harbored this MITF-CREM fusion. That's how it was defined, and the biologic potential remains unclear. There's just another example of this tumor. Let's see. And you can see here on the right, we see an example where there was some perineural invasion, and you can also see, hopefully, there's more cytologic atypia. Lastly, just to finish up with this category, there's a very recent series by Ko and colleagues in Modern Pathology that reported 3 cases of this cutaneous tumor with monocytic differentiation at MET15 ATF1 fusion. 3 cases reported to date. I actually saw this morning another one, so there are 4 cases reported. They're all single cutaneous nodules with a relatively broad site distribution. 2 female, 1 male patient. I think the 4th one wasn't disclosed, but all of them seem to present specifically in younger patients, like pediatric, 1st to 2nd decade. Morphologically, they're mostly dermal with occasionally focal junctional involvement. They're usually monomorphic, mildly enlarged, drawn to ovoid cells. They have a vaguely spitzoid morphology, so definitely something where you start wondering about, are we dealing with one of the more conventional melanocytic neoplasms? But these also tend to have more cytologic atypia. By immunohistochemistry, they're positive for SOX10, MITF. They can also show some S100 and pan-melanoma markers, but HMB45 and melan-A are usually negative or, if at all, very focal. PRAME has been negative in all cases. In all cases have harbored this MET15 ATF1 fusion. Now these, the biologic potential is unclear with only 4 cases. That being said, 2 of the 4 cases have shown progressive disease, so I think there's definitely a potential for a worse outcome. So here you can see this tumor here on the right. You can see there was even some, you can see even it was so cellular, densely cellular, that it even led to superficial erosion and ulceration, and really sheets of epithelioid tumor cells. So to distinguish them, I think they're more oftenly epithelioid, and that helps me to distinguish them from the CRTC1 TRIM11 tumors. On the right, you can see the immunohistochemical profile. you can see it's usually positive for MITF, SOX10, S100, and the pan-melanoma marker can be positive, but the melanA and HMB45 tend to be more negative. And the authors did suggest that the Ki67 can be a helpful marker if you're interested in doing it. Just a brief, if you're interested in learning more about them, I think Michal and colleagues, they wrote this really nice update on cutaneous mesenchymal tumors of the recent WHO classification, so you can find a lot more information about these in there. Moving on to the superficial neurocrystic tumors with FAT-ETS fusion. Here we have, it's a fairly recently described entity, and so far there have been a total of 11 cases. 6 patients were male and 5 were female with a broad age range, and all tumors so far involved the dermis or subcutis. Dermis or subcutis. Morphologically, they're bland, round to ovoid cells, usually with inapparent nucleoli. They often show these thick fibrous septa, and intratumoral hemorrhage has been a very helpful clue for many of the tumors. Now, importantly, some of the tumors show a predominantly round cell morphology, so this is very reminiscent of Ewing sarcoma, and in fact, some of the cases included in our most recent series were previously described as unusual variants of Ewing sarcoma. Now, why do I say unusual? The specific or the helpful clue for this entity, in addition to them being superficial, is really that there's usually strong and diffuse expression of both S100 and SOX. So this is the most important thing that I want you to keep in mind. They do show expression of some other more non-specific markers. So CD56, I know in the initial paper CD99 was infrequently positive, but then we did a follow-up study together with Andrew Fulp, which showed that CD99 sometimes can show strong diffuse and membranous staining. Also, interestingly, NKX 2.2, which is thought to be a relatively specific marker for Ewing's, does stain quite frequently these cases. Molecularly, it seems to be that any fusion between the FAT and ETS family members is possible. So EWS151 has been the most frequent fusion, but there are many, some of the other cases have shown FUS-ERG, EWS1-ERG, FUS-ETV5. So any of the members can be involved. And why is it important to distinguish from Ewing sarcoma? So far, the prognosis has been excellent. So all of the patients of the reported cases have been without evidence of disease at a median of 18 months. Let me just show you some of the morphologic features. You can see here on the upper left, these are often these multinodular neoplasm with thick fibrous septa separating the nodules. You can see that if you look at more intermediate power, they're usually nested and relatively monomorphous. What I find very helpful if you have that feature is really this kind of trabecular single file pattern. And sometimes they have a vaguely neuroendocrine look. And they definitely can have some mitotic activity, but it shouldn't be it should be usually, I think in our series, the median was like 4 in 10. And here on the right, you can see what Fulp and colleagues initially described as a triphasic pattern. We have the admixture of these small round to ovoid cells with admixed with fibroblastic cells and adipocytes, so this classic triphasic pattern that can be helpful if present, but is not present in all cases. Just to show you a case with a more predominantly round cell morphology and really prominent intratumoral hemorrhage, I found intratumoral hemorrhage was quite frequent in these tumors. As mentioned by immunohistochemistry, strong and diffuse co-expression of both S100 and SOX10, it's really diagnostic of this tumor. If you don't have both strong and diffuse, then it's probably not that. CD99, as mentioned, can be quite positive, as you can see here. And then CD56 has been positive in all tested cases, but as you know, it's a very non-specific marker. Now, we work with Daniel Baumhörer and added our cases to the previously reported cases, and as you can see here nicely by methylation profiling, you can see that the neurocrystic tumors are here, and they're forming a very tight cluster, and they're relatively far away. Now, we learned a lot about the distance, you can't definitively rely on the distance, but I think the point is that they're very distinct, forming a cluster, and Ewing sarcoma is too, and they're not together with each other. Interestingly enough, they're closer to neurofibroma. So all supportive of a probably distinct entity. Lastly, I want to talk about some of the superficial tumors with ALK fusion, some of the more novel or emerging entities. There's a very recent variant of hemangioma with epithelioid features. There have been 5 cases to date. 4 were in male patients and 1 in a female patient with a very young median age of 14 years. They've all been dermal tumors, and they involved the proximal extremities, the trunk, and the scalp. And morphologically, what's classic for those is all of the cases had an epidermal collarette, and usually show well-formed vascular channels formed by these epithelioid endothelial cells. You can see intracytoplastic vacuoles and admixed inflammatory cells. By immunohistochemistry, these are positive for CD31, ERG, and then what's important, they are also positive for cytoplasmic staining of ALK, and you can hopefully see this here on the bottom right. Let me just, sorry, I'm struggling. But molecularly, since they all stained for ALK, molecular testing was performed, and all of them harbored TPM3 or TPM4 ALK fusions. These all seem to behave very indolently, so they've all been without evidence of disease so far. And just to show you some pictures of our recent publication, which should be out shortly in HASP, and you can see again, very classic is this epidermal collarette. You can see that there's true vasoformation. You can often see these ectatic vessels at the edges, and then the ALK stain usually nicely highlights in a cytoplasmic pattern. And just to show you the TPM3 ALK fusion in this case. Lastly, I want to talk about some of the other ALK-rearranged superficial tumors. There's really Josephine Dermawan who described this superficial ALK-rearranged myxoid spindle cell neoplasms. These are usually predominantly dermal-based nodules on the truncal limbs with variably clinical presentation. And they usually show kind of a biphasic morphology with often myxoid zones of whorls of spindled neoplastic cells and other areas that show these more hypercellular areas of ovoid to epithelioid cells. You also can frequently see ectatic and hyalinized vessels. And then classically, they usually show co-expression of ALK, CD31, and frequently, but not always, S100. So if you perform molecular testing, all of her cases showed ALK fusions with HMB OX1, FLNA, and MYH10. And now if you think about all the superficial ALK-rearranged tumors in the skin, I think another tumor that really comes to mind that we all are probably more well aware of is epithelioid fibrous histiocytoma, which we know has been shown since 2015 has frequently ALK rearrangements. And so here you can confirm it by FISH. And so David Papke recently picked up on this and reported this really nice series of epithelioid fibrous histiocytoma, suggested that epithelioid fibrous histiocytoma may be on a continuum with these superficial ALK-rearranged myxoid spindle cell neoplasms. This especially was triggered by the fact that he had 2 cases which showed a more distinct hybrid morphology where you could see abrupt transition. This is tried to be shown here. Here you can see nicely a relatively abrupt transition. So but in total he reported 35 cases, out of which had to have SAM's morphology, and showed that 2 of these had these more obvious hybrid features. So all of the tested cases harbored either ALK fusions, FRET fusions, or NTRK fusions. And so he suggested that most likely these are really a continuum of tumors rather than 2 distinct entities. With that, I want to thank you for your attention, and I'm happy to take questions if there are any.
We maybe have time for one question.
Thank you for this very nice presentation. I would like to ask you that there is quite a mystic entity in the soft tissue pathology, this cutaneous epithelioid angiomatous nodule. And I don't know, what do you think? It might be this rearranged neoplasm, or because they show many similarities.
Yeah, I think I think that's a great question, and we definitely thought about the Keens, and I think it's a very controversial entity, in my opinion anyway. I don't truly fully know if it exists as a distinct entity. Those usually are more solidly cellular, so I think our cases were a little bit more vasoformative as those that were described as Keen originally, but yeah, I think overall the Keen entity has to be studied a little bit further. Let's leave it at that.
Thank you.
Okay, so thank you, Carina.
Phase. They are highly cellular tumors, very infiltrative into myometrium, and they could have very extensive lymphovascular invasions in terms of intravascular PHAT. This is an example of a tumor with JASF1 SUS12 fusion. In terms of a closer look at the morphology, we have a small uniform cells with a scant cytoplasm, oval nuclei, no cytological atypia. There's this classic whirling of tumor cells around spiral-like vasculature. Molecular has helped a lot with classification of these tumors, and you can recognize that some of these overlap with, for example, OFMT in somatic soft tissue. High-grade endometrial stromal sarcomas similarly are very cellular. They have primitive growth pattern. They have LVI. They could be spindled morphologically or be very epithelial. They usually have a compact collagen in the stroma. In terms of closer morphology, we have a spindle set in a variable collagen stroma, again, a scant to moderate cytoplasm. They could be very uniform with burst mitotic activity or necrosis, or they could look overtly pleomorphic and sarcomatous. The top ones in high-grade endometrial stromal sarcoma in terms of molecular are the ones with YAWA, NOTAM2A-B, and again, we have B cores in some of the counterparts in somatic soft tissue. The tumors that I selected to talk about today are kinase sarcomas. Briefly, since they're going to be covered by our next speaker, sarcomas with cancel-1 rearrangement, dicer-1 mutated sarcomas, PLAG1 rearranged sarcomas, including myxoid leiomyosarcomas, and recently reported tumors with S100 SOX10 positivity and HER2, HER3 mutations. Starting with kinase sarcomas, these happen in cervix and lower uterine segment. If you look at old archives and see the tumor being labeled in GYN tract as neurofibrosarcoma, they probably were dealing with these because by immunophenotype, they're positive for S100 and CD34. They're usually younger women, perimenopausal. Some of these can have aggressive behavior and give rise to distant metastasis. Morphology is being described as fibrosarcoma-like morphology because they're very cellular, they have very fascicular growth. Morphologically, they're very uniform spindle cells, scant cytoplasm, clump chromatin, and small nucleoli. The atypia is variable. Some of them can have very overt atypia, but it's usually mild to moderate. And one feature that's being emphasized is prevascular hyalinization in these tumors, as we can see in the lower figure on the slide. Broadly, they've been divided in GYN tract in 3 categories, ones with NTRK, RET, and ROS1 fusions. Interestingly, we haven't seen any cases of BRAF rearrangements. The chimeric protein leads into ligand-independent activation of kinase domain. They have CD34, S100, and CD30. Positivity, SOX10 is negative. And if you have access to PanTrek immunostain, they're positive for PanTrek. The second group are the group that are characterized by COL1A1 PDGF beta rearrangement, same rearrangement that we see in DFSP, in dermal, in cutaneous lesions of Dermatofibrosarcoma protuberans. PDGF beta receptor is a tyrosine kinase, and the chimeric protein acts as a ligand for the receptor. These are CD34 positive, but S100 negative, and if you have access to PDGF beta immunostain, they are positive for that. And the third category are the ones that don't have fusion. There are 2 reported cases with EGFR mutation. Again, CD34 positive, S100, and CD30 positive. They have bland cytomorphology, low cellularity, and characterized hyalinized vessels. Moving on to our second category, which are tumors with KAT6A and B cancel-1 sarcomas. They were originally described as leiomyomas or very cellular leiomyomas and cases of leiomyosarcoma. And after those reports, Agami and colleagues put a series of 13 tumors that morphologically they felt that fits within the spectrum of low-grade ESS, but had some atypical features, including well-defined borders, so they didn't have widely infiltrative. There were some exceptions, but broadly speaking, they had hybrid stromal and myeloid morphology. They also had hybrid stromal and myeloid phenotype. Some of them had, frankly, sarcomatous high-grade area, so not all of them were low-grade. And about 30% of them had unfavorable outcome despite bland cytomorphology and lack of widely invasive borders with mortality and recurrence rate of about 30%. The panels showed very well-defined borders as well as areas with more myeloid-looking leiomyosarcoma appearance. This is a live case that I had just to depict that not all of them have well-defined borders. Some could be very deeply infiltrative. The features that have been described in the literature, we don't have that many of these cases, but generally they have the whirling pattern of low-grade ESS around spiral vasculature. They also have leiomyoma-like large hyalinized vessels. Immunophenotypically, they're positive for ER, PR, CD10, and smooth muscle markers. I don't find these markers very reliable in classification. And a closer look, they have spindle to ovate tumor cells with non to mild atypia, very similar to low-grade ESS, even though we mentioned that some have high-grade morphology, either in presentation or as they progress to their recurrence. Those cases have undergone methylation analysis, and from the 13 cases, it's been shown that 8 of them had a very tight cluster, which was termed as a core group, and 5 of them were outliers. And on a closer look, the outliers showed high-grade histologic features. They either had significant nuclear atypia, increased mitotic activity, or necrosis, while the core group were mostly bland and well-defined tumors. On the outlier group, the prognosis was poor. 3 of 5 died of disease. In the core group, which were blander tumors, there were no deaths, and only 1 of them recurred. The conclusion was that these are unique tumors. Their cluster was separate from low-grade ESS and smooth muscle tumors. So the thought is that these are a separate category from both of those. And even though the morphology is bland, we have examples of high-grade, and even the bland ones could have aggressive behavior. So it's important to recognize these tumors. Our third topic is Dycer-1 sarcomas. This is a heterogeneous group with very confusing terminology. History of these tumors goes back to pleuropulmonary blastomas, especially in the familial form. The cases of pleuropulmonary blastoma were thought to have reproducible morphologic features as they progress from different subtypes of PPB, which was primitive non-committal sarcoma, either round cell or spindle, neuroectodermal elements, rhabdomyoblastic differentiation, cambium layer, focal or diffuse anaplasia, solid and cystic architecture, and chondroid or osteoid areas. Most of the progress that has been made in Dycer-1 tumors actually stems from the registry that was in collaboration with WashU, Minnesota Children's, and Children's in DC. So they followed these patients, realized that a lot of tumors occur in the familial and pedigree of these patients. In 2009, we realized that actually the culprit is Dycer-1 mutations. Dycer-1 locus is on chromosome 14. The role of Dycer-1 protein is RNase 3 endonuclease, which cleaves precursor microRNA. We could have germline inactivation of Dycer-1 with a second hit, or we could have a sporadic tumors with 2 somatic variants in hot spots. There's a whole host of tumors that could occur in Dycer-1 tumors. The ones that are important for this audience are the ones in brain, Dycer-1 associated sarcomas. In kidney, prototypical is anaplastic sarcoma of the kidney and embryonal rhabdomyosarcoma. In head and neck, nasal chondromesenchymal hamartoma and fibroblastoma. Peritoneum, we recently have reports of primitive sarcomas. And moving on to GYN tract, we have adenosarcomas, embryonal rhabdo, and what is in GYN tract is called PHAT. In GYN pathology and in GU, the term PHAT is still being used, even though in BSD we actually abandoned that term. In the ovary, prototypical is moderately to poorly differentiated sertoli-lytic cell tumor. You have a young patient, ovarian tumor, looks like sertoli-lytic tumor. Bedsard, this is a Dycer-1 tumor. Primitive ovarian sarcoma, you get the gist that the terminology is very heterogeneous in these tumors. And in fallopian tubes, embryonal rhabdomyosarcoma has been reported. We get to that point a little later. We have encountered 3 Dyser-1 sarcomas that had a unique morphology. They were characterized by diffuse round to spindle cell morphology and did not have other features reported in the literature for Dyser-1 sarcomas. One of them was located in the cervix. The other 2 were in uterine corpus. The patients were young, 37 and 59, with large-sized tumors, 8 centimeter, 10, 8.6. Morphologically, all tumors were characterized by a distinct diffuse spindle or round cell morphology. They all had various neuroectodermal differentiation, either had yolk sac tubules, blastomatous areas, or rosette formation, and did not have other features of Dyser-1 sarcomas. And all 3 were positive for SALL4 and had variable neuroendocrine marker expression. Showing the cases, this is the first case, a young patient. She had a large tumor in her lower uterine segment involving cervix and upper vagina. Morphology, it had a very interesting, it had 2 components. One was more tubular, with kind of a papillary architecture, almost glandular. It was a little deceiving for us, and very prominent basement membrane. It also had areas that were solid, tumors that had very scant cytoplasm. They had very brisk mitotic activity, tumor necrosis, Kerrixis debris in the background, very vesicular chromatin. And it had areas that we could recognize rosette formation. In terms of immunophenotype, both the glandular-looking area was positive for SALL4, as well as the more solid-looking area. We had expression of synaptophysin, and confusingly, there was also diffuse and block-like expression of P16, which made us chase HPV-related neuroendocrine tumor of the cervix. Second case was characterized by this solid and nested sheets of very uniform round cells that had a clear cytoplasm, very compact nests. It similarly had a lot of mitotic activity, karyorectic debris in the background, as well as areas that were more collagenous with benign glands kind of entrapped in between. In addition to SALL4 expression, this tumor also had desmin, myogenin, and myod1, so had rhabdomyoblastic phenotype or differentiation. Third case was characterized by diffuse rosette formation, shown more closely in the high power view. Other than rosette formation, this tumor also had areas that had prominent neurofibrillary stroma and areas that had more packeted growth. The morphology, the cytomorphology of the cells were very similar to other tumors. There was extensive necrosis in karyorectic debris. This tumor had SALL4 expression in addition to OLEC2 and synaptophysin. And since it looked neural, we also ran H3K27ME3, which wasn't entirely lost, but it was diminished. So this third case, we put for whole genome methylation analysis, and it came back as clustered with CNS embryonal tumors with multi-layered rosettes, which was very interesting for us, as Rossi and colleagues also reported 2 cases in a lumbar spine of a 22-year-old man and abdomen and pelvis of a 14-year-old girl that both were initially interpreted as sarcomas arising from teratoma, and methylation analysis put one of them close to CNS Dyser-1 associated sarcomas and the other one with ETMR. So one wonders if there are more of these neural-looking tumors in the GYN tract. So the follow-up, 2 patients were alive with no evidence of disease, but one of them had a large recurrence in the pelvis not long after the original presentation. Main differential for tumor in GYN tract with neuroectodermal differentiation is immature teratoma. which has neuroectodermal elements, or has sarcomatous overgrowth, or has rhabdomyosarcomatous overgrowth, or has low yolk sac appearing areas. We recommend searching for a benign component of the yolk sac and do further molecular workup in cases that appear in unusual locations outside of the GYN tract. Another differential would be if we're dealing with a Ewing sarcoma, I would recommend chasing that diagnosis if you have CD99 expression, membranous and diffuse. That was not our experience, and that's not what the literature says, but EWS-R1 rearrangement could help with that. Main differential, if it's a rhabdomyoblastic differentiation, would be embryonal rhabdomyosarcoma or adenosarcoma with or without sarcomatous overgrowth, and the diagnosis is mainly based on morphology and architecture. Before going to that, there is now a push to actually move away from calling this embryonal rhabdomyosarcomas of the GYN tract or cervix and call them Dicer-1 sarcomas with rhabdomyoblastic differentiation. So you may see that terminology in upcoming literature. Embryonal rhabdomyosarcoma, classically immature appearing as spindle cells, spindle to ovate cells sitting invariably in myxoid stroma. We could have areas of focal or diffuse anaplasia, as we see in the left-hand panel. We could have foci of cartilage. We could have cambium layer, which is condensation of the tumor cells underlying a benign epithelium. We did not have any of these features in our tumor. And adenosarcoma could be a more easier tumor to diagnosis. It has biphasic leaf-like architecture composed of spindelostroma and benign epithelial component. Moving on to plaque-rearranged uterine sarcomas. These were originally described in myxoid leiomyosarcomas. To give you a kind of a background, some of the criteria in GYN is very different from what we see in somatic soft tissue. Spindle or conventional is the one that most people are familiar with. Spindle or pleomorphic cells, long intersecting fascicle. They usually have very prominent nuclear pleomorphism. Criteria is 2 or more of the following: marked atypical tumor secondary sources and mitosis of 10, more than 10 in 10 high power fields. But in different subtypes, the criteria changes. In epithelioid leiomyosarcoma, morphology is round or polygonal. They have eosinophilic to clear cytoplasm, sheets, cords, or nests. And any of the following would put the tumor in the category of leiomyosarcoma. The count for mitosis drops from 10 to 4. And in the myxoid, which we're going to talk about, this is the rarest subtype of leiomyosarcoma. It's paucicellular. It has abundant myxoid matrix. The definition is 50%, but that's a loose definition. We require extensive sampling, and any of these would put the tumor in the leiomyosarcoma category, moderate to severe atypia. Mitosis drops to 1, and really infiltrative border is the main criteria. These have a poor outcome in prognosis. First reports were from Memorial. They were looking into a series of myxoid leiomyosarcomas, 15 tumors. They identified PLAG rearrangement in 4 of them with TRPS1 and RAD51B. No differences in morphology between fusion positive and fusion negative ones. And they found the plaque immunostain to be sensitive but not entirely specific, as it also stained fusion negative tumors. Another case report not long after was of a leiomyosarcoma that had some myxoid areas, as well as in panel B, very pleomorphic areas, areas of osteosarcomatous differentiation in panel C, and on G, liposarcomatous areas. This showed a novel fusion, TRIM13, with PLAG1. And then our friends in this institution reported 11 cases that had PLAG rearrangement but did not fit neatly in the category of myxoid leiomyosarcoma. Some of them lacked morphology, some of them lacked myogenic immunophenotype. 3 cases had myxoid leiomyosarcoma-like morphology. 5 of them were more epithelioid leiomyosarcoma-like. and 3 of them were nondescript sarcomas, prominently hyalinizostroma, adipocytic differentiation, osteosarcomatous differentiation, and frankly, undifferentiated pleomorphic sarcoma were the morphologies seen in this study. In terms of morphology, some of the reported features are depicted here. Myxoid background, areas of spindle fascicular growth, packeted growth, more of a collagenous background, and positivity with plaque immunostain. Some tumors had more of a epithelioid morphology, mimicking epithelioid leiomyosarcoma, and some of them were nondescript, as we discussed, more of a spindle sarcoma NOS. Some of them with fatty differentiation closely mimic myxoid leiomyosarcoma, myxoid liposarcoma with delicate vasculature, as well as in lower panel, seeing some osteosarcomatous differentiation. The fusion partners in plaque were all novel, with exception of 1 tumor that also reported TRPS1. And one wonders what to do with these results is that if we see these features, the differential could be very broad. These tumors had all aggressive behavior, and any uterine mesenchymal tumors that could potentially fall into this category of plaque 1 rearranged tumors probably should go under molecular analysis. It's important to know that some leiomyomas also have plaque 1 rearrangements. So it's important to look for worrisome features, mitotic activity, atypia, necrosis, and infiltrative borders. We should have a very low threshold for calling malignant in these tumors. And tumors that have adipocytic differentiation could be in the differential of lipoleiomyosarcomas, which are conventional leiomyosarcomas that have some adipocytic differentiation. Okay. Main differential, I'm running out of time, would be inflammatory myofibroblastic tumor because they have a myxoid background. Some of them can have a prominent cytological atypia, necrosis, and mitotic activity. And we now know that we could do ALK IHC in the ones that have ALK rearrangement. And B-core altered tumors that, these are usually high-grade sarcomas. They could have extensive myxoid areas. Majority are positive for B-core, and expressing smooth muscle tumors is not really a strong feature in them. So in last few seconds, I'm just going to touch on this HER2, HER3 mutated S100 and SOX10 positive uterine sarcomas. 2 of these have been reported so far in a 50-year-old and 45-year-old. Both tumors had high-grade morphology. They were spindle to ovoid. Both of them had very diffuse S100 and SOX10 with HER2 mutations as well as HER2 amplification, ATRX, and CDKN2A deletion. Morphologically, one of them had epithelioid morphology, high grade, while the other one mimicked fibrosarcoma more closely. Both of them were positive for SOX10, S100, and cyclin D, as well as diffuse membranous HER2. One of the cases that had follow-up did very poorly. The other one was very recent. And when the clustering analysis was performed, they clustered closely to MPNST-like tumors. The importance is therapeutic implications of HER2 inhibitors. To sum up, we now have a more sophisticated classification. We should have a lower threshold for molecular studies if we're dealing with an odd-looking leiomyoma, odd-looking leiomyosarcoma, and odd-looking ESS. Good idea to do molecular. We need to expand our IHC panel to include other markers and also the treatment options that patients can have. Thank you for your attention. I'd be happy to take questions if there's time.
Thank you, Nooshin. Unfortunately, I think we're going to have to just keep it moving here because we're running late on the session. But if anybody has questions for Dr. Dashti, you can ask her during the break. And last, who's coming from Indiana University, where she practices pediatric pathology.
Good morning, and many thanks for Dr. Michal's for having me here today. I recognize I am the only thing standing between all of you and probably a much needed bio break, so I will try to be on time. I know we're doing less well this morning than all of the speakers yesterday. So I'm going to talk on kinase fusion, either positive or altered tumors this morning. I do need to disclose that I serve as a consultant for Bayer Pharmaceuticals and Presage Biosciences. I like to ground my talks in a case, and I know for some of you that have seen me speak before, I've shared this case, and I also recognize that I saw this case now over a decade ago. But I think it's relevant for this discussion because we've learned so much over the last decade in this space. So this was a baby boy with a growing right foot mass. And this is a representative photomicrograph of this tumor. So you can see that there was kind of variable cellularity. Some areas were relatively hypocellular. Other areas were a little bit of increased cellularity. And this is deeply infiltrative, either in skeletal muscle off to the right-hand side or within fibroadipose tissue. Here you can see at higher magnification that this thing also kind of scares me. Ooh, that's fun. So deeply infiltrative, kind of ovoid to stellate cells within skeletal muscle here, or within fibroadipose tissue, in what we probably would describe as a lipofibromatosis-like pattern, or on the panel all the way on the right, pretty cellular. This was very low mitotic activity. And if you had this case, keeping in mind this was in 2011, we'd probably apply some immunohistochemistry, and I did. And this showed some patchy SMA. Beta-catenin was performed, and it was negative, and CD34 was performed, and that was negative. You probably nowadays wouldn't do a classic karyotype, but at the time we did, as was pretty typical for pediatric soft tissue tumors. And this showed a trisomy 8. And that's fairly nonspecific, but keeping in mind the differential diagnosis at the time, first and foremost, probably in a growing right foot mass in a pediatric tumor, be infantile fibrosarcoma. And we knew at the time that infantile fibrosarcoma has non-random chromosomal gains, usually in chromosomes 8, 11, 17, and 20. So this was nonspecific, but maybe could be supportive of infantile fibrosarcoma. If you were thinking about a fibromatosis, well, which type? Lipofibromatosis? Maybe, but this would be quite cellular for that. Doesn't really fit with the desmoid, and beta-catenin was negative. Again, going back to our differential diagnosis, at the time, what were your diagnostic tests available? So doing ETV6 FISH was performed, and that was negative. So really, we were in a bit of a quandary of what to diagnose this case. And so this was signed out descriptively as a spindle cell neoplasm with a differential including infantile fibrosarcoma, some sort of fibromatosis, or other that we didn't know yet about. Unfortunately for this patient, the tumor recurred a couple of years later in 2014. And this is what the morphology looked like at that time. So a little bit of increased cellularity, fascicles of tumor cells, and a little bit increased mitotic activity. So you can see a few mites now in this tumor. So a mite there. There was a couple mites up here, but still relatively low mitotic activity at about 5 and 10 high-powered fields. At this point in time, this was signed out as an unclassified spindle cell sarcoma and very much heavily favoring infantile fibrosarcoma. Per kind of standard protocols for the Children's Oncology Group, or the COG in the United States, this patient was treated with what's dubbed low-dose chemotherapy, if there is such a thing. So patient was treated with 2 cycles of ifosfamide, doxorubicin, and then followed by 2 cycles of ifosfamide alone. Unfortunately, the patient continued to have progression of disease and ultimately underwent a right foot amputation. So I think for us to know where we're headed in diagnostics and tumor classification, it behooves us to take a look at the past. So the history of infantile fibrosarcoma. So these tumors were first described in 1962 by Stout, although he didn't use the term infantile fibrosarcoma. In that paper, it was described as juvenile fibrosarcoma. And then the term was first coined in 1976 by Chung and Enzinger. And that paper by Chung and Enzinger described 52 cases. They only looked at pediatric cases. So of those cases, they were looking at tumors 5 and under, and they described the clinical features that we still know today. So about a quarter of those cases present congenitally or at birth. And then most of the cases really occur in early infancy, so 3 to 4 months of age. They typically occur in the extremities, but you can also see them truncal-based, rarely in the retroperitoneal, or even viscerally based. So if they occur in the viscera, say in the stomach, they can be confused with GIST. As Nooshin just talked about, we can see similar tumors in the cervix, et cetera. And pretty early on, they started describing these non-random chromosomal gains, which I just mentioned. And then both Brian Rubin, who we know from Cleveland Clinic in 1998, as well as Paul Sorensen in British Columbia, described the ETV6 NTRK3 gene rearrangement in 1998. And when we talk about pediatric patients, as David mentioned, I do both pediatrics and bone and soft tissue. And when we talk about the average size of these tumors, they tend to be about 5 centimeters. And in an adult, maybe that's not so big. In a pediatric patient, as we see here, that's gigantic. And so here is a clinical case that I had. So what do we see histomorphologically? And so I hope this talk, I'm going to focus a lot more on the practicalities of what we can see just under our microscope. And so by histomorphology, there's a few different patterns we can see. Most commonly, and I think what most people think about, are these uniform spindled to ovoid primitive cells and long fascicles. And for all the cases I'll show you today, these also come with the genetics that were described in this particular tumor. So here's a case of an NTRK1 rearranged tumor with a kind of a classic fascicular pattern. You can also see tumors that have haphazard arrangement or in long fascicles. Other patterns include, as demonstrated here, tumors with either myxoid, which in the early papers they talked about being ground substance. I don't think we write ground substance anymore in our reports, but I kind of like it. So either myxoid background or collagenized matrix. Often you can have chronic inflammatory infiltrate, which can overlap with inflammatory myofibroblastic tumor. You often have hemangiopericytoma-like vessels, previously referred to as pericytic-like vessels. Sometimes you can have a more round cell or ovoid morphology. And then some of the features that we talk about are deeply infiltrative. Here we have a deeply infiltrative tumor around skeletal muscle. And then sometimes you can have perivascular hyalinosis, as demonstrated here in a tumor with a canonical translocation ETV6 NTRK3. So going back to our case, unfortunately, moving on a couple more years, this patient developed widespread lung metastases, as seen here in the CT scan, and on morphology showed a very similar morphologic pattern with these fascicles of spindle cells. So keeping in mind what was going on in about 2016, this really began the era of targeted therapies. So while all of us were under our microscopes looking at the tumor morphology and being able to describe these tumors, in the clinics, we were also developing next generation sequencing for clinical exam, and our clinical oncologists were going into clinical trials with a variety of targeted therapeutics. So there were targeted therapeutics not only for NTRK tumors, but also for ALK, ROS, et cetera. And so in the United States, at least, we started not only having these phase 1-2 trials, but then going on to getting FDA approval for a variety of drugs. And corresponding to this, if you PubMed NTRK, this is just NTRK, this doesn't cover ROS or ALK, you see just this huge explosion, exponential curve, if you will, of literature in this space. At the same time this case was occurring, there was new developments, like I said, for next generation sequencing and antibodies. So in 2016, when I saw the metastasis of this case, we applied what at the time was a new antibody, and this is the pan-Trk staining. So we see this strong diffuse cytoplasmic staining for this case, indicative of a Trk fusion, and this case underwent, at the time, the only next generation sequencing available was DNA sequencing, and we detected a TPM3 NTRK1 fusion. And fortunately for this patient, they enrolled on one of those early clinical trials. So why does all of this matter, and what are the goals of the rest of my talk today? So like I said, this is going to be a more practical talk, hopefully to recognize the morphologic patterns that may be associated with kinase drivers. So I'm going to focus on the space of just infantile fibrosarcoma and what in the 5th edition of the WHO was dubbed NTRK rearranged spindle cell neoplasms, and now which we know covers actually a lot of different kinase drivers. Hopefully to utilize a pragmatic approach to ancillary testing, recognizing that not all of us can just sequence every tumor that we have, and understand which kinase drivers may have potential not only diagnostic but also therapeutic implications. So I think we need to ask ourselves, well, why do we name these tumors? And I think we spend a lot of time worrying about some of the nomenclature, and I think from a practical approach, our oncologists at this point in this space, they just want to know what the driver is so they can treat these patients appropriately. But our goal with our nomenclature is hopefully to inform and communicate to our clinicians on the current tumor. So in the case that I just showed you, if I were to say that's an infantile fibrosarcoma, that means something to our clinicians. They know from a practical standpoint what the prognosis is for that patient. And then if I tell them that has a TPM3 and TRAC1 rearrangement, that gives them a treatment strategy. We also provide nomenclatures to provide and classify biologically distinct entities, which is what a lot of the talks today have been about. And so I think that there's some good recent separations of our round cell sarcomas. And then something that I think we don't think about a lot as pathologists is to aid in the categorization for cancer registries for epidemiologic data that can help influence allocation of funding for the future. So over the course of the case that I just shared with you, we updated many WHOs, and the nomenclature for these tumors have changed, and we're actually moving on now into the 6th edition. And so with that, this category of kinase-driven spindle cell tumors has changed. And so in the space of the tumors I'm going to talk about today, this is current, at least at the beginning of the month when I put this talk together, but it may have changed because we keep identifying new fusions in this space. But at least as I would like to kind of lump these tumors together, kinase-altered spindle cell tumors includes both kind of an IFS subtype and then what historically was called NTRK rearranged spindle cell tumors. And I'm going to lump them under kinase-altered because it includes both fusions and some activating point mutations. And arguably, some people may throw tomatoes at me for saying this. It may include IMT and some other kinase-altered spindle cell tumors as well. We know that they share overlapping genes involved, and they share an overlapping prognosis, being that they're locally aggressive and infrequently metastatic. They share a wide age range. However, the infantile fibrosarcoma subtype more commonly occurs in infants, and they share similar locations of presentations. Here are the genetics. Like I said, they share overlapping genetics with many different kinases involved. Most of them are fusions, but not all of them are fusions. So we know that there are activating point mutations in BRAF down here that have been described. We also know that there are kinase domain duplications and internal tandem duplications in EGFR in the spectrum of tumors. And as soon as I made this figure, it became outdated, and I had to tack on this kind of tacky little FGFR1 alteration here. And so overlapping alterations. And the other thing to note is all of these alterations have potential therapeutic implications. And so here you can see the various targeted drug options that can potentially work against these mutations if you're able to identify them. So again, focusing on IFS and these kinase-altered spindle cell tumors. So I think throughout the talks in the last couple of days, we've asked ourselves, will methylation solve all our woes? Daniel says, yes, I think maybe. Other people say, maybe not. I think it's still, it's a tool, as we've said, and I think there's been several nice studies looking at these kinase-altered spindle cell tumors in nomenclature, and are these one entity, are they multiple entities? And this was a study from the lab here, from Michal, looking at least a few of these tumors, and here are the different fusions in his series of, I believe, 9 cases, and showing that there is at least somewhat of a cluster of these tumors with infantile fibrosarcoma and these NTRK rearranged or other alterations together. There was one case that clustered with IMT, but that case had a lot of chronic inflammation. So I think having chronic inflammation kind of skews where those tumors kind of end up. So the rest of the talk, I'm really going to focus on morphology, because I think one of the keys to this is recognizing the tumors that may have these kinase alterations to utilize resources wisely. And so there's several different patterns that show up in these kinase-altered spindle cell tumors, and they're recognizable once you've seen a lot of these cases. So one of the patterns is just the classic infantile fibrosarcoma-like pattern. And I recognize that I went from a new technique, which is methylation, to a black and white photo. And I kind of like that because the black and white photo holds true. So this is from Chung and Edzinger's original paper in 1976. And these are the common patterns we see in these kinase-driven spindle cell tumors. It can also be known as adult fibrosarcoma-like or malignant peripheral nerve sheath-like pattern. And these are the fascicles of spindle cells seen here, So either fascicles of primitive spindle cells, here it's more haphazardly arranged, and sometimes we just see hemangiopericytoma-like vessels. Here's, now we've moved into the pink and purple pictures, so more recent pictures of cases I've seen. Again, either haphazardly arranged primitive cells in a myxoid stroma, the BRAF point mutation tumor, maybe you would argue that's a more MPNST-like pattern with kind of alternating hypo and hypercellular areas. Here is an EGFR kinase domain duplication tumor that has those HPC-like vessels and scattered mitoses. I think the important part is to recognize the pitfalls. So what not to call this. So infantile fibrosarcoma, it can often be very cellular, it can be mitotically active, and it can have necrosis. And so one of the pitfalls is diagnosing this as a high-grade tumor. So I've seen many of these cases come to my consultation practice as high-grade spindle cell tumor. If you do that, particularly in a pediatric patient, you'll be treated like a high-grade tumor. But these, we know infantile fibrosarcoma is not a high-grade tumor. It's definitionally a low-grade or intermediate malignant potential tumor. So please don't overgrade these tumors. An adult fibrosarcoma is also in the differential, particularly in an older patient. Adult fibrosarcomas should have a null immunophenotype. So many of these tumors, and as I'll talk about in a minute, can show CD34 and S100, and adult fibrosarcomas do not. Adult fibrosarcomas also lack kinase alterations. And then, of course, as I've been talking about, these can mimic MPNSTs. It's important in the diagnosis of MPNST to look for either limited expression of S100 or SOX10. Also, the history of neurofibromatosis is useful. In this photomicrograph, this is actually a photomicrograph of MPNST with a background neurofibroma. Other things in the differential of the IFS-like pattern is, of course, IMT. And so here are a couple pictures of IMT. They're the classic form, or the more epithelioid pattern of IMT. Often IMTs arise in older children or adults. These are often viscerally based, and these can having the ALK cytoplasmic stain, or in the cases of epithelioid IMS, you can see the nice perinuclear staining with the RAN-BP2 fusion tumors. Other things in the differential of an IFS pattern is DFSP in the superficial cases, or as David mentioned, just maybe in the differential. So other patterns we see in these kinase-driven spindle cell tumors is a lipofibromatosis-like pattern. This is fibroblastic spindle cells which often traverse or infiltrate mature adipose tissue. Most commonly, this will be seen along the periphery of these tumors. This can be seen, however, alone, but more often this is in concert with other patterns. And so seen here in this tumor with a RAF1 fusion, most of this tumor had just a lipofibromatosis-like pattern. However, if you look carefully, there's actually these clusters of these more ovoid cells that are along these fibrous septae. Lipofibromatosis pattern, the differential diagnosis and pitfalls, of course, lipofibromatosis itself. However, in recent studies, mainly the paper by Alia Al-Ibrahimi suggests perhaps lipofibromatosis isn't a discrete entity, but rather a histologic pattern that can either be seen in these receptor tyrosine kinase tumors or as an earlier evolving calcifying aproneurotic fibroma, since the only recurrent genetics were FN1 gene rearrangements. Another thing that might be suggested in a lipofibromatosis-like pattern is a lipoblastoma, particularly in the mature or maturing lipoblastoma, where you see mostly mature fat, often in a lobulated pattern with fibrous septae. And then another pattern that we often see in these kinase-altered spindle cell tumors is something akin to fibrous hamartoma of infancy. So I go back to Karen's talk yesterday when I start seeing something that maybe makes me think of lipofibromatosis, maybe makes me think of FHI, maybe makes me think of infantile fibrosarcoma, then I automatically think this is probably a kinase-driven spindle cell tumor. And so here are a couple different examples that I've seen that you could argue are bi or triphasic tumors. So they have primitive ovoid or component plus a more mature collagenized component. So here we have the primitive component here. We have this more mature fibroblastic component. And then here I would argue this is just entrapped adipose tissue, not actually a component of the actual tumor, giving it a bi or triphasic appearance. And that makes me, again, think that this is probably a kinase-driven spindle cell tumor. If you see that, though, obviously something in the differential is FHI itself, so fibrous hamartoma of infancy. This classically has the triphasic organoid growth, which is at the bottom panel. That's the classic appearance of FHI. But something that we don't see in these kinase-driven spindle cell tumors is the pseudoangiomatous component of FHI. So that's the top panel. So sometimes that pseudoangiomatous component, if you see that in FHI, it's not going to be one of these kinase-driven spindle cell tumors. The other thing that can be helpful is some basic immunohistochemistry. So CD34 is positive in either that primitive component of FHI, so here in these primitive areas, or in the pseudoangiomatous component. And there's no S100. You also can use PanTrack and ALK. FHI will have EGFR exon 20 insertion and duplications, so again, genetically, these start to overlap. Other helpful morphologic features, I know in our discussion at the microscope yesterday, we started talking about rhabdomyoblastic differentiation. So a subset of these tumors actually can have heterologous elements. So I've seen cartilage in several of these tumors. Here's an example of a foci of cartilage in a BRAF-altered tumor, and then several of the EGFR ITD tumors have skeletal muscle differentiation, including bona fide rhabdomyoblastic differentiation seen here. Many of these tumors have hyalinized vessels, which is also a helpful feature. So that's a lot on the morphology. What about immunohistochemistry? So here's kind of the panel of stains that I think about for these tumors. So many of these kinase rearranged spindle cell tumors will be positive for CD34 or S100, but not all of them. And some will have some CD34, some S100. Of course, for the talk, I gave you my best staining CD34 and S100 because that's how it works. And then those tumors with NTRK will show PanTrack immunoexpression, and those tumors with ALK will show ALK expression. Again, there's a variety of other kinase drivers though, right? So RET, MET, et cetera. So these aren't always going to be positive. For PanTrack specifically, those tumors with NTRK 1 or 2 rearrangements will show strong diffuse cytoplasmic staining. Those with NTRK 3 gene rearrangements can be more difficult to detect by IHC. Again, I showed you a really nice staining tumor here with nice cytoplasmic and nuclear staining, but many of the NTRK 3s will show very weak nuclear staining. So this is a pitfall of missing it by IHC. Other testing, there's a variety of other molecular testing that can be useful depending on the resources of your laboratory. So historically, we used a lot of FISH, particularly for ETV6, to help in the diagnosis of infantile fibrosarcoma. About 70% of the classic infantile fibrosarcomas will have ETV6 and TRK3 rearrangements, but we know now that there's a variety of other alterations. This is an example here from one of my dear colleagues in pediatric hem-onc world that used NGS, but with copy number, being able to just demonstrate copy number variation in a MET fused tumor, and we still see gains that we used to be able to see by classic karyotype for 8, 11, 17, and 20, just by a different methodology. One of the things I like to point out, and Josephine pointed out yesterday, next generation sequencing isn't a one-size-fits-all. And so I think for sarcomas, we often rely on RNA sequencing. And yes, that will detect the fusions, but in this space, we also have ITDs and kinase domain duplications and activating point mutations. And so if you rely on RNA only, you will miss some of the drivers in this space. So for me, if I see one of these cases and I am suspicious of a kinase altered tumor, I actually do RNA and DNA. So in my last few minutes, I'm going to walk through a couple of, I hope, illustrative cases to hopefully demonstrate how I work up these cases and how we can still reliably use morphology in this space. So this is a 3-month-old male that had a rapidly growing shoulder mass surrounding the branchial plexus. And in my experience, a lot of these are often deep-seated. Yes, some are superficial, but a lot of these are deep-seated in spaces where operations would be very morbid. And so this was really inoperable without sacrifice of the plexus, which would be terrible for a 3-month-old. And so an incisional biopsy was performed, and this is a representative photomicrograph from that incision. So I think we can see here this is very infiltrative around individual skeletal muscle fibers. The gaping spaces we see here are actually very ectatic vascular spaces, so all of those spaces were lined with endothelial cells. And you can see kind of some variable cellularity. So some of these cells are very ovoid and primitive, and then some areas, I would argue to you, are a little bit more mature fibroblastic. And here are actually representative photos from different areas of this tumor. So for me, actually having intratumoral heterogeneity is actually really helpful in detecting these tumors. They look different in different areas of the tumor. So some of the tumor in the upper left-hand photo was very myxoid and hypocellular. Other areas right under that looked lipofibromatosis-like. And again, some of the areas looked maybe a little bit like fibrous hamartoma of infancy. Other areas were quite bland, as seen here, with kind of stellate cells infiltrating through fibroadipose tissue. The CD34 and S100 in this case were negative. And so yes, a subset of these show co-expression of CD34 and S100, but in this case, they were negative. So what to do? CD34, S100, I do usually use those stains, but in this case, they were negative. I performed Pan-Track and ALK because I was highly suspicious this was going to be a kinase-driven spindle cell tumor. They were negative. SMA had some focal nonspecific staining. I did perform myogenin, again, wanting to rule out maybe a spindle cell RMS, particularly in a young child, the infantile form of spindle cell rhabdo, and it was negative. So at this point, I made the diagnosis of spindle cell neoplasm favor kinase-driven spindle cell tumor / infantile fibrosarcoma, and I sent it for broad next-generation sequencing, including RNA and DNA sequencing. Unfortunately, I don't know what your experience is. For me, that takes about 3 weeks to get back. So in the meantime, I wanted to give our clinicians a pathway forward for treatment. This ultimately came back with a MAP4 RAF1 fusion. The patient was then treated with a MEK inhibitor to hopefully shrink the tumor before resection to spare the branchial plexus. So the photomicrographs I'm showing you here are actually post-treatment now, and so we can actually see some post-treatment effect. So after treatment with the MEK inhibitor, we can see increased fibrosis of the stroma and some decreased cellularity. The patient didn't tolerate the MEK inhibitor well, so they didn't do all the cycles they were planning, but were able to resect the tumor with sparing the branchial plexus with a subtotal resection. The patient is still doing well today. My second case that I wanted to share with you is a 10-year-old girl who had a kidney mass, they thought, or perhaps intra-abdominal mass, that underwent nephrectomy. The clinical impression was a Wilms tumor, because of the age and that they thought this was arising from the kidney. Obviously, as soon as we got the resection, this was not a Wilms tumor. This is not a triphasic mass. Instead, we see here on the left long fascicles of monotonous spindle cell tumors. Performed a few antibodies. This was diffusely positive for S100 and CD34, so co-expression this time of those two markers, and then diffusely positive for ALK. So in this case, I signed this case out as a cellular CMN. And the patient also underwent next-generation sequencing and showed an ALK CLIP1 fusion. The patient underwent just the surgical excision alone and is now several years out with no evidence of disease. My third case, and then we'll wrap it up, was a 7-month-old boy with a superficial to deep mass. So it extended from the dermis all the way to the deep soft tissues and actually wrapped around his sciatic nerve. And most of the tumor looked like panel A, but again, in panel B and C, you could say maybe that looks a little bit like fibrous hamartoma of infancy. I did not see this case at 7 months of age, but I actually first was introduced to this patient 20 years later, after the patient had underwent 2 cycles of chemotherapy, had stopped that second to intolerance and opted for an amputation, but had gross residual disease, and that gross residual disease was now growing and had metastases to his lungs 20 years later. Panels E and F was the disease I saw, as well as his original disease. I stained this for CD34 and S100, which showed focal staining, but mostly was negative. And I was highly suspicious based on the morphology that this was going to be a kinase-driven spindle cell tumor, and indeed had an FGFR1 gene fusion. This patient got compassionate release for an FGFR1 inhibitor, did not respond well, and unfortunately died of disease. So going back to our original case that was put on the NTRK inhibitor trial, this is his lungs during the trial. All of his metastatic disease cleared and is now still alive with no evidence of disease. I think there's a lot of future questions in this space. How do we predict prognosis? I've shown you several different cases that really had variable prognosis, and we're not good at predicting that. Will larger case studies looking at multiple variables, age, site, fusion, histology? I think from Michael's study, he looked at copy number variation. Are there secondary hits such as CDKN2A and B? Will those help us predict prognosis? What about treatment? We're starting to see neoadjuvant first-line therapy with these targeted therapies, but for how long? They're not without side effects. Should this patient that I'm demonstrating right now still stay on therapy? We don't know the answers to these questions yet. So in summary, IFS, kinase spindle cell tumors, have several different morphologic patterns. I think it's important to recognize these patterns so that you can distinguish this from other non-related entities. We have some IHC and molecular testing that can be helpful, and the identification of these kinase alterations can aid in the diagnosis and elucidate potential targeted therapy. Thank you so much.
So hello everyone, welcome to the next session. From now on we will move from these larger comprehensive review presentations into shorter 15-minute presentations on usually very narrow topics, so a little bit different change of format. The moderators now are Dr. Julie Fanburg-Smith from Virginia University and Dr. Hsuan-Ying Huang from Kaohsiung in Taiwan. Please.
Alrighty. So this is the advance. All right. I've got nothing to disclose, unfortunately. If anybody wants to help me work on that, I'd be open to that. Okay, so I'm at University of Kansas, which is in Kansas City, which I didn't know where that was before I moved. It is smack in the middle. And it's right on the border between Missouri and Kansas. And there's a Kansas City, Missouri, and a Kansas City, Kansas. And they're part of the same area, and they're separated by state line roads. So this picture is taken at the hospital on the Kansas side, looking across to the Missouri side. So we're centrally located. And when I was moving there, I thought there would be nothing there. But it's actually a lovely city of about 2.5 million people, and it has it has a lot of fountains. It's known as a fountain city, and also you can get barbecue in the gas station. But most recently, we are known for Taylor Swift, who's dating one of our football players, and this is a very big deal in my household because I have 3 daughters. So there's a lot of Taylor Swift. We listen to honestly nothing else. And I'm a big Swiftie. It's wonderful. So if any of you have heard of KU before, maybe it's because of Dr. Dominoff, who was I know not from
Czech Republic, but was from Europe and was spent his career at KU. And I am not going to pretend to be as cool, knowledgeable, smart, or anything as Dr. Dominoff, but I hope that this presentation will be slightly high yield in his, legacy. All right, so I'm just going to start with a very brief illustrative case. This is a 72-year-old male with a chest mass, and it stains not unexpectedly based on that morphology, and we'll get more into the morphology for SMA Desmond, but then also a lot of cytokeratin. And this case belonged to somebody much more experienced than I am, an international expert in bone and soft tissue, but eventually made its way to me. And this person had really sunk their teeth into this keratin, even though I think this happens in leiomyosarcomas, and got SS18 fish, and that was positive. And then this became a source of confusion in the case. But then a fusion panel was negative, as I would expect, based on that morphology. And what this illustrated to me is that we all look at cases differently. I'm not trying to denigrate this person's approach. I don't think I would have gone for the fish, but I think we learn about a lot of entities, but we don't necessarily learn how to look at them all the time. And so I just wanted to share the way I teach my residents how to look at these little spindly cells and what they mean to me. And maybe you look at things differently, and you can share that with me, and maybe this will be useful for how you teach your trainees. And so what we're going to do is we're going to talk about this, I don't know, histophenotype, whatever that is, but kind of what things look like, whether they actually are that or not, I don't know. And then try to integrate those very just kind of basic histologic findings with our immunohistochemical and our ancillary findings. And then I just realized as a side objective, I see all the time that people really struggle to stage things because they can't tell desmoplasia from smooth muscle. And I hope maybe at the end of this, you'll be more comfortable or able to explain to people maybe how to. So my very simple approach, and this is the last Taylor Swift. This is the last Taylor Swift picture, I promise, woefully, is where's the pink stuff, and what is it, and what's it doing? And so here's what I would say are the patterns of pink that we see in spindle cells. It's inside the cell, it's coming out of the cell, it's merging with the cytoplasm, or it's surrounding the cell. And, roughly, usually, that pink stuff is collagen. It's contractile proteins or something. Just remember, pink in pathology is protein. So it's got to be either a protein in the cell or it's a protein outside of the cell. Or it's a very long cell process that is basically a protein inside of the cell, but just kind of stretching out. And so that's where we go. So if it's inside the cell, for the most part, in a spindle cell neoplasm, right, it's going to be contractile proteins. And so that's a myoid phenotype, whether it's smooth muscle or whether it's skeletal muscle. Of course, it could be something else. In epithelial land, it could be mitochondria from oncocytic tumors, whatever. And if it's kind of outside the cell but merging with the cell, then it's probably collagen out there. But then maybe the cell is pulling on it because it's got some actin as well, and that's a myofibroblast. If it's just kind of sitting around the cell and it's all collagen out there, that's kind of like a fibroblast. It's not pulling on it anymore. And if it's a long process, maybe that's also kind of like a fibroblast or a Schwann cell or a perineurial cell. And so that's sort of what I think. And then you layer onto that the low power picture. Dr. Gross is going to talk a lot about that tomorrow. And then if there are any special features, maybe there's a special vascular pattern that means something or it doesn't. And then use your clinical and your radiology and your ancillary studies. But so what we're really going to talk about is where's the pink stuff? So if the morphology and the IHC don't fit, this is I think there's three things that could be. When things don't make sense, it usually is D. diff liposarcoma. Or it's something very esoteric, like you've heard a million examples of in the last day, and you'll continue to. Or it's an unusual presentation of a common tumor, and that's where you just need to be very careful, like in our intro case of a leiomyosarcoma that had an SS18 break apart just probably because of chromothripsis. That's a time to be careful about things not fitting. All right, so let's dive in. So we're going to have a lot of 40x pictures. So to me, there's a lot of pink stuff, and it is mostly outside of the cell, but, oh, how do I do this? Where do I point? How do I know where to point? You know, whatever. There's also a mouse, right? Oh, okay, whatever. I think that, oh, okay, whoa. Sorry. This is, you know, watching old people use technology is cute. But I think you can see that this pink stuff is kind of coming out of the cell and merging with this collagen in the background. And to me, that is a myofibroblast. At least that's that phenotype. And then we step out to lower power and see this sort of tissue culture-like appearance with some microcysts and extravasated RBCs. And you put all that together, and that's nodular fasciitis. So let's look at a different appearance. And in this, I would say again that we've got pink stuff that's outside of the cell. And it looks kind of like collagen, but it doesn't have that same relationship to the cells as the last one. It's more enveloping the cells. Maybe it's emanating as long processes, maybe it's enveloping them, maybe it's surrounding them. And so that's a sort of fibroblastic, whatever that means. We don't have EM, but that's sort of, you know, what we would call a fibroblastic appearance. And just for comparison, I would say that these have, although these are both collagen-rich tumors, these have a different appearance. One, this collagen is splitting, going around the cell, enveloping it, and one, it's emanating from it. The cells appear to be pulling on that matrix. And so, you know, I would say it's different. So we'll go back to our case, and we step out, and it's sort of patternless. Maybe there are some HP vessels, and put it all together, and that's a solitary fibrous tumor, which is sort of the poster child for a kind of a fibroblastic-ish tumor. Okay, let's look at this one. I think this looks a little different. I think that it appears that the pink is inside the cell, and that around the cells is actually kind of empty. So I don't think, unlike the other two, that this is a collagen-rich tumor. I would say that the pink stuff is inside the cells. And so that is sort of a myoid phenotype, probably either smooth muscle or skeletal muscle. And just to compare what I mean by inside and outside, if we have our last one, where our pink stuff is, is sort of outside of the cell, and this one, it's inside. I hope you are hallucinating successfully with me. I think that they look very different. And then, you know, we step back, and we've got intersecting fascicles of these eosinophilic cells that are containing their own eosinophilic material, and then there's clear atypia, and so this is a leiomyosarcoma, whether it has an SS18 break apart by fish or not. Okay, so let's move on, and let's look at this, and what, you know, kind of what's going on with this pink stuff. I would say that it is largely existing outside of the cell. It's maybe emanating from the cells. Maybe it is enveloping them. I mean, it appears to be collagen. And so that's sort of fibroblastic or maybe slightly neural appearing. And, you know, at lower power, it has this what I call butter on toast appearance, where it's just kind of like completely even. And that, you know, some of those cells, to step back, look a little bit inky. Some of them look a little bit different. You know, I think like, oops, I'm so incompetent at this pointer. I think some of them look cytologically different from others. And so this, to me, is a neurofibroma. Now, for comparison, we have this, where the pink stuff looks different. It doesn't, as opposed to the last tumors that we've seen, it doesn't really look like collagen. It looks more kind of fibrillary, maybe neurofibrillary. And I would say it doesn't look like collagen, but it looks like it's sort of surrounding all of these cells, and it has a neural phenotype. And then our little special features, it has these clumped hyalinized vessels with alternating cellularity, maybe even some Verricae bodies, lovely kind of disintegrating hyalinized vessels, and very classic schwannoma. But just to differentiate, because sometimes, I mean, honestly, for everything, all the fanciness, sometimes I torture myself over whether it's a neurofibroma or a schwannoma, and if that's in the retroperitoneum, unfortunately that matters, because if it's in the retroperitoneum, that's probably an NF1 diagnosis. And, you know, it can be hard, right? I mean, and sometimes the Antoni B areas of schwannomas do look a lot like neurofibromas, but I think if you remember that neurofibromas are collagen-rich tumors, and schwannomas are, Schwannian stroma, that can help a lot. You just pay attention to the pink. Okay, another kind of differential that can get difficult. So again, I would say that this looks like a collagen-rich tumor, and the collagen appears to be surrounding these cells, enveloping them, sort of this sort of fibroblastic appearance, and some more low power. It's infiltrating in the superficial dermis. There's areas that are storiform and have honeycomb infiltration of the fat, very classic DFSP. And the point here is to illustrate that this is a collagen-rich tumor. And let's contrast that to a tumor here. And the key to me to this tumor is to realize that this pink stuff is not the tumor's pink stuff. Unlike in the SFT or in our DFSP before, this pink stuff is this thick, higgly-piggly, as David Elder taught it, dermal collagen. I think it's very striking. I think that you can recognize dermal collagen anywhere you go. If you go to the store and it's sitting on the shelf, you would still recognize it as dermal collagen. But there are these little cells that are not particularly collagen-rich that are tripsing along through them. And so the pink stuff is not tumor collagen, it's dermal collagen, and it's not associated with these cells, and I don't really know what phenotype to give that. Some more pictures of it, this sort of trapping, and this is a classic dermatofibroma. And sometimes, the differential comes up of DFSP versus dermatofibroma. It's sort of this classic differential that people struggle with. And I don't think they look overly similar, because DFSPs are collagen-rich tumors, and DFs are not. Sometimes there are hard cases, but I don't think it is as hard as we make it. Okay, so I believe, I'm a very fast presenter. I think this is my last case. We've got this, and I don't know what's going on with this pink stuff. I think there's some that are inside the cell. I think there's some collagen around. I think there's some that look like it's merging. I think this is all over the place. I don't know what that is. And whenever things don't make sense, I have an idea of what this would be. I think that there's atypia out of proportion to the cellularity. There's atypia out of proportion to mitotic activity. There's no mites here. And then you see an immunostain for Desmond. And I don't think that this looks like a leiomyosarcoma. I just don't think it has the features. In spite of some Desmond, I don't think it looks like a rhabdomyosarcoma. And so I think when things don't make sense, it ends up being a D. diff liposarcoma 99% of the time. And I don't know, does that matter? I think we're starting to have targeted therapies for D. diff lipos. So this is always a good thing to remember. And I have more cases in like the extra, but I think we've done enough. So I hope I've convinced you that pink stuff is important. And did I lose? Oh, and I hope everybody's a big Taylor Swift fan now. Thank you all so much.
Now, this lecture is open for discussion. Any question from the floor?
Yeah, I just want to thank that we haven't heard of any gene. And even immunohistochemistry was just a few. Thank you.
Any other questions? If no,
All right, well, thank you all so much. And thank you, Michael, for putting this together. Honored to be here.
now I'm very honorable.
Thank you very much. And now for something very different. I'm going to draw together this morning's talk on heme path with bone and soft tissue pathology, particularly where dendritic or histocytic cells meet bone and soft tissue. And I want to thank Michal, Michael here, for this incredible program that he's put together. I feel very honored to be part of this program with this next generation of excellent colleagues and bone and soft tissue colleagues and participants. And I'm really thrilled to be in Pilsen because I've known his father, Michael, for many years. He used to come to the AFIP in the late 90s and early 2000s and do research with us, and he always talked about the lab, and so it's been really exciting to be here. So I'm going to talk about tenosynovial giant cell tumors, and I can't really talk about these without talking about some of the other giant cell-rich tumors, namely because these are, they have some overlapping recruited cellular milieu, and they also take each other's space occasionally. So although giant cell tumor of bone is usually in bone in the metaphysis and epiphysis and goes to the end of bone, it can occasionally be in soft tissue upon recurrence. And soft tissue giant cell tumor of soft parts, which is rearranged that we're familiar with, keratin positive, very distinctive cells. We know that these can also be in bone, particularly in the spine. And then tenosynovial giant cell tumor, which is usually in the joint or tendon or bursa, can also sometimes be in the big soft tissue away from the joint, or can sometimes be in bone, and I'll show you a case of that. And these have very distinctive, but possibly very unique cells that really define their molecular event. The stromal pre-osteoblastic or precursor osteoblastic cells, progenitor cells, in giant cell tumor of bone are G34W positive, and the keratin positive stromal fibroblastic cells are perhaps their reticulum cell, fibroblastic reticulum cells, are keratin positive in soft tissue giant cell tumor. And then in tenosynovial giant cell tumor, we know that these clusterin positive synovial cells or synovial sites are also D240 positive, and occasionally Desmond stains some of these. And so we think maybe these are also possibly a specialized fibroblastic reticulum cell that can be either Desmond or keratin positive. And so we're going to talk about each of these briefly, just because they share location and also cellular milieu. The cells of interest, of course, this will be discussed probably in other talks, of giant cell tumor of bone, the most interesting cell is the stromal cell, that precursor osteoblastic cell. But there's also a mononuclear macrophage cell that coalesces and forms the multinucleated osteoclast-like giant cell. These can be, as we see in the top right, have cytoplasmic vacuoles and have up to 50 to 100 nuclei in one cell. The distinctive cell is G34W positive, as mentioned, and this is the cell that is unhindered when the patient's treated with denosumab. And so this cell goes wild, and it starts, there's some regression, but there's also some bone formation in a very zonal pattern. It's the same cell that becomes part of the nodule of malignant giant cell tumor of bone when giant cell tumor of bone undergoes a primary malignancy. And this can either be in a non-ossifying UPS-like pattern or can have osteosarcoma-like features because it does make bone. Of interest, the G34W does not stain the osteoclast-type giant cells, which are innocent bystander cells that are treated by denosumab or gotten rid of by denosumab, but it does stain the multinucleated pleomorphic giant cells when this tumor becomes malignant, because this is the cell type that is undergoing malignant change, and that's really what's staining. All the cells are staining when it's malignant. Soft tissue giant cell tumor, just briefly, has the same cellular milieu. It attracts, we'll see in a second, all of the osteoclastic giant cells, Teuton-type giant cells, the xanthoma-like cells, and this is an eosinophilic cell that is keratin positive. It can occur in the bone, occasionally mostly in the spine. We've seen these multilobulated tumors. I can't mention giant cell-rich tumors without briefly discussing multifocal giant cell tumor bone with Paget disease and Avellino tumor that's distinctly from this area of Italy, nicely described by Fernanda and Adrian's group as having this very distinctive ZNF687 mutation in this family. And when we talk about both foam cells and osteoclastic giant cells, we can't forget about just briefly mentioning non-ossifying fibroma, which has a very distinctive location in the metaphysis with a geographic 1A margin, very sclerotic rim. It's eccentric. It has, this is a different pattern with a KRAS and FGFR1 mutation in greater than 80% of cases, the MAPK signaling. So tenosynovial giant cell tumor has been known for a while. In 1852, it was originally described in the finger as a nodular synovial lesion. In 1941, Jaffe recognized it as pigmented villonodular synovitis of the joint and noted that there was an inflammatory component. With Rosenberg and O'Connell in 1995, we did look at some histiocytic markers in these tumors, and I think this is now, we know, probably stains passenger histiocytes. 1997, Franco Bertoni created the first series of malignant pigmented villonodular synovitis, and then in 2006, it was noted that CSF1 is the fusion that can occur in these tumors, and then in 2008, we discussed some radiologic findings with extrinsic erosion of the bone in the joint lesions that are diffuse and the nodularity of the finger lesions. So localized or nodular type has a very, as mentioned, has a very nodular appearance. It's usually in the finger. These are very common. We see a couple of these a week. They're usually relatively small. They can have a cauliflower-like appearance when they're gross. They can occasionally occur in the knee in the top right, where they are nodular. If one does have a nodular lesion in the joint, however, if the person who's doing arthroscopy sees a nodular lesion in the joint, they should definitely sample it, because sometimes these turn out to be malignant tumors and not just a nodular tenosynovial giant cell tumor, because most of those in the knee are going to be diffuse. And then when these are taken out, they have a very well-circumscribed pattern. The cell of interest is the synoviocyte. I learned this morning when I was looking it up that this ladybug cell, or synoviocyte, which I guess resembles a ladybug, it has been described in cytology specimens by my own institution, my colleagues at University of Virginia. And these cells that are the tumor cells are few and far between, because we'll see in a moment they recruit a lot of other histiocytic and giant cell-rich types. And so we see that they are positive for clusterin, and they can be positive for desmin. And they do look a little bit stellate on the desmin. Not sure if those are the same cells, but probably they are. This is nicely described by Judith Beauvais and colleagues of the landscape effect that occurs in these tumors, where CSF1 positive tumor cells have an autocrine loop, and they recruit other inflammatory or histiocytic type cells, macrophages, in the paracrine loop. There's many different cell types in here. There's going to be small histiocytes, foamy macrophages, siderophages, osteoclast-like giant cells, Teuton-like giant cells, etc. The fibroblasts will make the variably hyalinized background. Of note, when I was preparing for this, I noticed there's a lot of emperipleuesis or phagocytosis going on of these giant cells, and mostly the Teuton type are doing that kind of pattern. So we can see here that the ladybug cell, so to speak, or synoviocyte, can sometimes have hemosiderin around the periphery of it within the cell. These are the xanthoma cells. And there's a fibrosis that occurs in the background. Here's more xanthoma cells. The diffuse type is generally going to be found in the knee most commonly, and then secondarily in the hip of the more proximal large joints. These can cause pain and stiffness and fluid accumulation with the decreased range of motion. They're very painful. They can come on abruptly for the patient. dark on T2, large, and basically we see a lot of hemorrhage in these. Occasionally we can see a diffuse tenosynovial giant cell tumor in the finger, but it's not very common. It's more common to see a nodular type. Diffuse tenosynovial giant cell tumor has a very villonodular appearance, like the original name of PVNS, which we don't use that terminology anymore. It's important in these to recognize the proliferation of tumor cells because the hemosiderin that's present in the joint can also be found in hemosiderotic knees as well. And here are the very characteristic cells we'll see in both the nodular and diffuse type. But what's very specific to the extra-articular diffuse tenosynovial giant cell tumors is kind of a discohesion of the cells. And what's very worrisome, and we get many cases submitted to the ISS over the years that look like malignancies, is these very rhabdoid or epithelioid cells that look very concerning for a more worrisome tumor. Of course, there's no mitotic, or there can be mitoses in these, but it doesn't have atypical mitoses, and these are benign. And basically, these are all CSF1 mutated, we'll talk about in a second. So this is an interesting case that we saw that with the radiologist swore up and down this was a giant cell tumor of bone. It was entirely intraosseous. It turned out to be a tenosynovial giant cell tumor with very distinctive areas of, on the gross, we can see in microscopic of these xanthoma-like areas. But this process was negative for H3F3A, and the diagnosis was confirmed. This basically turned out the patient had had some surgery prior in which they had repair, and so that's probably how a tenosynovial giant cell tumor got into the bone. Malignant tenosynovial giant cell tumor can either occur de novo or after multiple recurrences. And these are all the papers, several of the papers that are written on malignant tenosynovial giant cell tumor or tumors that metastasize of tenosynovial giant cell tumor. We think the ones that metastasize are malignant. And basically, the first paper was by Franco Bertoni, and I've gotten to speak with him prior to his demise over the years about this entity. We have our series that we're working on with Michal and John Gross and several others of a large series of malignant tenosynovial giant cell tumors. And they have also, in addition to the CSF1 mutation, they harbor some additional mutations we'll talk about in a second. These are typically large. The tumor cell will take over, so there will not be the background of inflammatory or admixed cell types. Just mostly the synovial cell is the malignant cell, and they often have atypical mitoses. They can have complex CSF1 and additional acquired molecular genetic findings. The morphologic features based on those that metastasize, we went back and applied these features to other tumors to make to look for criteria for malignancy. Included, all of them had decrease or absence of giant cells, osteoclast-like or teuton, and or xanthoma cells. There was tumor cell discohesion in all of them. They all had atypical mitoses. So many of these features are very highly reproducible in malignant tenosynovial giant cell tumor. They often have an area that looks more banal in some others we don't see this component any longer. These are just a couple examples that metastasize. We know these are malignant. They all had atypical mitoses. Here's another example. It has clusterin positive. It's much more common in this tumor than it is in the benign tumors, which is few and far between for the tumor cells, whereas this is malignant, so it's more prevalent. D240 can be positive. CSF1 has also been positive in these. I'm going to talk briefly about CSF1 and treatment. So all of these tumors have, well, many of them have involvement of colony-stimulating factor 1, which is the ligand of CSF1R. In benign, it's only in a small percentage of the cells. The most common fusion partner is collagen type 4 alpha 3, or ColCA3, 6A3, located on chromosome 2, resulting in a 1-2 fusion in a subset of patients. Also, there are novel fusions now for deletion of CSF1 in exon 9, and this is a negative regulator of CSF1 expression with truncation of the 3' area, leading to overexpression of the CSF1 immunostain. concurrently or sometimes separately, about a third of these cases have now been found to have Cas-BR murine ectotropic retroviral transforming sequence, or CBL mutations. And these can be associated with receptor tyrosine kinase as a driver event. And of course, all of these can be targeted. As we know, CSF1 is also targeted. We'll talk about that in a second as well. And I mentioned that malignant tenosynovial giant cell tumors have additional overexpression of several gene types, including they can have some tumor suppressor gene downregulation of TP53. So how do we identify CSF1? It can be identified by immunostain or FISH, most commonly CISH, by a nice paper by the Mayo group. CISH does, however, show CSF1 in normal synovium, but also shows positivity in localized and diffuse tenosynovial giant cell tumor, as well as in malignant tenosynovial giant cell tumor. Although malignant tenosynovial giant cell tumor has demonstrated rank L by immunohistochemistry, and there's been variable success with denosumab treatment, leading to eventual non-success in patients, the best treatment of choice is the CSF1R inhibitors. My new sarcoma oncologist, who's amazing, they're all very excited, and all of the other oncologists I've worked with and orthopedic oncologists have been really excited about these inhibitors. They've all been using pexidartinib, which has been the hot new approved inhibitor. But unfortunately, it causes liver toxicity, and many of the patients have to go on a clinical risk evaluation mitigation strategy for liver disease. And what's very exciting is next month, in March, there hopefully will be approved this vinceltinib, which does not have liver toxicity, and this is targetable for the CSF1. Thank you very much.
Thank you for your very gorgeous presentation. Now this lecture is open for question. Any question from the floor? May I ask one question? Besides atypical pathosis, do you think the architectural changes will help identify malignancy in TSCCT?
Architectural change?
Yes,
Yeah,
or mesofibrous.
Yeah, they typically are diffuse, and they have this discohesion of the cells, and they have the loss of the other cell type, so it's mostly an overgrowth of the synovial cell, which I did say in the beginning of the talk that I think might be a fibroblastic reticulum cell variant, but basically these are, yes, I think that's basically what's happening in the tumors, is it does have a very diffuse pattern typically. It doesn't have the spindling like we see in other malignant transformations, but it does have epithelioid cells that are the tumor cell, and it takes over, and there's a paucity of giant cells and xanthoma type cells.
Thank you.
Thank you. It's my pleasure to introduce the next speaker, Dr. David Suster, and here you go, David.
All right, good morning, everybody. I'm back. We're going to move through this quick. It should be a very fun lecture because it's a controversial subject. So I hope we're not too sort of gene exhausted at this point, because we're going to find a few more here. So this is an update on some rare pleomorphic superficial soft tissue tumors. And these are the entities that we're going to cover today. So we're going to go over superficial CD34 positive fibroblastic tumor, myxoinflammatory fibroblastic sarcoma, and pleomorphic hyalinizing angioectatic tumor, plus some related tumors. I'm going to try to say out the names of the tumors because it turns into a sort of alphabet soup if I use only the abbreviations, so bear with me. All right, so starting with superficial CD34 positive fibroblastic tumor. So this was described about 10 years ago by Dr. Fulp. And this is a mesenchymal tumor that's primarily located in the skin and subcutaneous. As the name implies, it's superficial and CD34 positive. It's considered a tumor of borderline malignancy, so locally aggressive behavior, but only very, very rarely metastasizing. And it's characterized histologically by marked nuclear pleomorphism, low mitotic counts, and what helps me identify them the most is probably this sort of glassy characteristic of the cytoplasm of the cells. So this is a prototypical example. You see this sort of fibroblastic tumor, very irregular pattern, maybe short fascicles. You can make out from even this power that there's that sort of glassy cytoplasm in some of these cells. Looks like these kind of eosinophilic globules, like this thin right here. And you can also make out the pleomorphic cells from this power. This is slightly higher power magnification. Again, just showing that sort of glassy cytoplasm and the degree of pleomorphism in these cells. So they can be spindle, they can be epithelioid. It has a little bit of variable histology. This is a morphologic spectrum that's sort of been described thus far. One of the other characteristic features is that you can have sort of lipidized cells or vacuolated cells. It could be either macrovacuolated, as in the top left image, or they can be microvacuolated. They almost look like foamy histiocytes. Again, in the middle panel, you can see the degree of pleomorphism. Sometimes you have macronuclei and multinucleated giant cells. You can have spindled areas, and you can get this sort of hemangioparasitic vascular pattern, reminiscent of solitary fibrous tumor. Not pictured here are tumors that have been described, with atypical fibrous histiocytoma-like, sort of features, and other tumors that have very prominent granular cytoplasm. So this tumor went through this sort of interesting evolution over the last 10 years. Following this, I know this is complicated, but follow the marker. So, following this tumor where you had these suprafascial pleomorphic tumors with CD34 positivity was described, Dr. Mertens and his group had sort of two subsequent publications in the next 2 years. The first one was this paper on these recurrent PRDM10 fusions in UPS, or undifferentiated pleomorphic sarcoma. But interestingly enough, what they noted at the time was that the PRDM10 rearranged tumors behaved in a much more indolent fashion than the high-grade UPS. So a little bit unusual. And then a few years later, they published this series shown on the right side over here of these PRDM10 rearranged soft tissue tumors. And the histology in that paper had features that overlapped with superficial CD34 positive fibroblastic tumor. So a few more years of people sort of recognizing these entities and kind of comparing all of them led to multiple studies, as you can see here along the bottom, including by Dr. Perret, Dr. Anderson, and Dr. Pools, who basically, sort of noticed that these tumors were likely the same entity or related entities. PRDM10 fusions were found in the superficial CD34 positive fibroblastic tumors as well. So this is something that probably is going to be reclassified in the future, and are either the same entity or on the spectrum of the same entity. So the take home from this is, like, remember that glassy cytoplasm, superficial location, and the pleomorphic cells. That's like how you pick these out. But there's a broad differential for them. So moving along, where it gets a little bit more complicated is the other two tumors that I was asked to cover in this update. So this includes MIFS and PHAT, which is myxoinflammatory fibroblastic sarcoma and pleomorphic hyalinizing angiotatic tumor. So we're gonna go over all of these, and we can't really go through these without also including a third tumor called hemocytotic fibrolipomatous tumor, which is a tumor that was actually described by Dr. Fanburg-Smith, who's here with us today. So we'll start on the left side with MIFS. This is a low-grade soft tissue sarcoma that's mainly limited to superficial distal extremities, and it's usually young to middle-aged patients. So it's more like the 30 to 50 range instead of like a UPS where you expect it to be in an older patient. And it's characterized by varying proportions of inflammatory cells, myxoid stroma, and large atypical and spindled and epithelioid cells. True incidence for this tumor is unknown. They're very, very rare. There's somewhere around 500 cases reported in the literature, but they're probably under-recognized and often misclassified and just signed out descriptively, especially in the past. The etiology is unknown for these tumors, and the patients often present with a painless mass that has enlarged over the course of several months. And this tumor, you can see down here, was described by 3 separate groups, all in the same year within like 3 months of each other. And if you look at the last citation, there was actually Michael's father, Professor Michal, who, as a single author publication, recognized this entity and published it. So, it had multiple different names, but eventually settled on myxoinflammatory fibroblastic sarcoma. Now, pleomorphic hyalinizing angiectatic tumor, is a tumor that may or may not be related. There's some controversy there, but this is defined as a rare low-grade soft tissue tumor, most commonly involving the distal lower extremities. And it's characterized by these ectatic fibrin-filled blood vessels with a cellular pleomorphic cell population, and you also can get hemosiderin-laden cells admixed in there. HFLT, or hemosiderotic fibrolipomatous tumor, is a rare low-grade superficial soft tissue tumor. You're starting to see the theme here, usually involving the distal lower extremities, most often the foot, and all the ones I've seen have always been on the dorsum of the foot, so a weird sort of a location to target, but this is a lipomatous tumor with infiltrative, occasional pleomorphic spindle cell population and a lot of hemosiderin deposition. So areas of HFLT have been observed in relationship with tumors classified as MIFS and with tumors classified as PHAT. Dr. Fulp sometimes refers to the HFLT-like areas around the periphery of PHAT as early PHAT. I hope that made sense. All right, so this is just a couple of prototypical examples. So this was a finger mass in a 48-year-old female. And you can see there's a relatively well-circumscribed suprafascial tumor directly under the skin. The right side of it is a little bit more fibroblastic. The left side has the biopsy tract, but also more myxoid changes. And on scanning magnification, you can see it's a subcutaneous tumor, and it has this kind of lobulated appearance to it. It's infiltrative at the edges, at the right, at the left, at the lower part of the tumor. Myxoid stroma, fibrous stroma, and when you go and you look up on these things on higher power, there's a mixed inflammatory infiltrate, as you can see in the top right, and then these really prominent sort of macronucleated cells, and those cells are the things that are often referred to as Reed-Sternberg cells. Sometimes in the literature it's been referred to as a Hodgkin-like sarcoma, but these can be a little confusing when you start seeing them. And it's also important to note that those cells are not specific to this tumor type. You can see them in other types of tumors, particularly various high-grade sarcomas. You'll occasionally run into macronuclei and a weird Reed-Sternberg-like cell. So you have to have the appropriate clinicopathologic sort of situation for it. Other features that have been described are in peripolesis, and in the bottom right panel, these sort of pseudo-lipoblastic cells, where in the myxoid areas, they uptake that myxoid stroma and they get all bubbly. Sometimes confused for liposarcomas, but usually people can pick them out. Now, HFLT and PHAT, this is an example of that. This was a resection specimen. It's a skin excision with a little bit of the subcutaneous fat. You can see there's this sort of like brownish, reddish nodule in there. And this was from the dorsum of the foot, in a 32-year-old female. And the microscopy is that of a sort of fibroblastic spindle cell neoplasm with pleomorphic cells. And on the bottom left panel, you can see that there's all these ectatic vessels, and these tumors are classically positive for CD34. And this particular tumor also had areas that looked like a hemosiderotic fibrolipomatous tumor. So that's shown on the bottom right. Now, where this gets very complicated is once you start looking into the molecular genetics of everything that's been published. There's been quite a bit of work done on this. Many of the authors on a lot of these papers are sitting in the crowd right now. So hopefully I get some of this stuff correct. All right, so the molecular in MIFS. It's basically characterized, at least in the early studies, by this T110 translocation. And that is a fusion that occurs between TGF-BR3 and MGA5, or now known as OGA, and also includes FGF8 and MPM3. So there's usually upregulation of those genes. BRAF rearrangements have been described in these tumors, as well as, and this is probably the most common alteration, to be quite honest, is amplification of the 3P11.1 region, which contains VGLL3 and CHMP2, okay? Now, interestingly enough, in HFLT and FAT, that same exact translocation was described. The T110, approximately 70 to 80%, depending on how many cases or how many papers you look at, And that amplification of VGLL3 has also been described in those tumors. So in the early studies, it was postulated that there was, an overlap or a link between MIFS and HFLT and FAT, and they may all represent the same entities, which may still be true. It's not entirely clear at this point. However, some of the subsequent studies have, sort of called that relationship into question. So Dr. Fulp in 2015 had a study where he looked at 31 cases of MIFS, and he did the OGA gene rearrangement by FISH and found that it was positive in only 2 out of 31 cases. And he stated, you can see it down here on the bottom left over here, he stated that the sarcomatous components, in MIFS, or excuse me, in these HFLT slash MIFS tumors that look like they're related, have this subtle difference where they slightly are, he thought they were different than classical MIFS or pure MIFS. So he raised the possibility that these lesions may be different, particularly because he wasn't finding T110 in these classical MIFS tumors. He was, they were really only being found in the HFLT slash MIFS tumors. We had a study on this too where we basically corroborated those results. We looked at 55 of those cases. We found that T110 in only 3 out of 54 cases of pure MIFS or classical MIFS, very low rate. We looked at 70 cases with BRAF FISH, and we only found BRAF alterations in 4 of them, which is well below the level that has been reported up until that point. And we found the VGLL3 in about 40%. So that might be one of the most diagnostically helpful things. But all of this data raises, the question, are these entities separate or are they related? There's still some things that look like classic MIFS coming out of HFLT that have the T110. So it can be very hard to differentiate all that stuff. And this is kind of a short, sneak preview, but hopefully we will finish this paper one day. Dr. Gross and I have sort of put together cases of sarcomas that have HFLT fat-like areas. They may be true HFLT fats evolving into MIFS, or they could just be, areas that have HFLT and fat, at the periphery of the sarcoma. So these are some of the figures from that study that's going to, I promise it will come out eventually. But on the left panel, there's multiple different images. It just shows HFLT-like areas where you have, it's a little bit hard to see on the projection here, but this sort of spindle cell population with hemosiderin deposition, often infiltrating fat. And on the right side, you see more of these tumors that have, areas that look like pleomorphic hyalinizing angiectatic tumor with these dilated blood vessels. There's often sort of like fibrinoid necrosis or hyalinization around the blood vessels. And in these tumors, we have over 40 cases of this now. So in these tumors, what you see is that the majority of them are actually myxoid sarcomas that are arising with these areas of HFLT and fat. So is it possible that in early studies, some of these were being mixed up and misclassified? We think yes. Some of these tumors that we've seen have heterologous elements or other alternative, sort of histology, such as osteosarcoma, UPS-like histology, or even sort of a plasmacytoid or epithelioid morphology. So we'll see what happens with these. We're putting together, the manuscript and sort of struggling through it. So trying to piece all this together, if I haven't confused everyone here already, I try to make a diagram, and then the diagram itself was, extremely confusing. So you have MIFS. It seems like they're mostly T110 negative. You have FAT and HFLT, probably related, usually T110 positive. You have myxoid or MIFS-like sarcomas and other sarcoma subtypes with HFLT and fat-like areas. And you have HFLT/fat, like true ones with the T110, that progress to myxoid sarcomas or other things, and those are often called hybrid HFLT MIFS. In the last few seconds, I want to show this. This was a case that came in. It was sent as MIFS, but we tested it for T110 and it was negative, and then it came back with a PRDM10 fusion. So just to tie it back to the beginning of the talk, there's a little bit of overlap there. So these tumors can get sort of confusing, but note that glassy cytoplasm. And then last couple things, this gets complicated by the fact that there's other subtypes of MIFS that have been described. Dr. Perret described these nodular necrotizing MIFS, and Dr. Michal also described a variant of high-grade MIFS, where high-grade histology, necrosis, high mitotic activity. So the picture becomes even more complicated, and then at that point, you're just in trouble. So I'll wrap up. These are the highlights. And as a summary slide during questions, if there's time, there'll be this little chart for your own edification. Thanks.
Thank you very much. Is there a quick question for Dr. Suster? Dr. Suster, I have this is a great review. I think the MIFSs that we've seen have been 110 positive.
You've seen like pure MIFS with T110s?
They're probably hybrid. You're probably right. They're probably the hybrid ones. But I think what's important is the MIFS probably has worse behavior than the other two other entities. They're kind of more borderline, and that's really almost like a low-grade malignant, even though it doesn't really have mitotic activity. So it behaves more aggressively. So I think there's probably such a big variety of morphologies of MIFS that maybe some of that has fat-like features. And I think some people are calling them, like you said, they're calling them MIFS if it really does have some of those Myxoid features. So,
yeah, I totally agree. And I think it's one of those things where the best way to approach it might be to get like a working group together with a bunch of experts and have them review a lot of cases and sort of decide what's actually going on. Thank you.
Hey, Dave, great talk.
Yeah.
So, given the presence of often overlapping morphologies in some of the tumors, when people talk about the actual frequencies of all those molecular alterations, the different entities, how do you define what is ground truth, when there's so much subjectivity in terms of how we classify and diagnose these tumors?
Yeah, I think it's extremely difficult to do that and to know what the ground truth actually is. I think possibly some future prospective studies, maybe even if these things are amenable to methylation studies, might help sort of stratify these. But I think in the early literature, there is a lot of things that were included that were not what the authors actually thought they were. But there's no way to know whether that's true or not. If we could get all the authors of all the papers to sit down and pull all those cases and put them in one spot and then re-review every single case, that would be the best way to find the ground truth. But I don't think that'll ever happen.
Thank you very much. Excellent. Our next speaker, I'm pleased to present, is Dr. Hsuan-Ying Huang, and he is a professor and director of anatomic pathology at Hospital. Thank you.
I'm very thankful to Dr. Michael, my heart, and his gorgeous meeting coordinators for inviting me to share the podium with so many world-famous experts on bone and soft tissue. It's truly my pleasure and a privilege. Today, my talks will be focused on the updates of genetic and morphological variants of extraskeletal mesoid chondrosarcoma, followed by another fusion-driven mesenchymal neoplasm, DFSP, in the next lecture. Now let's look at these particular tumors arising from the right arm of a 70-year-old female. At a low magnification, this tumor comprises multiple nodules of variable sizes set in a fibrotic stroma. On high power, the tumor was predominantly composed of slender spindle cells in compact bundles on the left, but also focally formed nested or packet pattern, as you can see on the right, surrounded by a delicate thin wall brachiocells. This tumor showed strong c-KIT reactivity without the expression of a smooth muscle marker and DOG1. But given its spindle or cell morphology, the referring pathology suggests the possibility of an unusual gist metastasizing to somatic soft tissue. However, both the endoscopy and abdominal imaging study revealed no abnormalities. Notably, this case was diffusely positive for a pancreatic, although stromal in the perivascular hyalinization was not that evident. The possibility of an emerging anti-arcade rearranged spindle cell neoplasm still has to be considered. Therefore, we performed RNA-based sequencing and unexpectedly identified an infrared fusions involving EWS1 and NR4A3, the genetic hallmark of extraskeletal mesoid chondrosarcoma, which was further validated by fish thing on the right to demonstrate the rearrangement of both partner gene. Following this result, we carefully reviewed all H and E sections and identify a minimal focus of Myxoid stroma, confirming the diagnosis of solid EMC with a predominant spindle pattern. Our recent study suggests that the wild type NTRK2 and NTRK3, but not NTRK1, may show increased mRNA levels compared to more than 100 non-EMC cases analyzed by the same RNA-seq platform. And these upregulation likely contributes to moderate to strong pain tracker expression, in approximately 35% of cases are tested. Another case predominantly consists of solid sheets of a small rounded cell with clear cytoplasm in a delicate fibroblastic septa, closely mimicking an Ewing sarcoma. The presence of EWS1 and R4A3 fusion are confirmed as a solid variant of EMC. Notably, the Myxoid focus again was only minimal and easily overlooked. This example involved a superficial dermal-based lesion with an EWS1 and 4A3 fusion arising from the acral extremity of 60-year-old females at her foot. Unlike the typical deep-seated somatic soft tissue location seen in the majority of EMC, histologically it showed a hypocellular proliferation of uniform spindle cells set in a fibrous to Myxoid stroma with only subtle reticulate histology, raising differential diagnoses such as acral fibromyxoma and perineuma and so on. As you are aware, the classical EMC variant that shows a multinodular growth, copious Myxoid stroma with frequent stromal hemorrhage, high-powered tumor cells oftentimes form interconnecting cords, nests, or gun-like structures imparting Myxoid reticular pattern. However, diverse histological patterns can be observed in a single case, as exemplified by this example harboring TF15 and R4A3 fusion, showing a range of features from classical cording fascicular pattern and aggregation of a rhabdoid cell. Although the cellular variant of EMC are enriched in those harboring TF15 or NR4A3 fusion with frequent presence of rhabdoid cells, as indicated by red arrow, they are not limited to these fusion variant. Actually, in the cellular variant with the canonical EWS1 and R4A3 fusion, we still can observe quite a few prosthetic cells within the compact sheets of a round to epithelial cell. We also came across an EMC example with a prominent microfollicular pattern and EWS1 and R4A3 fusion reminiscent of a mixed tumor of salivary gland or soft tissue. Along this line of consideration, morphologically distinct EMC subset resembling soft tissue myoepithelial tumors have been recently proposed. In this series, both cases exhibit TF15 as the 5' fusion partner and it is spread by phasic histology. Spindle cells were arranged in distinct or vague bundles transitioning into epithelial cell with within a more hyalinized stroma. Myxoid reticular areas were only minimal or even absent. And the epithelial cells were arranged in nested or even pseudo-pulmonary structure as shown here. Dr. Michal also reported an EMC with the same TF15 RNA diffusion, but very prominent pseudo-papillary structures throughout the lesion. Atypical's group from Japan also identified a small subset of our EMC exhibiting keratin positivity, rare phenomenon thing in these tumors, along with prominent fibrotic stroma closely resembling myoepithelial tumor. Tumor cells were predominantly arranged in sheaths or nests within a hyalinized stroma rather than in cores within a Myxoid matrix. Notably, this subset was not restricted to cases with TF15 related fusion, and indeed more often thing in EWS1 or rearranged counterparts in their series. NR4A3 associated fusions are known to occur in more than 90% of extraskeletal Myxoid chondrosarcoma, with EWS1 being the most common 5' pattern are in approximately 17 to 80% of our cases, followed by our TF15 in 10 to 20%, our TCF are 12 in less than 10%, and TFG. Notably, ultra rare are 5' partners have been reported in isolated cases, such as fields marked A2 just to name a few. More recently, an alternative EWS1 or an NR4A2 diffusion has been identified in two separate cases. One shown here is with the presence of a hybrid classical Myxoid on the left and complex cellular patterns on the right. Another case demonstrated nearly the solid growth with hemorrhage composed of monomorphic rounded cells in sheaths with occasional micro follicular appearance on this corner. In terms of disease specific survival, we found that 5 factors were univariately significant to predict worse outcomes, including TF15 related fusion, while only tumor size larger than 10 centimeter and our mass at the presentation remain prognostically independent. It's important to emphasize that NR4A3 associated fusion are not restricted to extraskeletal Myxoid chondrosarcoma. A small subset of gynecologic leiomyosarcoma was found to harbor NR4A3 arrangement. Most commonly are involving a fusion with PGR gene, including the progesterone receptor, among others as the 5' partner. These tumors are characterized by strong desmin expression and displayed a range of histologic patterns, including solid sheets, aggregation of rhabdoid cell, Myxoid reticular pattern, and follicular appearances. Features partially overlapped with those seen in EMC. In summary, among the aforementioned morphologic and genetic variants, the hypocellular spindle and classical cases are significantly enriched with EWS1 or NR4A3 diffusion. In contrast, the proportion of TF15 as the 5' partner is higher in those resembling myoepithelioma, mixed tumor, or even exhibiting pseudo-papillary structure, as well as in the cellular variants, whether of the Ewing-like or hypercellular spindle cell type. Finally, the cellular variants featuring rhabdoid or anaplastic cytomorphology are particularly enriched with TF15 NR4A3 fusion. Happy to take any question.
Thank you. Are there any questions about the first talk? Yes.
Professor Nielsen, thank you.
So you describe extraskeletal myxoid chondrosarcoma with a variety of different morphologic patterns. Most of them don't look anything like extraskeletal myxoid chondrosarcoma, how like they were originally described. Why are we calling them extraskeletal myxoid chondrosarc? Some of them are keratin positive, some look myoepithelial. They can arise in the peritoneum, they can arise in the uterus, some of them with NR4A3. So why are you lumping them all together?
I think these studies, including mine, are poor. These cases are under the name of extraskeletal myxoid chondrosarcoma because of the presence of an NR4A3 genes. Although, yeah.
We have so many tumors with the same fusions that are different entities. So you basically, so why don't you call them in the uterus too? Or in the peritoneum? They have NR4A3 too. So I think it just comes down to nomenclature. Oh, you want to say something?
I think there are cases of this solid variant of extraskeletal myxoid chondrosarcoma that often have this myxoid conventional areas, which kind of confirms, I would say, that it's a spectrum.
Yeah, actually, in two cases of sorry variant, we still can observe the minimal myxoid reticular pattern, but the main portion has been overgrown by solid sheet or compact bundles.
I think there are also some studies. I'm not saying that's definite evidence, but there are methylation studies showing they cluster together. I don't know about the uterine ones. I don't think that has been done, but and they look different. So I don't know if that is extraskeletal myxoid chondrosarcoma. But in soft tissues, I think these solid variants or hypocellular myxoid variants, they are just in the spectrum, but weren't recognized previously.
Your experience with INSM1 when you look at this huge spectrum that you've shown us, and the other is INI1, because generally these are chemo-insensitive tumors. There's some role of radiation therapy, in these, and maybe trying to see for a low-hanging fruit like tazemetostat for tumors that are large, unresectable. So INSM1 and INI1 expression in extraskeletal chondrosarcomas.
Okay. Actually, we are stand INSM1 in our series of 58 EMC cases, and the percentage is quite high. It's around 30 to 45% of our cases. But it depends on the thresholds that you use as a cutoff. Yeah, so I think it's helpful, but not our determinant biomarkers for extraskeletal myxoid chondrosarcoma. Most of the time, are older INS1 and c-KIT together. If I think of the possibility of extraskeletal myxoid chondrosarcoma, and then I will do our FISH or molecular stuff. But in our series, we didn't do that many, but nothing turned out INI1 deficient.
You haven't seen, including the rhabdoid variants.
Yeah.
So heavy, but it's mentioned in the literature because they are one of the INI1 deficient, but even in our experience, we haven't seen INI1 loss in EMCs. Thank you.
Yeah, that scenario is unlike what we are discussed in myoepithelial carcinoma.
I think what Dr. Nielsen was asking you is if you have a keratin positive one of these, are you going to call it myoepithelial tumor, or are you going to keep it as extraskeletal myxoid?
Actually, another case reports use the term myoepithelial tumors. for NR4A3 are a few cases. But yeah, this is the concept of Professor Nielsen. Yeah.
My question is, many of these have much more cellularity. Are you going to up the grade for those? You believe those are higher grade tumors when they're much more cellular?
Yeah.
Okay. Thank you very much. You want to move on to the next talk?
Yeah. Now let's move on to a more common mesenchymal neoplasm, dermatofibrosarcoma protuberans, to discuss this rare but clinically important genetic and histological variants. In the latest WHO classification, as you can see on the left, the DFSP is characterized as a dermal-based spindle cell neoplasm that often exhibits honeycombing infiltration into the subcutis. These the tumor cells are monotonously brained and arranged in a distinct storiform pattern. Upon fibrosarcomatous transformation, the tumor cells become high-grade and, more importantly, undergo an architecture change, adopting a herringbone-like pattern and hence acquiring a metastatic propensity in 10 to 15% of cases. The hallmark genetic alteration in DFSP is these CAR1A1 or PTGFB fusion, resulting from a translocation between chromosome 17 and 22, facilitated by swap promoter, contributed from the 5' proportion of the CAR1A1. However, PTGFB rearrangement indicative of this gene fusion can only be detected by a break apart fusion in approximately 90-something% of cases. Including the classical cases and unusual variants showing myoid nodule, numerous stick-home vessel, mesofibrosarcoma-like histology with long curving linear blood vessels, and a giant cell fibroblastoma-like variant with characteristic multinuclear tumor cell. Now let's look at these tracheotomies arising from the right shoulder of a 60-year-old male. He presented with a distal mass at initial presentation, for which a needle biopsy was performed. It shows several rows of hypercellular spindle cell arranged in a whorl, fascicular and herringbone-like patterns with increased mitotic figures. Immunohistochemically, tumor cells were diffusely positive for CD34 and pain-track focally reactive to CD30 but negative for S100. As such, the differential diagnosis lies between our fibrosarcomatous DFSP and the emerging NT-RK rearranged spindle cell neoplasm at the high-grade N, driven by different gene fusion. This differential diagnosis is clinically crucial, as their gene fusions, despite ultimately converging on similar signaling pathway, may present distinct therapeutic vulnerabilities to different specific small molecule inhibitors. To make things more complicated, 15% of fibrosarcomatous DFSP may show diffuse pain-track expression, as you can see here. Within performed PTGFB break-apart fish are showing no evidence of rearrangement. Nevertheless, RNA-based Archer sequencing successfully identified the underlying CAR1A1 PTGFB fusion, confirming the diagnosis of fibrosarcomatous DFSP, while highlighting challenges such as cryptic translocation and deceptively diffuse pain-track expression. 3 months post-imatinib treatment, the partial response was observed in these short mass. Now let's look at these circumscribed tumor located in the side of a young male, showing diffuse expression of CD34. Beneath the where the marketed tumor border there are numerous, there are some ectotic stay-home brabisol. The tumor exhibits hypercellular proliferation of atypical or elongated spindle cell in a herringbone-like pattern on the upper right, accompanied by focal tumor necrosis and mitotic activity. Despite the absence of a CAR181 and the PDGFB arrangement on fish, an alternative diffusion involving CAR683 and the PDGFRD was identified, confirming an unusual circumscribed fibrosarcomatous DFSP with these rare variant fusion. Actually, the CAR683 PDGFD diffusion was first identified in a subset of DFSP by my esteemed mentor, Professor Antonescu, and her colleagues who neatly described 6 histologically classical cases, all are located in the female breast. Soon after these, French sarcoma team reported 11 additional cases with PDGFD-related fusion, including 9 are involving CAR683 and 2 with amylin-2 as the 5' partner. In the latter scenario, tumors were associated with fibrosarcoma transformation and CDK and 2N homozygous deletion. In our recent study incorporating more than 118 cases, approximately 4% are Hopper cryptic PDGFB rearrangement, and another 4% are presented with PDGFD rearrangement, including 4 cases each fused with CAR683 and amylin-2. Interestingly, both cryptic PDGFB rearranged and the PDGFD associated DFSP were more common, are subcutaneous, and well circumscribed, potentially complicating the diagnostic consideration. For example, one case shown here is with the CAR181 PDGFB fusion was indeed detected by RNA-6, displaying a well-demarcated tumor border, herringbone-like structure, but no rearrangement of PDGFB by fish. Another case with amylin-2 or PDGFD fusion exhibited perfectly circumscribed border, and the numerous stay-home brabisol are in the centers, but no honeycomb fat infiltration. In the context of a diffuse CD34 expression, this tumor may closely resemble a SARS-CoV-5 tumor. Another case with amylin-2 PDGFD diffusion, again presented as a circumscribed tumor with these peculiar fibrous plaque. Our fish analysis reveal rearrangements of both partner genes along with low-level copy number gains. Next, we examined a very intriguing case of a 60-year-old female presenting with dermal-based nodular tumors on her foot on low-power magnification. This tumor appears a polypoid, well-defined nodule composed of bringing monotonous spindle cells, you can see on the right, and arranged in a distinct storyform pattern within fibrous stroma. Occasionally, we can come across some cellular micronodule and deposition of melanin latent dendritic cell. This case was diffusely positive for CD34 but negative for S100. Despite its circumscription, other morphological and immunophenotypic features are reminiscent of a benign tumor, namely the pigmented variant of DFSP. However, we could not demonstrate the rearrangement of these 3 genes by fish. As such, we outsource these cases to perform RNA sequencing and identify a novel MCC fusion. This finding was cross-validated by FISH, showing rearrangement and immunochemical study demonstrating diffuse OCK expression. However, you might question whether this particular case is better classified as a pigmented DFSP with an alternative OCK fusion, as described by Professor Fritsch yesterday, or cutaneous kinase fusion-driven spindle cell neoplasm, similar to the scenario of NTRK rearranged spindle cell neoplasm, as mentioned earlier today by Professor Jessica Davis. Shortly after we came across our particular case, a relevant series was published by Professor Fritsch groups to address the classification of such tumors. Here are two examples demonstrating a typical morphologic feature of DFSP, including honeycombing fat infiltration on the left and the scleroform growth of a monotonous spindle cell on the right. Both cases were CD34 and OCK positive, but had different 5' partners. In their series, besides the 3 cases are classified as plaque-like CD34 dermofibroma, which are beyond the scope of today's discussion. Another 4 cases were categorized into DFSP, with a consistent co-expression of CD34 in OCK, but harbor various 5' partners and retained the C-terminal kinase domain of OCK in all cases analyzed. Methylation profiling of 2 represented cases reveal clustering with classical DFSP, likely harboring the canonical gene fusion, supporting their better classification as a genetic variant of DFSP. In summary, 92% of DFSP cases exhibited the canonical CAR181 PTGF-B fusion, and almost invariably present as honeycombed extensive infiltrative growth pattern. In contrast, the cases with cryptic PTGF-B rearrangement or alternative PTGF-D fusions are more likely to present as a well-demarcated subcutaneous nodule, as you can see on the right. Regardless of the presence of or absence of fibrosarcomatous transformation, due to the extreme rarity of OCK fusion-driven DFSP, further investigation is still required to elucidate its full morphologic and genetic spectrum, including the pigmented circumscribed lesion we shared today. Thank you for your attention. Happy to answer any question.
Thank you. That was an excellent review. This is open for discussion. Are there any questions? So in terms of the fibrosarcomatous transformation, do you think that has worse behavior, and does it vary by the gene pattern, or is it basically all the same once it has fibrosarcomatous morphology?
Fibrosarcomatous transformation should rely on morphology criteria, including herringbone-like structure and increased mitotic figures, likely up to 5 protein hypofields. But I think our herringbone-like pattern is quite useful, even more than our mitotic counts. But they are usually correlated with each other. Perhaps our CDKN2A deletion or P53 mutation would occur during the fibrosarcomatous transformation.
Thank you very much for this nice talk. How you approach Myxoid variant of the FSP, they look sometimes very polycellular, very angiomyxoma-like, blunt looking. I have seen very few cases that came many years later as lung metastases, but I don't know how to call them primarily as fibrosarcoma as always or not.
Indeed, I experienced some Myxoid DFSP, but unfortunately, my cases do not show metastasis after follow-up. So I have my own experience to let you know in this regard.
Okay, thank you, Albert, for your presentations. You guys are doing a wonderful job in Taiwan. I'm very happy you are here with us. There will be also... We'll also have a talk from J.C. Lee in the afternoon. He's somewhere here. I'm very much looking forward to it. And I also like to thank all the other speakers of this session. And now I would like to ask all the speakers to remain here for group photo. And anybody from the audience who is interested to take a photo with us, and whoever can fit in, just come over here. All the others, there is lunch, and we will meet back at 1 o'clock. Thank you. All right, ladies and gentlemen, welcome back. Before we start with the afternoon presentations, I have something much more important here. First things first, we have brewery tour tonight, so what do? The program should end shortly before 5 o'clock, so I suggest whoever wants to can meet us at 5:30 at the Pilsner Urquell Visitor Center. Here is the lab. You just walk along, there's a train station, here is the Hotel Vienna House, and you come to the visitor center. Whoever wants to, especially the speakers, but whoever wants to really can meet us at the Red Square, that's Hotel Vienna House in the lobby, and it's basically across the street, so meet us there at 5:20. So the meeting in the hotel lobby is 5:20, so it's just enough time, hopefully for you, for the speakers to go to the hotel, leave your clothes there, maybe put on something less formal, and then we will walk slowly to the brewery. There are two groups for the tour because they can't accommodate so many people at once. So the first group starts 5:45 p.m., the tour one. That will be the speakers and the participants that can fit in the first group, which is like 40 people, I think is one group. And whoever else remains goes 15 minutes later with the second group. The tour should take, I think, like 70 minutes or something like that. And when we are done, we continue to the brewery restaurant. At 8:30, there starts a dinner. The brewery restaurant is across the yard, basically from the visitor center. It's called Naspilze. Here's the name, Naspilze. Very easy to get there. It's a huge restaurant, so we will easily fit in. So whoever signed up for that, we'll meet you there. Okay. So now I have also the first presentation, which will be about anisometric or dysplastic lipomas. So the first description of this entity dates back to 2016, and it was nobody else but famous Dr. Harry Evans, who described it under the name anisometric cell lipoma. In his first series, he had 13 cases of very well differentiated, purely subcutaneous lipomatous tumors with minimal atypia. Almost all patients were males, except for one, and the anatomical distribution was basically identical with what we know from spindle cell lipoma, so shoulders, back of the neck, and so on. As usual, Dr. Evans had a very long follow-up for these cases, and he could say that 3 out of 13 cases recurred. Also, which is very notable for the rest of the story, already in this paper he showed that one of the 13 patients had a history of ocular retinoblastoma, therefore he most likely had a retinoblastoma syndrome. Because Harry Evans is well known to not use IHC or molecular, he didn't use this in his paper, and that's why it was published in AGSP, but not in the AGSP, but in AGSP reviews and reports, which is like a much lower grade journal, I think still without impact factor. And so basically nobody read that paper except for maybe one person. If some of you probably may not know what I'm talking about, so this is how the tumors look like. I'll speak about the morphology later in more detail, but basically the name Dr. Evans chose, anisometric, is completely logical because it basically says that the fat cells have a very great variation in size of the adipocyte vacuoles. So that's, for me, also the most striking feature of these tumors, very large variation in size. Then another important feature is almost complete lack of spindle cell stroma, except for recurrent cases which show kind of like a fibrosis there. There is almost no stroma at all. Then if you would go on higher power, you would notice areas like this, which basically are histiocytes, which occur there after what is called single cell fat necrosis. So there are minute small places where single adipocytes undergo necrosis and then histiocytes colonize that place. Then if you go on higher power, most cases, not all cases, but most cases have really minimal atypia, but already more than what would be acceptable for normal lipoma, benign lipoma. So this is hyperchromatic, slightly hyperchromatic nuclei, a little bit weird, dark nuclei, sometimes weird shape as well. So some 80–90% of cases look like this, really minimal atypia, and the rest can have a much more prominent atypia, as I'll show later. Here are some more examples. Okay, so I said nobody read that paper probably, except for one person, and that was nobody else but Dr. Abbas Agaimi, who collected 6 cases of the same tumor. And as you have probably noticed, Dr. Agaimi isn't ashamed to use molecular methods. So he has done everything that was needed, basically. MDM2 FISH, it was negative in all 6 cases. He also did RB1 FISH, because he suspected it might have something to do with RB1 alterations because of the anatomical distribution, the appearance, and the association with retinoblastoma syndrome. And indeed, 4 out of 5 cases were confirmed to have RB1 deletion by FISH. By IHC, basically all cases had loss of RB1 expression. Another person that has noticed these tumors, he didn't notice the paper, but he noticed the tumors in his practice, was another famous pathologist, John Fetch, who worked most of his life in AFIP. He's a fantastic soft tissue pathologist. And he was telling me and my father that he has been noticing these weird subcutaneous lipomatous tumors, which occur almost uniquely in males and typically at the back of the neck, and that he doesn't know what to call them, that he thinks they are something special. So he told me, and I was resident back then, I had quite a lot of time, so I was going through our archives, I was looking at lipomatous tumors, and I was trying to find cases that matched his criteria. And during this review process, Abbas's paper came, I think I can say it now, it came to review to my father, and he came to me and he was like, maybe John meant these cases. So I sent it to John and he was like, yeah, that's exactly what we are looking for. So since then it was easy to find more cases, and eventually we put together 66 cases. And we published it, and we called the tumor dysplastic lipoma. So we suggested a name change, which looking back today, I think it wasn't the best thing to do. The name, I don't like the name anymore today, really. So yeah, I think anisometric is better name, but whatever is used is okay. But I think what we chose well is the subtitle, because it basically says everything important about these tumors. So we think this is a distinct entity among adipocytic tumors, and I'll try to show you why. In the WHO, it is unfortunately now classified among atypical spindle cell pleomorphic lipomatous tumors, which is, honestly, my opinion is that these tumors really exist, but it's currently, the way it's defined is it's a very heterogeneous mixture of tumors, and I see no reason why to add into this group some very well characterized tumors as dysplastic lipomas are. Raul will talk about these atypical spindle cell pleomorphic lipomatous tumors later, and he will tell you what they are, how they are currently classified. And again, I really think this is an entity, but I don't think dysplastic or anisometric cell lipomas belong in there. I think they are very much distinct. What is important, basically all cases in our series, or 90% of them, were either diagnosed or sent for consultation as atypical lipomatous tumors. So basically all or most general surgical pathologists would call these tumors atypical lipomatous tumors. Interestingly, the experts of tissue pathologists, I noticed that they don't call them ALT, they call them lipoma with fat necrosis, which is okay because there is no overtreatment, anything, but general surgical pathologists very often mistaken them for atypical lipomatous tumors. So clinically, how do they look like? They are purely subcutaneous tumors. They don't go into skeletal muscles. As I mentioned, same as spindle cell lipomas, they occur typically in middle-aged males. There is a very strong male predilection and a pretty wide age range. If you look at this, at this graph, you can see a nice distribution with one peak in the middle group. So this is another support for these tumors being a well-characterized, distinct entity because there is this clear distribution, this trend towards this distribution. So the location, again, upper back, neck, and shoulders. And what is interesting and what is different from spindle cell lipomas is that up to 1/5 of the cases reported have been multifocal. Also, 9 out of 92 cases that are known to us have a history of ocular retinoblastoma. I'll speak about this more at the end. Regarding biological behavior, it's not fully established yet. There are not so many data, but definitely some 10% of cases at least recur. So that's a frequency somewhere between lipoma and ALT. And importantly, there has not been a case described with dedifferentiation or even metastasis. So they seem to be completely benign, but locally recurrent occasionally. Morphologically, I've mentioned this, so extreme variation of adipocyte size, absence of spindle cell stroma, mild but diffusely present atypia of adipocyte nuclei. And regarding the genetics, there seem to be RB1 abnormalities. The problem is that because there are so many histiocytes sometimes, it's very hard to pick the RB1 alterations by FISH. And because there is so few nuclei overall, it's kind of hard to analyze them by molecular methods. So we know this from RB1 IHC that there is basically always loss of RB1. And because there is such a strong association with retinoblastoma syndrome, that's another confirmation that these are RB1 altered tumors. And in the cases where FISH analysis was successful, there was usually RB1 loss as well. There are no MDM2 amplifications by FISH, but there might be some abnormalities. I'll touch upon that a bit later. So again, one typical case here. And here we see the small subset, some maybe 10% of cases, which show much more prominent atypia, which you can see here. Some higher power on the bizarre hyperchromatic nuclei of the adipocytes. And what is useful for differentiating these tumors from ordinary lipomas is that the hyperchromatic atypical nuclei usually overexpress P53. So that might help you differentiate that from ordinary lipoma. It will not help you to differentiate it from ALT because ALTs are sometimes P53 positive as well. RB1 is also diagnostically useful, always lost in the nuclei, but it won't help you to distinguish that from ordinary lipomas because they are also sometimes RB1 deficient. You can visualize the histiocytes by histiocytic markers, of course, and perhaps a pitfall, some cases seem to overexpress MDM2 in a very small subset of the adipocyte nuclei. But again, MDM2 FISH has been negative in all 60 cases studied. NGS done on few cases have been negative for other recurrent abnormalities. This is a nice paper written by Yin Rex Hung. He is here in the audience as well. He will speak tomorrow. And Dr. Nielsen, which they use MDM2 in situ hybridization, so not FISH but ISH in their practice to confirm well-diff liposarcomas or atypical lipomatous tumors. And they noticed that almost all dysplastic lipomas are positive by MDM2 RNA in situ hybridization, but even their cases, of course, were negative by FISH. So there seem to be, coupled with the MDM2 IHC, immunohistochemical overexpression in some nuclei, there seem to be some abnormalities in MDM2 expression, perhaps related to the abnormalities in RB1 gene, because RB1 is interconnected with MDM2. So there might be some mechanism leading to the overexpression of MDM2 RNA-ish. So this is one of the last slides, and this is unpublished largely. Basically, patients with retinoblastoma syndrome have been repeatedly reported to frequently develop lipomatous tumors, very often multiple lipomatous tumors. Unfortunately, those studies are purely written by geneticists, so they don't offer any histological pictures. As we knew about a possible association between RB1 syndrome and dysplastic lipomas, we speculated that perhaps most of these tumors or all of these lipomatous tumors reported in retinoblastoma survivors are in fact dysplastic lipomas. So we have basically written dozens of our friends and colleagues around the world to if they could search for lipomatous tumors arising in retinoblastoma syndrome patients. And although multiple people responded, we have identified only 6 patients because it's obviously pretty rare. And out of these 6 patients with lipomatous tumors, on a histological review, 5 of them showed typical dysplastic lipoma morphology, and only 1 of them was ordinary lipoma. Coupled with the few case reports in the literature mentioning dysplastic lipomas in retinoblastoma syndrome patients, we now know about 9 patients with retinoblastoma syndrome and dysplastic lipomas. Overall, it's 9 out of 92 published cases, so almost 10%. Definitely they are overreported, so it will be less. What is important, the retinoblastoma syndrome patients often are known to have multiple dysplastic lipomas, which might be helpful to kind of think about this possibility. And another important thing, some people have a low penetrance retinoblastoma syndrome, so they do not develop ocular retinoblastoma in childhood. So they are not known to have this syndrome, but they are still at risk of developing some high-grade malignancy, leiomyosarcoma or whatever, later in life. And so we think that knowing this, that when you have a patient with multiple dysplastic lipomas, could be that the patient could have a retinoblastoma syndrome, even the low penetrance retinoblastoma syndrome. It could trigger the molecular testing to, detect the germline mutation. So this is a project going on for 4 years. I still didn't push myself to publish this. So it's unpublished. So basically, I'm also showing it here. So if anybody here from the speakers or audience could, would be willing to search their archives for retinoblastoma syndrome patients, if they had some lipomatous tumor, and could look at it or send it to us, we still have time to add it to the study. I hope to finish it this year sometime, but we'll see. So this is one picture, this from the retinoblastoma syndrome patient. It's the same morphology, basically. So I think I'm kind of running out of time, so I'll leave this here for everybody to read if they are interested. It's just a summary, and I'm happy to take questions.
Michal, very, very interesting. You didn't comment what you told us to about the fish of MDM2. So I experience a lot of cases where we have these polysomies, and I don't really know what to do with that. Is that something that you find in these dysplastic lipomas as well, or is it always diploid?
We did MDM2 fish only for the study, and it was done by our lab technicians, which do it regularly, and they have no doubts. They just said it's negative. They didn't call us to look if that's polysomy or not. They just said it's negative. And honestly, in my routine practice, I think these tumors are so distinctive. I don't really do fish on them.
Okay, but the thing is that, of course, if you have a polysomy, then it comes back negative because there is no amplification. But still, sometimes I have like 30 MDM2 signals and 29 signals of the centromere. And since these are obviously hypochromatic and large, I was wondering if they could show that as well.
I must say I don't have insight into this, so can't comment. Sorry, maybe Rex would know.
Well, thank you for the question. It's a good one. So, I mean, the images actually Michael showed, you see there's no evidence of polysomy that we can see. The MDM2 fish is absolutely look normal. What is interesting is you see the p53 overexpression, RB loss, the MDM2 transcript, RNA is high. Of course, P53, RB, MDM2, those all sit in cell cycle. So I think in a way, they all related that way, actually, but not genetically through MDM2 amplification, DNA level. So.
Thank you. That was excellent. Oh, somebody else? Oh, go ahead.
Go ahead.
I have two quick ones. One is, I know that we use for like a poor man's MDM2 P16 and Ki67. Have you stained these dysplastic lipomas with these two stains?
Yeah, we definitely didn't do Ki67. We
Yeah.
might have done P16, but I don't really remember because I don't use it. I don't really
Yeah,
care
I
about
would-
it. But might
yeah.
be in the paper if you check.
Yeah, I would
check
anticipate it
out.
would be negative.
It's already 7 years ago.
And then the second question is, when you said this was included in a group, do you think there's something else beside dysplastic lipoma that's in the atypical spindle cell lipomatous tumor? Do you think there's other tumors, or do you think they're all dysplastic lipoma?
No, don't take me wrong. I think there is atypical spindle cell polymorphic lipomatous tumors. These tumors exist, no doubt. But I don't think the tumors I was talking about, the dysplastic lipomas, should be classified in this category. It's already, it's not there. I have here already the Raul's talk. So they shouldn't be classified with atypical spindle cell polymorphic lipomatous tumors because I think they are just distinct. But I'm not saying that atypical spindle cell polymorphic lipomatous tumors do not exist, as Raul will show right now. Maybe Abbas?
Yeah, just a very short note. These tumors are very frequent. I see at least one case per week, really, in Germany. And they never show transition to spindle cell or polymorphic lipoma, so it is usually purely entity. I know that some other authors have different opinion, and they recur occasionally, but I never have seen destructive or problematic, so I always make a note that they may recur, but they don't need any radical resection. And I think the recurrence is usually because they come as fragments, also they are not very well excised like other larger lipomatous tumors.
I have the same experience. I basically get all lipomatous tumors from the faculty hospital, and I see spindle cell lipomas and dysplastic lipomas pretty much the same time, the same frequently. And I think they're closely related to spindle cell lipomas, but because they are multifocal and they are so often multifocal and they are associated with retinoblastoma syndrome, and they are also morphologically different a little bit, I think it's distinct thing. Please have Mike.
Oh,
in the upcoming WHO, they're going to use the term anisometric. They're going to get rid of the dysplastic. But also, I'm trying to remember which chapter they're going to put it. They're not going to give it a separate chapter, but I can't remember if they're just going to put it with the spindle cell lipomas or the atypical. Do you remember?
That would be a good news, but I hope it will not be included in the spectrum of spindle cell lipoma, because we don't see any transition. Spindle cell lipoma can be spindle cell or pleomorphic or hybrid, but we don't see this pattern indeed in the spectrum.
Yeah, also, spindle cell lipomas never have such a huge variation in size of the nuclei, and there are some other minor differences.
Right. Thank you. That was really interesting. Very happy to introduce Raul Perret. He'll be talking about atypical pleomorphic / spindle cell lipomatous tumors.
Hello, good afternoon. Thank you very much for the introduction. So we are running out of time. I will try to do this talk quickly. Yeah, atypical spindle cell pleomorphic lipomatous tumor, a controversial entity, as you will see. I have no conflicts of interest. So atypical spindle cell pleomorphic lipomatous tumor is one of the new entities introduced in the latest WHO classification, along with myxoid pleomorphic liposarcoma, as you can see here. I'm just going to test this. Okay. So basically, these are classified as benign adipocytic tumors that show local recurrences in up to 12% of cases. The main clinical features is that you see a peak in adults in the 6th decade of life, and they have a wide anatomical distribution, but they tend to have a predilection for the hand and foot more than other locations. And sometimes, or generally, they tend to be poorly circumscribed, but not all the time, as you will see. Also, the majority of cases are superficial, so suprafacial, and up to 1/3 of cases are deep. So this is my recipe of atypical spindle cell pleomorphic lipomatous tumor. Basically, you see varying proportion of all the ingredients that I've noticed here. You have spindle cells, a fibrous to myxoid stroma, and a depositic component that includes lipoblasts generally, and they tend to be abundant. And there's nuclear atypia with low mitotic activity and no necrosis. And of course, it's very important to remark that these tumors have to be negative for MDM2 amplification, and they are negative also on immunohistochemistry. So these things are actually in a morphological spectrum where you will see, or continuum, as you can see in this graphic, where tumors that are predominantly composed of spindle cells will be more in the spectrum of ASLT, or atypical spindle cell lipomatous tumor, and the ones that have a bigger amount of pleomorphic cells, particularly lipoblasts, will be more in the spectrum of atypical pleomorphic lipomatous tumors. But there's some mixed cases, as you can see. So I started by showing some examples of what for me has to be classified. This is my personal view on the entity. This is the first case. It was an adult female with a 7-centimeter foot mass. As you can see here, the tumor was actually relatively well circumscribed, okay? And you see multiple components, the myxoid areas, the adipocytic areas, and also some fibers to myxoid stroma. And then when you are checking a bit the cytology, you will see that there's the adipocytic component shows significant variation in size and shape. And the spindle cell component tends to have a marked atypia with hyperchromasia, but the atypia still, it's variable. You see like a low to marked atypia in the cells, and you can find this myxoid stroma and some fibrous areas here. Again, this is just to point out the adipocytic component here, which shows striking variation in size, and also you can see several lipoblasts laying there. Another frequent finding is the presence of degenerative atypia that you can see in isolated cells, like you can see in this case with a really like a smudgy chromatin and a really weird nuclei, but you don't see mitosis, you don't see necrosis, you know, so that's what's reassuring. Again, just to illustrate the adipocytic component. So that will be an example of what I will call ASPLT. This is a second case. It was an adult male, and with a 3-centimeter mass. As you can see, this is a lobulated mass, predominantly adipocytic. You see some thin fibrous septa, and also there are some areas that look a bit more like busy or cellular here. When we go on higher magnification, we see that these cells actually have, again, striking variation in shape and size, and they are multivaculated, and they actually look a lot like lipoblast. And these cells are like hyperchromatic nuclei that are irregular. And you also see some of the features that Michal mentioned, like, for example, single cell necrosis, like with macrophages associated. Okay? So again, these look like pleomorphic lipoblasts, but you don't see mitosis and you don't see tumor necrosis in this case, and it was a well-circumscribed tumor. So that will be more in the atypical pleomorphic lipomatous tumor spectrum. And then a third case of what you will sometimes see in this entity, again, a predominantly fatty lesion that happened in an adult female with a 5-centimeter hand mass. Again, at low power, you can already see the presence of septa, of fibrous septa that are quite thick in some areas and cellular, but this is a predominantly adipocytic lesion. On higher magnification, you see that the lesion is actually dissecting muscle fibers, and you see also the presence of fibers to myxoid septa with hypercellularity and nuclear atypia. Here, again, showing hyperchromasia, in the presence even of what looks like a floret-like cell there. Actually, this on morphology for me looks a lot like ALT, like a typical lipomatous tumor spectrum of the lesion, but this doesn't have MDM2 amplification as you will find in ALT, right? And the location, also the hand, is not typical of that entity. So this particular case, you have the SNP array profile, and you can see that there's no amplification, but we do see the RB1 deletion here in chromosome 13, and there was also TP53 deletion in that particular case. So what about the immunohistochemical profile? These tumors have a particular profile. It's not necessarily useful, but they tend to be positive for CD34, variably for Desmin and S100, particularly in the spindle cells, they had been reported to be positive for MDM2 and CDK4 rarely, but they don't show amplification of the genes, at least what has been reported thus far. And you have in a variable proportion of cases RB1 loss of expression. So this is to illustrate just the immunophenotype of the tumor. The molecular findings, what has been described thus far is the presence of deletions in chromosome 13q, and this encompasses the RB1 locus, but also the flanking genes. It's what has been described as most frequent in these lesions. We have also seen that, and the group of Stanford and Greg Charville also reported alterations in TP53 that can be either deletions, either point mutations, as you can see here. And to complexify things, you also see 16q deletions that have also been reported in spindle cell lipoma. And in a really small subset of cases, monosomy of chromosome 7 have also been reported. So the main differential diagnosis will be ALT, or well-differentiated liposarcoma. These lesions are usually deep, in deep soft tissues, or the retroperitoneum, and by definition, they are MDM positive and amplified for the locus of MDM2. Here's an example on your right side. The other differential is pleomorphic liposarcoma, but these are really high-grade sarcomas, typically where you will see high cellularity, marked nuclear atypia, brisk mitotic activity, and frequently necrosis, as you see on the right side. The other problematic differential diagnosis is a spindle cell and pleomorphic lipoma. And actually, there's really no good criteria that is effective to tell them apart. There's just like different features that you will see more frequently in one entity and less frequently in the other. So I try to list them there, what is generally used and or described on papers. This is more or less controversial. But spindle cell lipoma and pleomorphic lipoma tend to be more well circumscribed. Most are subcutaneous and occur in the shoal region of adult males, as everybody knows. Nuclear atypia in the spindle cell and adipocytic component are generally rare. Lipoblast, you can find them sometimes, but you have to really look for them, contrarily to atypical spindle cell pleomorphic lipomatous tumor. Floret cells are also generally present and abundant in pleomorphic lipoma, okay? That's something that is important, I think. Desmin expression is rare, but it has been reported. And apparently, RB1 deletions are less complex and they generally do not include flanking genes in SAL and PL, but the reality is that most cases have studied like spindle cell spectrum of these lesions, and maybe if we tested pleomorphic lipoma, we will see similar findings. At least that's my theory. And this spindle cell and pleomorphic lipoma uniformly benign and local recurrences are exceptional. So this is what for me represents a typical case of a spindle cell lipoma in an adult male. Once I guess it was a subcutaneous lesion in the upper back. We see the typical areas of, again, a adipocytic component that can be more or less abundant, also like in ASPLT. It has significant variation in shape, size, and diameter. And the spindle cell component that is in the background is really, they are composed of bland spindle cells with really like small amounts of cytoplasm that they are like immersed in this abundant myxoid matrix with thick collagen bundles that look like a ropey collagen. As you can see here, you will frequently find mast cells. And of course, this case lacks any atypia. This is the prototypical case of spindle cell lipoma. These are typically CD34 positive in a diffuse way, and they tend to show also like some dendritic projections of the tumor cells that is quite characteristic of this entity. This is what a typical case of what I will call pleomorphic lipoma. In this case, occurred in an adult female. It was an 8 centimeter subcutaneous lesion in the back of the neck. Once again, we see that there is an adipocytic component. There's areas where you will see some myxoid and collagenous areas, and we can see there's some pleomorphism like in the cells. I cannot talk about the circumscription here, to be honest. This is like most cases that I receive of spindle cell and pleomorphic lipoma, they just they take out the tumor entirely, and in most cases you cannot assess accurately the borders. So when you go a higher power, this is an important feature, you will see an abundance of floret-like cells, which are these cells. We have a nuclei that are distributed in the periphery that tend to be hyperchromatic and sometimes irregular. You see, again, a fatty component that also tends to have a variation in size and shape. And you have a spindle cell component. Truth is, it has been said that the spindle cell component lacks atypia. In my experience in pleomorphic lipoma, like you can see atypia. And I wouldn't say there isn't atypia in the spindle cell areas in this case, but for me, this is still what I will call in my practice pleomorphic lipoma, okay? So again, there is significant overlap with atypical spindle cell pleomorphic lipomatous tumor because spindle cell lipoma also have RB1 loss, as I mentioned. They are not, they don't express MDM2. So once again, I repeat, there is clearly overlap between spindle cell and pleomorphic lipoma and atypical spindle cell and pleomorphic lipomatous tumor. It is a controversial entity, as I mentioned. I think there is a substantial improvement that could be done for define the criteria for drawing the line between the entities. But I do think there is something there. And just to create a little bit more controversy, I have this last case that was in a 74-year-old male that had a 6-centimeter deep groin lesion. And this one was excised, and the patient had a similar lesion excised 14 years previously. It's kind of like lobulated again, adipocytic component, or other areas that show more abundant fibrous to myxoid stroma. And when you go actually at higher power, you will see that there's again entrapment of muscle. So this will be like infiltration. It will be atypical for a conventional spindle cell or pleomorphic lipoma. But again, when you see the cytology of the lesion, the spindle cells, they lack complete, they lack nuclear atypia. They are super bland, as you will see in spindle cell lipoma. And there's some collagenous background with spindle cell areas, etc. But I didn't find any atypia. This was the most atypical area where I found that, for me, they are just overlapping nuclei, actually. But so what you call this lesion, this thing was also Desmin positive, if you want to add to the confusion. And you have the SNP array profile there. There was RB1 deletion, and there was also 16q deletion that, as I mentioned, it doesn't discriminate between spindle cell lipoma and ASPLT. So is this spindle cell lipoma or ASALT spectrum? I think that's part of the controversy and the difficulty. For me, this resembles too much spindle cell lipoma, so my opinion currently will be just to call it spindle cell lipoma, but I know that this may not be the same for everyone. This is a benign adipocytic tumor, as I mentioned. Local recurrence is in up to 12% of cases, but I have to mention that recently we described with colleagues and friends 4 cases of what we thought was atypical spindle cell pleomorphic lipomatous tumor showing dedifferentiation or sarcomatous transformation, how you want to call it. Generally, they were all superficial lesions. They all had like typical areas of what we will call like a ASPLT spectrum, and in these particular cases, 2 of them transitioned to high-grade leiomyosarcoma, and we did a SNP array on both areas, and there was clear clonal connection between the tumors. So that's the last slide. When do I think about this entity? As I already gave you the ingredients, that they are variable in proportion, and to add to it, even if it's subjective, that's how I work it currently. You have the ingredients of atypical spindle cell pleomorphic lipomatous tumor, and at the same time, the features say too atypical for just calling it spindle cell or pleomorphic lipoma. That's how I work it out. And I'd like to see these tumors like Dr. Jekyll and Mr. Hyde. Dr. Jekyll will be the spindle cell lipoma and pleomorphic lipoma, while ASPLT will be more in the Hyde side, where they are more atypical, but they are related, but not the same. Thank you very much.
No questions, right? Yeah. Thank you very much for that. I don't think we have questions or time for questions now, but please find Dr. Perret afterward if you have any. And then I'd like to introduce, there she is, Dr. Josephine Dermawan from the Cleveland Clinic.
Hi, everyone. Thank you so much, Michael, for inviting me to talk about Myxoid pleomorphic liposarcoma. This is a topic that is really near and dear to my heart. So really the first big series that is trying to define the histologic and molecular genetic features of this entity is from David Creighton's group, published in this paper in Modern Path, where they look at 12 tumors. They look at it all over the place, but most of them are in the mediastinum. And really, they try to define the genomics of this entity, and they show lots of 13q14, including RB1, but other genes flanking RB1 in half of the cases. And in the study, they also look at chromosomal aberrations across the genome, and they saw complex chromosomal aberrations, which is kind of similar to a lot of other complex karyotype sarcomas, characterized by multiple chromosomal gains and losses across the genome. And they also did methylation profiling comparing the cases of myxoid pleomorphic liposarcomas with so-called conventional pleomorphic liposarcomas and myxoid liposarcoma. What they found is that pleomorphic liposarcoma and myxoid pleomorphic liposarcomas, they form the same cluster, as you will, on UMAP, and which is separate from myxoid liposarcoma. And as Daniel has told us, methylation profiling is the answer to all of life's problems. And so this has led to a school. Sorry, no, you told me that. I'm sorry, I'm just joking. Just frank denial. So this has led to a school of thought that myxoid pleomorphic liposarcoma is actually a variant of pleomorphic liposarcoma and not truly a distinct entity. Even though it is, as Raul has pointed out, one of the, it's a separate chapter in the WHO 2020 classification. And so when I was at Memorial Christina, I was like, I really want to find out more about myxoid pleomorphic liposarcoma. And at Memorial, patients who go to treatment, they get MSK impact, which includes a lot of data that you can get. And so I tried to look into the files to find cases that either has been diagnosed as myxoid pleomorphic liposarcoma, or we think could be this entity, and I'll show you the criteria later. So we look at histology mutations, copy number alterations, and more importantly, allele-specific copy number profiling, which I will talk about in more detail. And in this study, we also compare cases that we define as myxoid pleomorphic liposarcoma to pleomorphic liposarcoma and myxoid/round cell liposarcoma. And really, we really want to make keep a very pure cohort, because sometimes when you see studies and you question how are those cases diagnosed to begin with, sometimes the only thing in the method is like the cases were reviewed by an expert soft tissue pathologist. And so that is, of course, it's a good criteria, but it's not it's still subjective. And so in this study, we actually deliberately avoid any cases that are in the extremities. And also we, of course, we have to filter out cases with MDM2 amplification or DDID3 rearrangements. And for any cases of myxoid round cell liposarcoma that we include, we only include cases that are molecularly confirmed with DDID3 rearrangements. And none of the cases of pleomorphic liposarcoma and myxoid round cell liposarcoma in the control cohort that we included are located in the mediastinum or the head and neck. So they are in like usual locations in the extremities. So of the 8 patients that we included, 5 are female, 3 are male, and the median age is similar to previous studies. It's pretty young. It's like 32 years old. Except one were located in the mediastinum, surrounding critical anatomic structures, including large vessels, pleural, chest wall, spine. And usually the tumors, they are pretty large in size, and they involve a lot of critical structures. And so really, on radiology and also grossly and on low power, you can appreciate how invasive this tumor is. Involving surrounding structures, it really infiltrates and invade like the bone here in this like rib For example, lung, pleura, pericardium. And so you can imagine how incredibly difficult it is to completely resect this tumor. It's impossible for the cardiothoracic surgeon to completely resect it. I think that's why it's so, it has such a high mortality rate or morbidity. And really the hallmark of the histologic features is this, if you will, hybrid features of Myxoid liposarcoma and maybe pleomorphic liposarcoma, where you see this, on low power, you can see this like very nice, delicate, branching chicken wire-like vasculature. And then mixed with all these cells that you can recognize them as lipoblasts, but they are not the signet ring-like lipoblasts you see in Myxoid liposarcoma. A lot of the times they are this multifaculated pleomorphic lipoblasts with significant severe nuclear atypia. So the degree of nuclear atypia and pleomorphism really exceed what you would accept in myxoid/round cell liposarcoma. And in some cases, there could be a transition. I mean, this is a bad tumor to begin with, but they can even differentiate with, frankly, UPS-like solid areas that is non-lipoblastic. If you look at the mutational profile, the 8 cases, every single one of them have p53 mutations, and some RB1, some of them have RB1 deletions. The profile is like, okay, these are all the p53 mutations. Most of them have a high variant allele frequency, indicating that they really, is like one of the key oncogenic drivers. This mutational profile is very similar to pleomorphic liposarcoma, which has been shown already. So frequent p53 and RB1 alterations, it's a hallmark of most complex karyotype sarcomas, including leiomyosarcoma, osteosarcoma, UPS, and of course pleomorphic liposarcoma. So they are similar in this regard. In contrast, which is shown already previously, Myxoid liposarcoma really does not harbor a lot of p53 mutation. Really, it's like frequent. I mean, aside from the detected 3 rearrangement, the most frequent secondary alterations in Myxoid liposarcoma is frequent third promoter mutations and mutations in the PI3K pathway. And so this is a paper showing pleomorphic liposarcoma, again, frequent p53 and RB1 alterations, either by copy number deletions or mutations or structural variants. And third promoter mutation and PI3K pathway shown by Dr. Michal and others at the Heidelberg group. And so going back to myxoid pleomorphic liposarcoma, if you just look at copy number, it's not surprising. You see a lot of copy number gains and losses involving multiple chromosomes. So this 2 circles plot is an aggregate of all 8 cases, so that you can kind of see an aggregate of like the copy number profile of the 8 cases. Really, it's like in widespread copy number arm level changes. And here, this is from MSK impact of FACET algorithm. So in a typical diploid heterozygous genome, you will see the black line is the total integer copy number, which should be 2, and the red line should be the minor allele at 1. And you can see that the red line, the minor allele, is at 0 across most of the chromosomes, indicating a loss of heterozygosity. K7 is a case that is near haploid, meaning that not only is there a loss of heterozygosity, but the total integer copy number is only 1. So it's not diploid, it's near haploid. And then the metastatic tumor of this same case has most of the chromosomes have a copy number of 2, meaning that this near haploid genome has undergone a whole genome doubling of the original tumor in the metastatic tumor, which is a not uncommon mechanism in many high-grade sarcomas. When they progress, they undergo whole genome doubling. So if you aggregate the percentage of the genome involved by loss of heterozygosity or LOH, just adding up all the percentage across the fragments across the genome, there's a significant difference. Myxoid pleomorphic liposarcoma, almost the entire genome, like more than 80%, is involved by LOH, which is significantly higher than myxoid liposarcoma and pleomorphic liposarcoma. So this is like a real quantification with, it's not just of 3 cases, 2 cases, it's really trying to quantify. And so there's actually a case report in 2016 about one case of they call it pleomorphic myxoid liposarcoma in the pediatric case with near haploidization and loss of the IB1 gene. So this is very similar to, as we know very well, inflammatory rhabdomyolytic tumor with this near haploid genome. In the case, they did a chromosomal microarray, and they observed LOH involving most of the chromosomes. And the algorithm we use in the study is FACET. It's a very good tool to detect copy number neutral LOH. So the logs ratio, which indicates a neutral copy number, will be at 0. And then logs odds ratio is kind of similar to the B allele frequency plot you're used to seeing in the chromosomal microarray, where you see the separation of the total amount of alleles. So like when you see this separation of the two lines without the central line that is at level 0, then you know there is loss of heterozygosity. So this is the log odds ratio plots of pleomorphic liposarcoma and mixed liposarcoma. You can see that the lines really hover around 0. So even though there's like some copy number changes, there's no loss of heterozygosity in most of the chromosomes. However, this is like a typical case of Myxoid pleomorphic liposarcoma. It's really striking how much loss of heterozygosity there is so evenly, so widespread, involving almost every single chromosome in this particular case. This is really, when I was looking at the genomics, trying to figure out if there's anything different about MP-LPS, really this is what came out, and I look at one case and then the other case, and then it's like I can see this really striking loss of heterozygosity widespread in every single case. And so this circles plot, it's trying to aggregate all the log odds ratio plots of all 8 cases, or sorry, in this case only 7 cases. You can see every single chromosome has this loss of heterozygosity. In comparison with Myxoid liposarcoma and pleomorphic liposarcoma, you do not see that kind of LOH involving the genome. Even in pleomorphic liposarcoma, which is a complex karyotype sarcoma, it's only some chromosomes with focally. It's not like the entire chromosome with LOH. These are some of my recent cases where I sent to Meyer for OncoScan, which is a chromosomal SNP array, as you know, where the log2 ratio, where the number level is at 0, is copy number neutral, so diploid. And then the allele frequency and B allele frequency, again, you see the separation, and then you see this loss of the central line that is hovering around 0. So when it's heterozygous, you will see this like central line across 0, like across all the chromosomes. But in most of the chromosomes, you can see that that is gone. You can see this like big separation of the major and minor allele, meaning that you don't have the even equal frequency of the parental and maternal allele anymore. It's like all this is just like completely just like loss of a complete loss of heterozygosity. And what is it? Like, why do we care? So to me, I'm a firm believer that when you want to say that there's like a distinct entity, really what matters at the end of the day, it's difference in clinical outcome. We can sit together in a room, argue all day long about, I think this is that. But if there's no difference in clinical outcome or management, like what does it really matter at the end of the day? So we look for both progression-free and overall survival, comparing these 3 categories. And for Myxoid and round cell liposarcoma, I further separated them into the low-grade and high-grade Myxoid versus round cell, because we know there are some differences in survival. So like the median time to progression is the shortest in Myxoid pleomorphic liposarcoma. And when you look at overall survival, it's very striking. We know pleomorphic liposarcoma has a very bad prognosis, but Myxoid pleomorphic liposarcoma has an even worse prognosis compared to pleomorphic liposarcoma. It's the median time to death is only less than 2 years. For this 8 cases, compared to 75.9 months, I don't know how many years that there is in pleomorphic liposarcoma, versus like even longer for Myxoid/round cell liposarcoma, which we know, even though it's a sarcoma, it's usually a bit more indolent. These are the case cohort. Again, if you look at the outcome of these patients, like almost every single case, they have distant metastasis, and most patients, they actually died of disease at the end of the follow-up period. And this is the review of like the published cases so far. I want to draw your attention to the aggregate of all the literature review. Again, as we know, the median age is usually in young adults, but the age range is actually wider than we thought. Some patients are actually in their 60s. So just because it's in an older adult doesn't mean that it's not a Myxoid pleomorphic liposarcoma. Again, strong predilection to the mediastinum. I'm sorry. But then, like, if you look at the number of patients who died, it's striking. It's 26 out of, I don't know, 30 or so patients who died of disease at the end. So this paper, it's in Modern Path, and I really think we provided a useful tool to diagnose this entity using things like chromosomal microarray, where you can not only look at copy number, but allele-specific copy number changes to show loss of heterozygosity. And so I want to make the case that myxoid prolific liposarcoma should be regarded as a distinct entity because of the distinct genomic feature of widespread LOH, and also because of the aggressive outcome, which is even worse than prolific liposarcoma. Thank you very much.
Thank you very much. That was a wonderful talk. Unfortunately, we're running a little behind. So again, if you have questions, please find Dr. Dermawan in the break. And I'd like to introduce John Gross from Johns Hopkins University. We'll be talking about lipoblasoma-like tumor and fibrosarcoma-like lipomatous neoplasm.
Okay, thank you, Michael, for this invitation. I'm really excited to be here. Let's see. Okay, so we're going to start off with the case. So we have a 27-year-old healthy male presented with a dull groin pain and a palpable mass. The clinical suspicion was for an inguinal hernia, which prompted imaging, revealing a 7-centimeter paratesticular mass. Surgical exploration and a radical orchiectomy ensued, and then the specimen was sent to our institution. Here's a gross photograph of this mass, and you can see that it's fatty with a pushing border, but it's also very multinodular, and we'll talk about that multinodular appearance very soon. At very low power, we see a mass that is separated by fibrous septae, and admixed, you can see white spaces of mature adipose tissue and a vague kind of myxoid background stroma. Other areas have more mature fat at the edges, see at the periphery. And again, a myxoid background stroma that is very septated and lobulated. At higher power, you see the myxoid stroma, again with background admixed mature fat, and then a capillary architecture such as one would see in myxoid liposarcoma. And the cells of interest are a little bit spindled. Some areas have lymphoid aggregates, and others had extravasated red blood cells. Then you'll see the lipoblasts, and these are univaculated and bivaculated lipoblast in the background of a fibromyxoid stroma. Here we can see some, let me see if this thing works. There we go. So you can see we have lipoblast here that are ice cream cone. Some of them are hourglass shaped and optically clear. Yeah, here's a nice hourglass shaped optically clear lipoblast. So what is the differential diagnosis? So this case was several years old, and at the time, I was thinking, well, it's paratesticular mass in a 27-year-old man, probably a lipoblaст-rich, well-differentiated liposarcoma. It had some features that looked a little bit like myxoid liposarcoma, especially the myxoid stroma and the vasculature, so perhaps it was an unusual example of a paratesticular myxoid liposarcoma. It also has morphologic features reminiscent of lipoblastoma, with the lipoblasts and the myxoid stroma and all the septations. Could it be an unusual spindle cell lipoma? Perhaps an atypical spindle cell polymorphic lipomatous tumor, or something else. And so my opinion at this case was it was something else, and it was a lipoblastoma-like tumor, 7-centimeter mass, so in the paratesticular site. Additional pertinent testing, MDM2-ish was negative, as well as our fusion panel did not detect DDIT3 or PLAG1 fusions. So what is lipoblasoma-like tumor? So it's a benign adipocytic spindle cell tumor with mixed morphologic features of lipoblastoma, myxoid liposarcoma, and spindle cell lipoma. However, it lacks the genetic alterations of those tumors. It was originally thought to be site-specific to the vulva, and its original paper describing this entity was known as lipoblastoma-like tumor of the vulva. At the time, there was a recent case report by Droop in histopathology in 2020 showing one in a man. And shortly after I signed out this case, there was a second case report by Gambarati and Verkhaus. So I contacted some of my mentors at the Mayo Clinic, Andrew Fulp and Kenny Schoolmeister, and I said, hey, can we study these in males? And so that was the original idea. However, considerable morphologic overlaps exist between lipoblastoma-like tumor and an entity known as fibrosarcoma-like lipomatous neoplasm, which is a rare, indolent, adipocytic neoplasm first described by Andrea Derup and Sharon Weiss in 2013 in AJSP. And at the time, it was considered by some to form part of the spectrum of atypical spindle cell and pleomorphic lipomatous tumor. So let me show you some examples of what fibrosarcoma-like lipomatous neoplasm looks like. Here we see a very low power, see lobulated, septated, myxoid, macron stroma with some more mature fat, sometimes more at the periphery. At higher power, again, you have the myxoid liposarcoma like chicken wire vasculature, bland fibroblastic cells. Sometimes you have admixed lymphocytes. And then you also have the optically clear hourglass and ice cream cone-like lipoblasts. So we had opted to also compare those two tumors to each other. The clinicopathologic IHC and molecular genetics features of both, trying to understand their relationship to themselves as well as in both sexes. So here's our study, including Michal and Raul and a lot of other people in this room. We had 23 cases. 17 were lipoblastoma-like tumor, and 6 had been diagnosed as fibrosarcoma-like lipomatous neoplasm. As we started to study mostly in males, we tried to get a lot of males in the beginning. It ended up being roughly equal, 13 females and 10 males. 18 of them arose in inguinal genital region, but we also had some in the flank, shoulder, forearm, foot, and chest wall. So histologically, from very low power, again, you see that lobulated fibrous septations, myxoid stroma, and then sometimes you can see that more mature fat at the edges. Let me see. But again, very septated, very lobulated, very lipoblastoma-like. At higher power, again, the optically clear lipoblasts, again, fibrous, somewhat myxoid stroma, delicate capillary vasculature, and again, you have, in both cases, the hourglass and ice cream cone lipoblasts. So by IHC, they can be variably positive for CD34. RB1 can be lost in a subset by IHC. But by RNA sequencing, chromosomal microarray, or DNA NGS, all were negative for significant structural recurrent alterations. And so here's a heat map of our unsupervised clustering, both of lipoblastoma-like tumors in males and females, and you can see on the left side they're identical. So we concluded that lipoblastoma-like tumor and fibrosarcoma-like lipomatous neoplasm are identical. They occur in both sexes in diverse locations. No clinical, morphologic, IHC, or molecular genetic differences exist. At the time of our paper, we had follow-up in 11 patients, mean of about 4 years, all alive without disease, and yet one patient experienced a single local recurrence. Since the publication of our paper, we've seen an additional 11 cases, 9 sent in the consultation setting, 8 males, 3 females, mean age of 44, extremity, chest wall, trunk, groin, scalp, and 1 additional case had recurred. And here I'm going to show you one that was just last month. Here's a lipoblastoma-like tumor. Again, mature fat generally at the edges, very septated. Again, myxoid stroma from very low power. And then at higher power, again, you see these lipoblasts with bland spindle cell component, and then sort of the vasculature that we like to associate with myxoid liposarcoma. Okay, briefly, I'm going to mention another study that came out almost at the same time as our paper by Anderson and Fletcher about lipoblastoma-like tumor. And in their cases, they had 28 cases, 8 males, 20 females. Here's the site distribution shown here. By molecular, they all had a simple genomic profile, limited copy number alterations, and a very low tumor mutational burden. Here's a chart of their cases shown here. I want to draw your attention to one particular case. They had follow-up in 15. 8 had a local recurrence, so a higher rate of local recurrence than ours. But one patient actually had a metastasis. You can see the figure here to your right. And it was kind of an unusual case. The patient is still alive. There have actually been a couple case reports on this patient as well. The NGS was interesting. It did have a PIK3 kinase alteration as well as a mTOR mutation. And then in the pleural metastasis, it actually also had a TERT promoter mutation. So it does appear that exceptional lipoblastom-like tumor may metastasize, but apart from this one case, metastatic disease has never been reported. So I won't talk much about the differential because all of our great colleagues have already been speaking about this already today. But for take-home points, lipoblastom-like tumor and fibrosarcoma, like pulmonous neoplasm, represent the same entity. The molecular pathogenesis has not been fully figured out yet. Our take on it was to say lipoblastom-like tumor rather than fibrosarcoma like lipomatous neoplasm, because that's more recognized in the literature. It can occur in any sex and diverse anatomic sites. And then careful morphologic study and appropriate ancillary studying should allow distinction from, from potential mimics. I'd like to take any questions.
Thank you very much, John. Unfortunately, we don't have enough time for questions, so I'll introduce our next speaker, which is Dr. Michael Kallen from University of Maryland, that will talk about calcified condyle mesenchymal neoplasms.
Hello, everybody. Thanks so much. Pleasure to be here. Pleasure to talk about this. A bit of a controversial / hot topic. So hopefully we don't have any time for any questions. I'm just kidding. We'll hopefully save some time for questions. Would love to hear them. Anyway, calcified chondroid mesenchymal neoplasms. Oh yeah, I have declarations to disclose. The same number as this morning. Okay, let's start with a case. 45-year-old woman with a left TMJ mass, 8-year history of swelling and no inciting event, worse for the past 2 years, increasing steadily in size and causing some ear pain, now with a constant dull ache, worse with chewing and talking. So I'm not a radiologist, but I do have a clicker with a spotlight. Here's the left TMJ. You can see some erosive changes, kind of subtle, some accentuation, and it's thinning the middle cranial fossa. Over here it's zoomed in. You can see these subtle cystic-like erosion, and then, oops, wrong way. There we go. This one's an MRI image. You can see the mass lesion clearly. Trying to show it, but failing. There we go. So, in short, not a gigantic, super aggressive thing that you'd be jumping all over chondrosarcoma. Different radiology. Okay, so here's the histology, low power. It's nodular. It's obviously cartilaginous or chondromyxoid. I see what look like they might turn into some calcifications, and it looks like it's rimmed by synovium on the top. It's got a synovial layer. It's got kind of these hypocellular, myxoidy, edematous areas. You can see that here as well. It's got like a hypocellular myxoid core, and then on the outside, what looks like chondroid matrix. Here, this is important. You have spindle cell collections at the periphery of the lesion. And so that's kind of a unique feature. And you get these globular basophilic calcs spread throughout. Here it is on higher power. Notice, I don't think this tumor is terribly inflamed. All of that stuff, that's the spindle cell component of the lesion. This is not miserably chronically inflamed. That's going to become important in a minute. Here we have a striking pattern of chondroid matrix, a little bit of cartilage. You got some multinucleated giant cells in here. I am going to pull the spotlight. There it is. So that's a part of this, and then spindled cells. So the term CCMN was first proposed by Dr. Liu and colleagues in 2021 in Modern Pathology. In their series, they talked about 12 soft tissue tumors in distal extremities, some in the TMJ, and 10 of the 12 cases had FN1 fusions, which we're going to talk a lot about. Their histologic description included a multinodular architecture with cartilaginous matrix, increased cellularity towards the periphery, frequent grungy to lacy, what they call chondroblastoma-like calcifications, biphasic tumor cells with these plump, weird, polygonal to stellate cells in the matrix-rich areas, and giant cells. They talk about a morphologic overlap with what was called chondroblastoma-like soft tissue chondroma, but they expand the morphologic spectrum. So here's from their original paper. You can see chondroid matrix. You can see chicken wire calx in this striking pattern. And you can see there's some areas where it gets pretty cellular. And this example, these two examples had FN1, FGFR2 fusions. This one had an FN1 NTRK fusion, and it's got these very grungy calcifications, almost like you would see in PMT. It's got spindled cells with eccentric nuclei, and again, chondroid matrix, and it's nodular. This one has basophilic grungy calx at low power and CPPD deposition, like tophaceous pseudogout. More on that in a minute as well. This one's interesting because it has what Dr. Fanburg-Smith was talking about. It has what looks like ladybird cells. This one looks like tenosynovial giant cell tumor. And in retrospect, I'm not exactly sure this should have been included in the series. We didn't know at the time the chondroid TCGT separate entity. So there's morphologic overlap, but this has distinct features such as ladybird cells and inflam. So I think this one looks more like a chondroid tenosynovial giant cell tumor and less like the constellation of features that we're now calling CCMN. So we had a series, we collected 33 cases. This was in 2024. Ours happened in the fingers and the hands, some in the palms and the wrist. Only 1 out of our 33 was in the TMJ. So TMJ was not prominently featured in our group's work, but hands and feet, acral sites. Rarely, one patient had multiple lesions at presentation. The rest did not. And that patient had 1 in the hand and like 1 in the wrist. So similar site. Our histology, we found multinodular lesions, prominent chondromyxoid matrix, the same thing with the peripherally increased cellularity. We had variable cartilaginous diff, some with overt hyaline cartilage formation, others without. We had these plump, weird, polygonal-looking tumor cells with eccentric nuclei. They were all bland. Importantly, no inflammation, no ladybird cells. Different look than tenosynovial giant cell tumor. And we had grungy, lacy calx, a subset with more giant cells. We did not have necrosis. We did not have mitotic activity. We did not have significant cytologic atypia. Okay, so here's some of our photos. This one's got very prominent chondromyxoid matrix. It's multinodular. This one's got these coarse to grungy, lacy areas of calx and a lot of spindling. This one's got peripheral, like almost zonated spindle cell proliferation, and some admixed giant cells in there. This one's got these basophilic calc areas, almost like CPPD. Anyway, in our 33, we have no evidence of recurrent residual disease in the 15 with available follow-up. So these are essentially benign in what we've collected and what we know so far. Completely different than chondrosarcoma. Important to distinguish this from chondrosarcoma. So Bernard et al., a French group, recently last year published 33 cases and did whole exomes RNA sequencing, expression analysis, genome-wide DNA methylation, and compared to tenosynovial giant cell tumors. And in their 15 cases overlapping with soft tissue chondroma, 8 with tophaceous pseudogout, and 10 with chondroid TCGT, they found FN1 fusions in 76% with several different partners, importantly TEC and FGFR1, 4 cases with PDGFRA and USP8 fusions, and 3 with features resembling tenosynovial giant cell tumor. Importantly, all cases with FN1 tech were in the TMJ, and they had the right histologic features with or without the chondroid matrix. That formed a distinct cluster, and the cases which morphologically look like CCMN clustered with soft tissue chondroma with lacy calx, and also with tophaceous pseudogout. So 2 distinct clusters going on in that paper. This was historically called mass-forming tophaceous pseudogout. It likes the TMJ, it has chondroid metaplasia, it has 0 stromal inflam, and it has CPPD deposition. In their review, I just mentioned this, everything diagnosed as mass-forming tophaceous pseudogout had an FN1 fusion and clustered with what they called soft tissue chondroma with chondroblastoma-like features, or grungy calx. So things in the differential which could have some of the features that we're talking about here under the label CCMN. There's synovial chondromatosis. However, synovial chondromatosis has clustered chondrocytes. CCMN does not. It likes large joints, particularly the knee. We didn't report any in the knee. And it has an FN1 fusion, but it's with ACVR2A. And this can be a nasty diagnosis. Synovial chondromatosis can be aggressive. Those are not very clearly always benign nothing burgers. There's this thing called tenosynovial giant cell tumor of the tendon sheath, which can overlap with CCMN. There's the local type, there's the diffuse type. In distinction, those are very inflamed lesions with the xanthomatous cells and hemosiderin deposits and a ton of chronic inflam and ladybird cells. None of that is a part of CCMN. Now, the majority of tenosynovial giant cell tumors will have CSF1 rearrangements, but there's a subset which is being discussed now in the literature which do not have, they instead have FN1 fusions, FN1 very promiscuous. But even those have elevated CSF1, and so biologically different, which, anyway, here's ladybird cells. I think that's a great photo. Thanks, John. All right. Acral fibrochondral myxoid tumor, I don't want to talk too much about because we're about to hear about it from the experts in 4 minutes. PMT is a separate thing. It's a soft tissue tumor. It's not like this. It does not have chicken wire calx. It does have, in most cases, this osteomalacia with FGF23 excess. And they do have FN1, FGFR1 fusions and grungy flocculent matrix. So some overlapping features and a bunch of FN1 fusions, but different constellation of histology. Recently, a paper came out by Dr. Erica Cow and Dr. Fulp's group where they describe chondroid tenosynovial giant cell tumors of the TMJ, most of which have FN1 tech fusions. They proposed the name chondroid synoviocytic neoplasm, which I like also, has a nice ring to it. They talk about 21 tumors which resemble tenosynovial giant cell tumor, expansile nodules, stromal inflam, ladybird cells, stromal hemosiderin. They talk about a synoviocytic phenotype with clusterin IHC positivity and CSF1 CISH, but IHC negative. That was interesting. At follow-up, so tenosynovial giant cell tumors are different. That can be kind of a bad, locally aggressive disease. Having one of those in your TMJ is not a good thing. That could be a big problem for the patient. Not like CCMN. So different actor. They conclude that this is an unusual tumor and it's a distinct category. It's historically been called chondroid tenosynovial giant cell tumor. We are saying this is separate from CCMN. Here's from their paper. I can see already at this power ladybird cells, and I can see hemosiderin. And it's inflamed. And over here you've got some PVNS looking stuff. I know you can't say that anymore. Yeah, more photos from their paper. Anyway, back to our patient. I think it's reasonable to classify our patient's TMJ lesion as CCMN. Given the constellation of morphology, I do not think this is a chondroid tenosynovial giant cell tumor. Most important, don't call this a chondrosarc. It does not morphologically resemble some of the other things we talked about. It doesn't have clustered chondrocytes like synovial chondromatosis. It does not have inflam. It does not have ladybird cells. It does not have, this is distinct morphology, and this is a morphologically recognizable category with distinct features. You can make this diagnosis without FN1 FISH. You do not need to FISH for FN1 to get to CCMN. Take-home points. FN1 is a promiscuous gene, and its fusions are described in a bunch of different entities, a whole grip of them. There's tenosynovial giant cell tumor. There's this thing we're calling chondroid synoviocytic neoplasm. This is alphabet soup. There's calcifying aponeurotic fibroma. There's phosphaturic mesenchymal tumor. There's CCMN. There's synovial chondromatosis. It's even been described in IMT. So FN1, very promiscuous. Here we have something which can be morphologically split off and defined as lacking ladybird cells and stromal inflam. It used to get called mass-forming tophaceous pseudogout. Am I out of time? No, still good. Old school name, soft tissue chondroma with chondroblastoma-like features, plus minus grungy matrix calcifications. The molecular on this lesion is complicated and evolving. The most common thing we see is FN1 with FGFR2. It has a bunch of other different partners which are coming out in the literature, mainly in 2 big series. And with that, I would be happy to take questions. Thank you all for your attention. Fun, complicated topic.
Thank you very much, Michael. We have time for a short question if anyone is interested.
Hey, very nice. So did all of them have hyaline cartilage? Because why not call them chondroma?
And
I think at the ISS we've been calling these chondromas.
And that's the million-dollar question. I hope everybody heard that, because that's the million. You want that? Will you say that again? Yeah. I don't think everybody heard you.
Why not call them that rare variant or morphologic variant of chondroma?
So, yeah, that's a very important point. And I think it would be okay to expand. So basically, the morphologic spectrum on this thing has evolved. Some of them have more, some of them have less hyaline cartilage. These things have fusions, whereas a lot of what used to get called chondroma don't. And so it's a distinct morphology, and the molecular is a little messy and confusing, but this is an evolving story. Anyway, good point.
Thank you. We'll move up to our next speaker.
We can talk at the break.
So, Dr. John Krissinger from St. Louis, that we were talking about acral fibrochondral myxoid tumor and mimics.
All right, it's an honor to be here. Oh, sorry. It's an honor to be here. Thanks for having me. We're running a little behind, so I'm going to try to pare this down, but hopefully it'll still be comprehensible. If not, please find me at the break. Bouvier and colleagues were the first to report this tumor. They reported 10 tumors occurring exclusively in the distal extremities, and the tumors had a distinct histomorphology that was reminiscent of either a soft tissue or periosteal chondroma or a myoepithelioma. They also identified a recurrent fusion, which we'll talk briefly about. Oh, and they coined the term acral fibrochondral myxoid tumor. Shortly thereafter, there were 2 case reports. And then more recently, Dehner and colleagues reported another 37 cases. So total in the English language literature, currently there are 49 cases. So clinical features of this tumor, it's most common in middle-aged adults. The range is 17 to 79. And all tumors so far have occurred in the distal extremities, and they're twice as common in the hands as the feet, and you frequently find them in the fingers and toes. median tumor size is 1 centimeter, slight female predilection, and a subset of patients present with pain associated with their tumor. Behavior has been indolent with infrequent local recurrences. So I know this is the soft tissue section, but I thought even though this is still a soft tissue tumor, the bone pathologist might appreciate this. How do I, this one? Here? There we go. Okay, so here we can see there's an extrinsic erosion of the bone here with a sclerotic border, so some kind of indolent process. See the same thing in the oblique view of the hand. And then here is a different tumor, so we're moving a little more proximally, and the radiology in this case is clearly less obvious. But if you look closely here at the ulnar aspect of the fifth metacarpal base, I'm actually having trouble seeing it myself. So there's actually this tiny white thing right there. So that's a little bit of periosteal reaction, and then more proximally, there's a little bit of cortical irregularity, so this would be consistent with a subtle cortical erosion. So these tumors show kind of variable scalloping of the underlying cortex with or without buttressing. Here we see from the first case report a CT. You can see some nice buttressing with some scalloping of the cortex, and then you can also, of course, see the soft tissue mass. So MRI features, these are a little bit variable in T1, but usually intermediate signal. This one, you can see there's this tiny little focus of extrinsic erosion. You can see the nice black line here of the cortex, and then all of a sudden it's a little disrupted, but it doesn't actually go all the way into the medullary space. They're T2 hyperintense, and then on post-contrast images, they're enhancing. So histologic features of this thing. So these are multinodular tumors, and at low power, one thing that you can really appreciate in addition to their multinodularity is that they have hyalinized septa. And then when you look at these septa more closely, you can see in addition to the hyalinization at the periphery, the inside of these septa are highly vascular. And then, as is often the case with chondroid neoplasms, there's not much vascularity within, the kind of chondromyxoid looking areas. And then when you look within the lobules themselves, the tumor cells are often arranged in these loose groups or cords. And then their cytomorphology predominantly is these small epithelioid cells. They can also be plasmacytoid. There are areas that are more spindled. So the cytomorphology too, when you look at the nuclei, they're often reniform with frequent nuclear grooves. So they do look very chondrocyte-like. The nuclei are overwhelmingly bland. There are occasional cases that are maybe a little more atypical, like we see here. And then one thing that'll become relevant for our differential is it's pretty rare to actually see like overt straight up, this is like obviously hyaline cartilage in these tumors. They're more kind of fibrochondroid to myxochondroid to just myxoid, as opposed to actually, being sort of obviously cartilaginous. We did have one case in our study that was clearly making cartilage, and that tumor also had a bone formation. Another thing you see frequently with these tumors is these little myxoid microcysts. So this is just a summary of what I've just said. I just add also that the mitotic rate in these so far has been extremely low, like nothing to 1, if you look hard. And you can see some infarction type necrosis. So the immunohistochemical profile, so these are CD34 and ERG positive. And then you can see some focal S100, though, at least in our study, like they were actually all negative. SOX10 is negative, and Bouvier et al. Showed expression of SOX9 in the majority of their cases. So a small subset of cases will stain with P63, EMA, or keratin. It's usually focal. Let's see. Okay, so it has this recurrent fusion, as was identified by Bouvier et al., and they did RNA sequencing. They found this, and they also confirmed it with RT-PCR. In our study, we did a number of molecular genetic analyses, including FISH. We can see break apart of the THBS1 here. Okay, so this is just to make the point So this was a case I had recently, and you can, like looks exactly the same as what I've just shown. And unlike a lot of tumors we've been looking at in this meeting that have, like maybe it's going to be, round cell, or maybe it's spindly, or maybe it's epithelioid. This one, like, at least so far, has an extremely narrow clinical pathologic sort of niche. It's like all, in the distal extremities. They all basically look like this. And then I'm just putting this up here also just as, sort of we can, remind ourselves what these look like before we consider the differential, which I'm going to go through very fast. So really, these first 5, I'll touch on, and then these, of course, are covered by others. So this really is how you distinguish it, is that these like usually have obvious hyaline cartilage. This, I think, is really only superficially like related. It's pretty obviously a different tumor with like a range of histomorphologies. Also, they frequently express SOX10 and keratin. This lesion's interesting. So actually, one case in our study was previously reported as this. But I think when you look at this with all this, Myxoid change and wiry collagen, and we can see especially, where's my thing? Oh, sorry. Especially over here, you can see this thing, has a cystic change. It's got this buildup of eosinophilic stuff, and then, this chondroid change with fissuring. This to me, like, clearly looks like some sort of reactive phenomenon, whereas what we've been looking at before was clearly a neoplasm. This I really only mention because it's, like has a predilection for the distal extremities. I think we can all see for ourselves that this is not the same thing. It's storiform, it has loose fascicles, it's spindly, even though like there are areas that have like vaguely, lobular and myxoid, but otherwise really not that similar. Though I guess as a pitfall, these can rarely have cartilaginous metaplasia. And then chondromyxoid fibroma, like maybe histologically there's some overlap, but really this would be, they're very, very rare to start with. They're rare in the distal extremities. They're even more rare in the hands. And then it'd have to be periosteal. I mean, it's just like wildly unlikely. Okay, so in conclusion, we think it's a distinctive mesenchymal neoplasm. It has these features. It's positive for CD34 and ERG. It has this fusion, though. Once you're familiar with, I think Karen rightly said, knowing is half the battle with dealing with these difficult melanoma cases. I think with this tumor, it's like 95% of the battle. Like once you're familiar with it, you're basically good to go. So you don't need to like go try to find the fusion, and then it's we think it's probably benign. Those are my references, and thank all my collaborators.
Thank you for this excellent presentation. We have time for questions. Like we catch up with time, like maybe one, or if there's someone interested. No? Okay, thank you. So I'll introduce our next speaker, J.C. Lee, that comes from, sorry about that, J.C. Lee, that will be presenting about OGT rearranged acral mesenchymal neoplasms. He's coming from the National Taiwan University. Thank you.
Thank you, Raul, for your nice introduction. Today, the first talk of today is about a very ultra-rare, kind of funny-looking tumor termed OGT rearranged mesenchymal neoplasm. So it all started in 2016 when a really weird case was sent to me for consultation. It's a palmar tumor from a young lady. And you can see it's a well-circumscribed tumor. It's quite lobulated. And most of the tumor's cells are epithelial cells. They are arranged in a cold and nest patterns in a kind of a sclerotic stroma. And it tends to form this peculiar two-toned appearance composed of cellular myxoid areas alternating with hypocellular or acellular hyalinizing zones. And look at that, those signaling-like cells. I mean, what that even means? So we did the IGC. The tumor cells are diffusely positive for CD34 and focally positive for EMA, and rare cells are positive for A1, A3. They are negative for a panel of myopithelial, Hsuan-Ying, perineural vascular markers, as well as desmin, OG, CD117, and brachyury. And the INI1 was retained. By FISH, there is no EWS1 rearrangement. So I think this tumor has some features of myopithelial tumor. I hope you agree with me. But the immunostaining does not support it fully. So I submit this case to my dear mentor, Dr. Fletcher, and he kind of agreed with me. Then this case totally slipped my mind until 2 years later. My best pal, Dr. Karen Gao, showed me another case, also in the hand, from a young man. And it looked like this. And this. And this. So I say, wait a minute, have I seen this case before? Is this a recurrent or what? She said, no, it's not. So I managed to pull the first case, and we look at both cases side by side. They look like twins, maybe missing each other. I don't know. So we think we were probably onto something new. So we submit one case to RNA sequencing, and with FISH and RT-PCR, we found that both cases had this novel OGT FOXO3 fusion. So we coined the term myoepithelioma-like, just reflect on my mentor's insight of this case. Hyalinizing epithelial tumors of the hand, totally descriptive. Then the Japanese group reported the case in the dorsal foot. It's composed of the alternating hypercellular areas with these hypercellular myxohyalin areas with thickened walled vessels. And most of the tumor cells are also kinds of epithelial. And it formed a very interesting perivascular whorls. And interestingly, they also saw these signaling-like cells. So they, brilliant Dr. Yoshida, he, upon seeing these cells, he thought of OGT tumors. But turned out this case harbored this OGT FOXO1 fusion instead of FOXO3. So turns out this tumor is not limited to FOXO3, but it also can have FOXO1. And it's not even limited to the hand. It now can occur in the foot. So we thought back then this is an emergence of OGT rearranged acral mesenchymal neoplasm. But it turns out that of the barely 9 cases reported so far, there were 4 arising in outside the acral part, but in the limb or limb girdle, including both OGT FOXO4 fusion cases. It has a wide age range and a female predilection, and it seemed to follow a benign course. And the morphology forms a spectrum. So by MRI, I'm not a radiologist, but I will try. So this tumor tend to form a well-circumscribed superficial enhanced tumor. And they can have this glistening cut surface. And at low power, you can appreciate this well-circumscription and sometimes encapsulation. And a striking feature in many of the cases, not many, there are not many cases. And you can see this striking lobulation in many of the cases. And in most cases, the tumor cells are predominantly epithelial cells, although there can be some spindle cells if they are a little plump. They frequently form cones and nests, and some cases, like I mentioned, can have a thickening ring-like vacuoles. And like I mentioned, it can have this myxohyalin stroma sometimes form these peculiar two-toned appearances. And most tumors are hypervascular, and the vessels can form these fringe-like appearances or branching appearances. And perivascular hyalinization and perivascular concentric whorls are quite commonly seen. And mitosis and necrosis are essentially absent. So all the cases so far were focally or to diffusely positive for CD34, and they are usually focally positive for EMA as well, while A1, A3, and ERG were positive in a subset of cases. And they are negative for all these vascular Hsuan-Ying myoepithelial, myogenic, neural, and markers, and marked for static ALK. So the differential diagnosis, as the name indicates, should include myoepithelial tumor, as shown on the right. But these tumors are negative for most of the myoepithelial markers. And in tumors with vacuoles, they can raise the concern about epithelial hemangioendothelioma, EHE, as shown on the right. But these tumors are well circumscribed, and they are negative for CD31. And I found a similarity between some of the OGT tumors and the acral fibrochondromyxoid tumor, as John just nicely presented, given that common acral location, lobulation, myxoid stroma, and epithelial tumor cells, as well as the immune staining showing the CD34 positivity and sometimes ERG. But in my opinion, these OGT tumors are typically non-chondroid, and the ERG staining expression can be usually more limited. And for hypervascular tumors, like this tumor with OGT cited 1 fusion, with those branching vessels, it can look like angiofibroma of soft tissue. But in general, they are less vascular than angiofibroma. And this striking diffusely positive staining for CK in the FOXO1 OGT case, just one case, may raise a concern about epithelial sarcoma. But again, these OGT tumors are circumscribed, they lack mitosis or necrosis, and importantly, INI1 is retained. And other possibility might be raised, but they can usually be solved by immunostaining. So in summary, there are 4 fusion genes identified so far. And note that these 2 fusions are the results of intrachromosomal rearrangement. So a break apart of fish can fail to identify them. And interestingly, in all these 4 fusion genes, both the fusion partners contribute almost the full length to the chimeric protein product. So for example, in OGT and FOXO3, the fusion junctions are located near the 3' end of OGT and near the 5' end of the FOXO3, and which is also the case in FOXO1, FOXO4, and CITED1. So what does that tell us about the possible oncogenesis mechanism? So the OGT encodes the O-GRK-NAC transferase, which adds the sugar GRK-NAC onto the protein substrate, which could include FOXO1, FOXO3, FOXO4, and probably also CITED1. So when the nearly full length protein substrates were fused with a nearly full length enzyme, this proximity may facilitate this O-GRK-NACylation of this protein substrate, namely the fusion partners. All of them are transcription factors. And I think this may underpin the oncogenesis basis of these tumors. This hypothesis seems to have been supported by an earlier paper showing that the over-occlusination of FOXO3 can actually enhance tumorigenesis, which would require more study. With that, I want to thank you.
Thank you very much for your great talk, JC. I am ashamed to say that I was unaware of this entity, so thank you for educating me. We have time for questions if anyone from the audience is interested.
Yeah, nice talk. Thank you. Did you test any of the cases for INI1 because there are myepithelial-like tumors in vulva which are INI1 deficient? So.
One is retained in the cases that was stand for this marker. Yeah.
Anyone else has a question for JC? Yeah, David.
Nice talk, JC.
Hi, David.
Sometimes we see, I've had a couple cases that I thought were this entity, but they were international consults, and I didn't have the ability to send them for RNA sequencing. Do you think you can make the diagnosis on the H&E, or do you need, with supportive IHC, or do you need genetic testing?
Yeah, thank you. I think the tumor with OGT factor 1 and factor 3 look very similar to each other. They probably from a distinct entity. I'm not so sure about those with factor 4 or cited 1, but they share some common features as I showed you. So maybe you can suggest this, but it would be also always nice to do a molecular test. But I can do fish for you, if you like. But as I mentioned,
maybe I'll send them to you now.
Oh, sure. Yeah. Thank you.
Okay, guys, I think we will have a break now, and after break there will be 5 more talks about 5 fascinating tumors. And I can maybe tell you ahead that there will be some unpublished findings presented here today, so I'm looking forward to it. So thank you, see you at 3:20. Thank you. Welcome back, everyone. Let me start the last session. The moderators are Dr. Bharat Rekhi from Mumbai in India and JC Lee from Taiwan. Guys, it's yours. Thank you.
It's my pleasure to introduce our next speaker, Dr. David Papke from Boston, the States. The topic is GLI1-altered mesenchymal neoplasm.
Okay, thank you. And I think I forgot to thank Michal earlier today for the invitation to come here. This has been just a wonderful conference, and I really appreciate it. Okay, so I'm going to talk about GLI1-altered mesenchymal neoplasms. So GLI1 was first discovered in glioblastoma all the way back in 1987 by the Kinsler-Vogelstein powerhouse group at Hopkins. So this is an amplified gene in glioblastoma. It's not specific to mesenchymal neoplasms. Over the next 10 years, it was worked out that GLI1 is a zinc finger protein. It binds DNA and it acts as a transcription factor, and it's the end effector of the sonic hedgehog signaling pathway. And it's also amplified at some frequency in a variety of other epithelial tumor types, including gastric adenocarcinoma. So it's not specific to mesenchymal neoplasms. So I'm going to take sort of a historic approach to GLI1 in mesenchymal neoplasms. We'll walk through the different tumor types as they've been sort of described over the years. So the first description was back in 2004. These were the so-called pericytomas with ACTB GLI1 fusion. And so if we look at this series, there were 5 cases. They mostly occurred in the tongue. And if you look at the follow-up, you'll see it's entirely benign. None of these tumors recurred, none of them metastasized with good long-term follow-up. We actually have longer-term follow-up on these patients now even, and nothing happened to any of these patients. So I realized that we were sitting on this kind of interesting institutional cohort of pericytomas. So this is something that we recently went back and looked at, and we're currently preparing the manuscript now. I did this work with Kayla Elliott, who's now on faculty at Brigham, and Marguerite Carter, who's now doing a fellowship. Second fellowship. So the body site distribution of these was kind of interesting. So they have a predilection for the stomach, followed by the tongue, and then they sort of rarely occur at a range of other body sites. If we look at the morphology, so here's one of the gastric lesions. You can see this is a polypoid tumor. It's sort of involving the mucosa and the submucosa. Some other examples are mural masses. So this one's in the wall of the stomach, and it's a multilobulated tumor in the muscularis propria. If we look in the lobules, you can see that the cytomorphology is pretty uniform. The cells grow in a sort of haphazard fashion. There's this edematous-looking stroma. There are prominent vessels in the stroma. And in areas, you can see that the tumor cells sort of cling onto blood vessels, which of course is a common feature in tumors showing pericytic differentiation in general. If you look at the periphery of the tumor, you'll see perivascular proliferation of tumor cells, which again is a common feature in myopericytomas and glomus tumors as well. So these tumors are mostly positive for SMA, and it's usually pretty diffuse, as seen here. Fortunately, these mostly occur in the stomach. They're negative for markers of other tumor types that might be in the differential in the stomach. And these do stain for GLI1 by immunohistochemistry, which is something I'll talk about in more detail in a few minutes. So we were interested now looking at the genetics of these tumors and also the behavior of this larger cohort. So we found that most tumors did have ACTB GLI1 fusions. A smaller subset had other GLI1 fusion partners. And then there was a small subset, it was 3 cases, that had GLI1 amplification. So then the interesting thing is the clinical behavior of these. So most of them were indolent, didn't recur, didn't metastasize. But there's one tumor that recurred, and there's one tumor that metastasized. So let's look at this metastasizing pericytoma. It was a gastric mass. It looked just like the other ones, completely bland. I couldn't find mitotic activity in the thing. And the liver metastases 3 years later looked exactly the same. Totally bland, edematous stroma, couldn't find mitoses. But if we look at the details of this case, it had some interesting features. So this was by far the largest tumor in the series. It was 16 centimeters. It directly invaded the portal vein. So that's a worrisome feature sort of at presentation. Interestingly, so this patient had her liver metastases resected at 3 years. We have 6 additional years of follow-up. Nothing's happened. She hasn't had any other disease in those 6 subsequent years. So the one that metastasized, even in the metastatic setting, was fairly indolent. And then interestingly, this tumor was GLI1 amplified. This was one of those few that had amplification. The tumor that recurred was one of the other ones that was GLI1 amplified as well. Okay, so then the next tumor type that was described that has GLI1 alterations was gastroblastoma. This was described in 2009 by Markku Miettinen at the NIH. So this is a very rare primary gastric tumor. It has a characteristic biphasic growth pattern, which I'll show you. These occur in children and adults, including older adults, we know now. And these are centered on the muscularis propria. So they're sort of, although the name would suggest they're similar to pancreatoblastoma or hepatoblastoma, they're sort of conceptually different. They're not really arising from the mucosa or from an epithelial structure. And these are rarely metastasizing, but again, even in the metastatic setting, these seem to be pretty indolent. So there are no reports to date of patients dying of disease. And some patients have very long follow-up, even decades. So here's a gastroblastoma. It's, again, a multilobulated tumor in the muscularis propria. The lobules have this very striking appearance. So there's an epithelial component and then a spindle cell component. And they're really sharply juxtaposed to each other. The spindle cell component is sort of a nondescript spindle cell vesicular neoplasm, very bland. The epithelial component reminds me of a well-differentiated neuroendocrine tumor. It has trabecular growth and epithelioid monomorphic cells. Fortunately, these are negative for neuroendocrine markers because that could be a pitfall otherwise. And the epithelial component truly is epithelial. It expresses keratins, and as you can see, the spindle cell component doesn't. So in 2017, it was discovered that MALAT1 GLI1 fusions drive gastroblastoma. This was work done by Rondell Graham and Andrew Fulp. And they showed in the study very nicely that GLI1 immunohistochemistry was sensitive and specific for gastroblastoma among its morphologic mimics in the stomach. So we recently extended this finding to just the whole class of GLI1 altered mesenchymal neoplasms. And so we found that GLI1 was 91% sensitive and 98% specific. So we think it's a good diagnostic marker. This is work I did with Paige Perrick, who's now on faculty at University of Oklahoma. And this finding was recently corroborated by Isidro Machado and colleagues. In their hands, GLI1 was 100% sensitive and 91% specific. I think this is just a tuning issue. You know, they tuned it to be a good screen stain to catch all the cases and then to follow up with sequencing, whereas we tuned it to be very specific, and then it's a diagnostic marker, but we do miss some cases. So then, in 2016, it was discovered that plexiform fibromyxomas have GLI1 alterations in a subset of cases. So plexiform fibromyxoma, it's benign. These generally occur in the gastric antrum. They don't recur, they don't metastasize, they're entirely benign. They're centered on the muscularis propria. And these have Gli1 fusions and amplification in about 30% of cases. And interestingly, a small subset have patch1 inactivation. So of course, patch1 inactivation indirectly activates Gli1 through the sonic hedgehog pathway. Here's an example. You can see this plexiform growth through the muscularis propria. Some of these have collagenous stroma. Others have this sort of looser stroma seen here. Very uniform cytomorphology, hard to find mitoses. These usually express SMA, and it's usually diffuse, as you see here. These also express desmin in about half of cases, or maybe even a little more than that in my experience. And as you might expect, Gli1 is positive, sort of correlating with the frequency of fusions. So this is really just a morphologic diagnosis, but I just want to emphasize this is a benign tumor type that in a subset of cases is driven by Gli1 alterations. So then in 2018, there was a series that took a different angle, and this was really a seminal series. It changed the field and really accelerated progress. So this was from Dr. Antonescu's group, and they had these malignant tumors that had Gli1 gene fusions. So there were 6 tumors in the series with follow-up available for 3 patients. And if you look at those 3 patients with follow-up, they all developed metastatic disease to lymph nodes, and one also developed lung metastases. So if we look at those tumors, the one that went to lymph nodes on the left is very nested. It has a high NC ratio, almost sort of round cell cytomorphology, it seems, but very nested. The lung metastasis looks a little different. It has clear cell cytomorphology. It's sort of nested or maybe a little bit lobulated. But so there were nested tumors in this series. In 2019, Dr. Antonescu's group had a follow-on series of Gli1 amplified sarcomas. There were 10 tumors in the series. Follow-up was available for 3 patients. And 1 patient developed lung metastases, and another developed a local recurrence. So in this series, there were tumors that looked like this, very bland and nested. The tumor that went to the lung looked like this, though. So this looks overtly malignant. It's sort of spindle to epithelioid, nuclear hyperchromasia. It looks different than those bland nested tumors. And the tumor that recurred locally, to my eye, also looks overtly malignant. It has atypical mitoses, nuclear hyperchromasia, and it's not really beautifully nested. It's sort of growing in cords. So in that series, it seems that there was a range of morphologies, and some of the tumors that look like bad actors or potentially bad actors were not nested. So after 2019, there were many series on Gli1 altered tumors, often organ site specific. And among these series, there was a wide range of morphologies and clinical outcomes as well. So we decided just to look at those bland nested tumors only, just looking at that morphologic subset to see how they behave and what they are. So we called them nested glomoid neoplasms, just to give them a descriptive term. And so these generally occurred in somatic soft tissue sites, so the trunk and the extremities, followed by the tongue in 4 cases. And this is different than that body site distribution I just showed you for the pericytomas. Those had the striking predilection for the stomach and didn't occur very often in the limbs or the trunk. Here's an example of one of those nested glomoid neoplasms. So you can see it's a beautifully lobulated tumor. It looks very similar to the one that Abbas showed yesterday. The lobules are separated by irregularly thick fibrosepta. And then within the lobules, there are these small nests of neoplastic cells that are separated by this fine capillary network. If you look at the periphery of the tumor, you can find perivascular proliferation of tumor cells, including little lobules of tumor cells bulging into vascular lumina. This looks just like that glomus tumor picture I showed you earlier today. Some examples have a bit more stroma between the nests, and those actually start to resemble well-differentiated neuroendocrine tumors a little bit more, so that's another potential differential diagnostic consideration. And Gli1 works quite well in these tumors, so you can see here it really nicely highlights the lobulated architecture of this case, and within the lobules it highlights the nested growth pattern. So we found that these tumors expressed S100 in about 20 to 30% of cases. And we found that they were uniformly negative for SMA, which has been true in most of the other series of Gli1 altered tumors too, and seems to be different from those pericytomas that I showed you earlier. The genetics of these were more of a mixed bag, so some of them had GLI1 rearrangements, including a few cases with ACTB GLI1 fusion, but that certainly didn't predominate in this cohort. And 6 tumors had GLI1 amplification. If we look at the behavior, so these behaved in an indolent fashion. 4 tumors recurred locally, but usually with long intervals, and they kind of were slow-growing local recurrences. We had no metastases with pretty good long-term clinical follow-up. And 4 of these tumors actually have been present for quite a long time before they resected, even 10 years in a couple cases. So overall, this cohort behaved in a benign fashion. If we look at the mitotic index of this cohort, most of these tumors had very low mitotic indices, but there is this one exception out here at 28. And that tumor was the one tumor that recurred rapidly, and that tumor was GLI1 amplified. So since our paper came out, we've been recognizing these malignant counterparts to the bland nested glomoid neoplasms that I just showed you, and this is one of them here. This is a femur tumor. It's nested. It has a rich capillary network, but when you look close, it has significant cytologic atypia and a lot of mitotic activity, and this tumor gave rise to lung metastases at 2 years. So this tumor was very large, and like the other ones that behave badly, this one is GLI amplified. So this is all leading up to a very nice paper that came out last year from Dr. Antonescu's group, where they did a very comprehensive literature review and also presented a series of new cases where they found, so here's a survival curve. In red are GLI1 amplified tumors, and in blue we have the rearranged tumors. And you can see that the GLI1 amplified tumors are killing patients. They're dying of disease, whereas the rearranged tumors, even in the metastatic setting, are relatively indolent. They also proposed these criteria which seem to track with our cohort as well, where you can just use standard criteria, mitotic count and tumor size, to risk stratify these tumors into low-risk tumors and high-risk tumors. So what's the current state? So I think that there are some clinical pathologically distinctive tumor types with GLI1 alterations. For example, plexiform fibromyxomas occur in the gastric antrum. They're benign. These nested tumors have a range of behavior and tend to occur in somatic soft tissue sites. The pericytomas tend to occur in the stomach, and they also have different staining patterns and somewhat different morphologies. It does seem like we're heading toward risk stratification in these tumors. And probably the GLI1 amplified tumors, they are certainly more aggressive, and possibly those should all be considered sort of malignant, even if they look relatively bland. Okay, so with that, I'll thank you for your attention. I'm happy to take questions.
Thank you, David. That was very nice. Are there any questions or comments? I think we have plenty of time.
I picked a controversial topic. I was expecting questions. Peter doesn't disappoint. Thank you.
Now, I was just curious why you use the term nested glomoid instead of calling them GLI1 amplified. I think it just confuses people rather than makes it easier to understand what's going on.
So I think there are a couple of different sort of approaches. I actually think it's, so one thing that we're doing in our study is we're trying to learn whether the pericytomas sort of have the same type of risk stratification. It seems like preliminarily they will, in which case, if all the tumors, regardless of the morphology, if you can use the same criteria to predict their outcomes, then I think it would be fine to just all call them all GLI1 altered mesenchymal neoplasms. But I would make the comparison to myopericytoma and glomus tumor, where those tumor types are on a biologic spectrum. They have overlapping genetics in some cases, but they look different from each other. And when you're learning to recognize them, you learn about them sort of as distinct entities to facilitate recognition. So I do think giving them a descriptive name that reflects their morphology actually does help facilitate recognition. But I think both approaches could be valid.
All right, I'm going to ask a question on behalf of myself and audience. So since GLI1 and MDM2 are so close, and when one is altered, sometimes the other one's altered. So in your opinion, how do you think we can tell a GLI1 amplified tumor from an MDM2 amplified tumor?
That's a very interesting question. So, in our GLI1 IHC study, we looked at a bunch of dedifferentiated liposarcomas that co-amplified GLI1. And I kind of thought that they were going to mostly be positive. But it turns out that only 1 or 2 were positive. And I think it has to do with the antibody titer. I know in Isidro Machado's study, proportionally more of them were positive. But we titered our antibody to be very specific for tumors driven by GLI1. So yeah, we've had a bunch of tumors, people have even sent tumors to us because we have the antibody, and they said, oh, we found amplification of MDM2, GLI1, some other genes. Is this a liposarcoma? Is it a GLI1 amplified spindle cell sarcoma? And GLI1 is generally negative in those tumors, the liposarcomas.
Hello. I have a practical question. In your practice, do you still use the GLI1 immunostain regularly, or do you send all straight to the molecular testing?
So right now we're using the immunohistochemical stain. I think in part because of the nature of our consult practice, we're not able to do molecular testing in all of our cases just from a sort of volume standpoint. For in-house cases, we have sent some for sequencing, but probably not consistently. The immunostain is very specific, and especially when you take into account the morphology and other, other staining results you have on the tumor, I think that's sufficient to put it in this class. Whether you need to demonstrate if it's rearranged or amplified, I think is something, something we may be heading toward right now, in which case then molecular testing, maybe even FISH testing for MDM2 or DAD-IT3 as a surrogate, may be another approach.
So thank you, David. In the interest of time, we'll move further for the next talk by Raul Perret on pseudoendocrine sarcomas, a new emerging provisional entity. Raul.
Thank you for the introduction, and David made me realize that also I didn't say thank you to Michael and Professor Michal for putting up together this wonderful meeting and for inviting me. I'm really honored to be among such a big amount of experts. So, pseudoendocrine sarcoma have no conflicts of interest. This is an emerging entity, initially described by David Papke and Dr. Fletcher. I actually, while revising my review yesterday, I realized that I actually put the wrong number of cases because there are less than that currently reported. We have there's actually 27 currently reported. What we hopefully will publish a series soon with 7 additional cases. I pulled the information that you will see in this presentation is pulled from all the cases that have been published and haven't been published yet. Okay, and this is a collaboration we have ongoing with several experts, including Michael. So this name, which is a really good name and catchy, it comes because this tumor has a neuroendocrine-like morphology, but it doesn't have a neuroendocrine marker expression, okay? And it generally affects adults in most cases with a median age of 63 years, and it shows a male predominance, as you can see, slight male predominance. It frequently arises in paravertebral locations, and it has the potential for local recurrence and metastatic spread. So as you can see, this tumor really shows a really particular predilection for paravertebral soft tissues, which is quite striking. Almost 73% of cases that have been reported that have been located in that place. Here are some radiological findings of our unpublished series. You can see the paravertebral lesion, which is quite big in this case. It shows some calcifications, and it's also destroying the lateral aspect of the vertebra. Some images of the gross findings of one of the lesions that you can see is pretty lobulated and flesh. It has a fleshy aspect, some hemorrhagic areas. On histology at very low power, generally these lesions will be relatively well circumscribed, but they tend to show infiltration of the surrounding soft tissues with like tongue-like projections,
as you can see, this is something that you can find. Or angioinvasion is something that you can see also sometimes. This is illustrating the typical architectural findings that you will see in the upper left panel. You see that this proliferation is composed of sheets of small to medium-sized epithelioid cells with pale eosinophilic cytoplasm and round nuclei that are extremely homogeneous, extremely uniform. Sometimes the cells will arrange in islands, if you want, and frequently we'll have like small capillaries at the periphery that can reminisce a neuroendocrine, a carcinoid tumor, for example. Frequently, you will also find extracellular hyaline material, as you can see here in this area. This can be more or less abundant. And also a frequent finding is the presence of fibrobascular or fibrohyaline cords and septa that divide a bit the neoplasm that traverse the neoplasm, yeah. Here, just a really high power view to see the characteristic of the cells. As you can see, they are medium-sized, epithelioid. You tend to not see correctly the cell borders, and the nuclei have like a really uniform morphology. There's no pleomorphism, and the chromatin is tends to be speckled. It's really similar to an neuroendocrine tumor. Here are some of the other findings that you can find in a subset of cases. Calcifications that can be heterogeneously distribution on the left, also like Samoma body calcifications. Frequently, you will also find hemorrhage and sheets of foamy histiocytes. And on the right side, you will see areas that are rich in myxoid stroma and that show kind of a microcystic pattern that you can see sometimes in this tumor. Other findings on the left, you will see a pseudoglandular architecture. This is most likely an artifact related to hemorrhage, I think, and the poor cohesiveness of the tumor cells. Chordal architecture, and you also, that hasn't been reported yet, but we have cases, a case in our series that show actually true pseudopapillary architecture, as you can see on the right side, lower part of the, if I can make, sorry, there. Okay. So again, some of these markers we have haven't been reported yet. There's not a lot of data on these tumors in the literature. They are consistently positive for nuclear beta-catenin, have an aberrant expression of nuclear beta-catenin. They also express diffusely CD56 and GLUT1 in our experience. They are variably positive for S100, desmin, C34, CD99. Brachyury also is something that we found focal expression in our cohort in a subset of cases, although I have to mention that this was not consistent with every brachyury clone. It seemed to be that some clones were not detecting the protein. And also we had a case with positivity with androgen receptor. Most importantly, these are uniformly negative for keratins, for SOX10, for most specific neuroendocrine markers, as you can see here, smooth muscle actin, myogenin, and progesterone receptors, even though some of the markers haven't been tested extensively, as these are so rare. So this is just to illustrate what you see in general in this tumor. No pankeratin. Desmin tends to be focal. S100, in our experience, tends to be quite diffuse, but it can be focal. CD56, beta-catenin, the brachyury of one of our cases, GLUT1, androgen receptor, and progesterone receptor. So at the molecular level, these tumors are characterized by recurring CTNNB1 mutations at exon 3. So far we haven't found any gene fusions, And as you can see in an array CGH here, they generally tend to show like a flat profile without significant copy number variations. So what about the clinical behavior and prognosis? So far, local recurrences have been seen in about 30% of cases, and 22% of cases show metastasis at the lungs, liver, and lymph node. However, we haven't seen yet death of disease. In general, the primary treatment is surgical excision. We have had a case in our series that show response to radiotherapy, like quite dramatically, it reduced from 6 centimeters to 3 centimeters. We don't know if this is just an isolated case or maybe these are really radiosensitive. And there's so far no documented case with response to radiotherapy. So the differential diagnosis is broad, but in general as you can see here, so it includes neuroendocrine tumors, paraganglioma, carcinoid, several mesenchymal tumors, and also it includes other tumors like solid pseudopapillary neoplasm of the pancreas, or even neurocytoma if you want to include things that can resemble morphologically. So the important point I want to make is that the clinical and morphological features of pseudoendocrine sarcoma are very distinctive, or seem to be very distinctive, and IHC should be used mainly for ruling out the differentials. And so I give you like a panel, like a proposed panel that you could use, but they are quite distinctive of morphology. So just to show you some of the differential diagnosis, glomus tumor can be similar on cytology, but these tumors tend to have like conspicuous cell borders and a prominent vasculature, and they tend to be SMA positive, which is not a frequent finding in pseudoendocrine sarcoma. Gli1 tumors have epithelioid to spindle cells with a lobulated architecture with fibrous septa and have Gli1 alterations. And round cell sarcomas are like, in general, for CIC and B-core, they tend to show more higher pleomorphism than pseudoendocrine, and you have immunos that can be helpful too for ruling out if necessary. So pseudoendocrine sarcoma is kind of a new kid on the block. So when do I think about it, or when to make the diagnosis? Generally, it's when you see like a tumor with neuroendocrine-like morphology, but with a disappointing immunophenotype, just expression of C56, that is not like specific. Paravertebral location, and of course, exclusion of mimickers. That will be like my approach. So, and just for the last part of this talk, as I mentioned, this entity was initially described by David and Dr. Fletcher, and actually wanted to discuss some nosological insights that our research has brought up. So these tumors were classified as sarcomas due to location in somatic soft tissue and lack of definite line of lineage of differentiation, and because they had metastatic potential, that is, they are classical definitions of what a sarcoma is. However, it has become evident for us and other groups which collaborated with us that pseudoendocrine sarcoma can show significant overlap with solid pseudopapillary neoplasm of the pancreas, including close morphological features, immunophenotype greatly, and we also had some gene expression data on total RNA sequencing and methylation profiles that, even though like the cohort is small yet, as you can see, for example, on the TSNE visualization of methylation data, we had 3 cases of solid pseudopapillary neoplasm of the pancreas, and 4 cases of SPNP and 3 cases of pseudoendocrine sarcoma, and they're forming a common cluster. This was also confirmed by hierarchical clustering. As you can see here, that they show a really overlapping, very overlapping signature, at least on the analysis that we did, which is preliminary because we are still working on additional tests. And as you can see, we compare them with other tumors like chordoma or whatever, and they are not overlapping with those. So what I think this points out is that these two tumors may have a likely common cell of origin, and maybe this could be a primitive cell like the neural crest cell, which could explain the distribution of the tumor and several other findings. But on the other hand, I want to remark that pseudoendocrine sarcoma and SPNP have significant clinical differences which warrant their distinction. So SPNP has a clear predominance in females who tend to be young, and metastatic potential and recurrence is generally less than 10%. And they really generally occur at the pancreas or in other regions in the abdominal cavity. While pseudoendocrine sarcoma seems to show a similar age distribution, it affects older patients, it appears, and it has a higher tendency for metastatic spread and recurrence. And the anatomic distribution, once again, is different. So this is like an open question. I don't have the answer. But how should these findings be integrated in the classification of SPNP and pseudoendocrine sarcoma? Should we acknowledge it with a nomenclature modification? Should we call it pseudoendocrine neoplasm? Should we call solid pseudopapillary sarcoma of the pancreas, or none of the above? I think this is something that needs consensus, like it really needs discussion and additional studies in the future. Okay? Thank you very much for your attention, and I'm happy to take any question.
Any questions? Yeah.
Thank you very much. Just a brief question. You said there are 27 cases published now. So there are two publications, or only the one from David?
No. There's the one from David, and there's case reports. Mostly, yeah.
And what about the series that you talked about, the 7 additional ones? When is this going to come out? I'm just asking because this is quite important for the new WHO classification, because the definition is that no new entities should be included that are defined only by a single case series, which is probably in this point pretty stupid, but it would be probably a good argument if the next case series would come out quickly.
But it doesn't depend on us, we are waiting for, we have the reviewers which suggested some.
So you submitted it already?
Yes, you submitted. It's waiting for major modification or review or whatever. We're trying to. Hopefully it will pass, but nothing is sure.
That should suffice.
Thank you. Very nice study that you're looking at. We actually had a case that we presented at the International Skeletal Society, and we've also published it. And so we found that the breakpoint is different from that found in fibromatosis for the CTNNB1. So did you find also similar breakpoint to what's been described already in the literature or in our paper?
Yeah, they are not the same in general as in desmoid fibromatosis. Yeah, I think there were some additional ones that were not described. We have the mutation for the 7 cases, so yeah, I think there are some that were not described.
Okay, thank you, Raul.
Thank
you. Now let's move on to our next speaker from Mumbai, India, Professor Bharat Rekhi, and his topic is FET CRAB fusion-associated neoplasms.
Good afternoon, everyone, and at the outset, thank you, Michael, for inviting me for this very prestigious and wonderful meeting, and really pleased and happy to be here. And the topic you've assigned me, I think I would start by saying, as one of my colleagues in another state says, fusions causing confusion. But I think for the first 2 rows, the faculty, I would say this is an evolving spectrum of these tumors. I have nothing to disclose as I move further. and sort of reflect my talk through two cases that I came across and learned the spectrum of these tumors evolving. Patient number one was a 32 years old lady with a tumor in her deltoid region. You can see a large sizable mass, about 7 centimeters. It's the axial view of the MRI showing the post-heterogeneous enhancement in this particular tumor, so looks very worrisome. And this was a recurrent tumor referred with a diagnosis of neuroblastoma. And you can see the microscopy mirrors towards what we are seeing. This tumor in the subcutis, pretty nodular in its appearance, and with this very blue cell areas and these frankly areas of necrosis. So high magnification showing these monomorphic cells in a sheet-like pattern, kind of giving an impression of a neuroendocrine appearance to this tumor with a heterogeneous chromatin pattern. A nondescript sheet-like pattern is seen in this particular tumor. And then I come to case number patient 2, who had this tumor in the mesentery, a 16 years old young male, and this was an initial biopsy. Again, we see a round cell tumor, but what is a nuanced difference in this particular case is that we see more sclerosis in otherwise this malignant round cell tumor appearing. And after a diagnosis, this tumor was resected, and you can see it's not too different from the first tumor that I shared with you, showed you, and you see again this very monomorphic round cell tumor with this heterogeneous chromatin and this very delicate collagen traversing through the entire tumor. Pretty shaded pattern of this, this tumor, not too different from the first case that I showed you. So this brings me towards, the talk that I've been assigned about the PHAT family of fusion oncoproteins that are encoded by 3 genes, that is the Ewing sarcoma RNA binding gene and 22q12.2, we all know that. And then we have the fused in sarcoma, as we call FUS gene at 16p petite, and then TAF15 Tata box binding protein. That's purely coincidental that I'm talking about this. What I'll be focusing further is about the fusions between the PHAT or TET genes with the CREB family of transcription factors. And what are these? These are 3. In 3 different types, the CAMP response element binding protein, the CREB. Then we have the CMP response element modulation protein, CREM, and the ATF, the activating transcription factor 1. And the tumors characterized by this PHAT-CREB fusion is expanding. We've known classically the example as angiomatous fibrous histiocytoma. It's hardly a sarcoma. It's an intermediate malignant tumor characterized by classically EWSR-CREB in about 90% cases, and followed by EWSR ATF fusion and also the FUS ATF fusion. The other tumors that we know and have known is sclerosing epithelioid fibrosarcoma, characterized by EWSR CREB 3L1, 2, and 3, and these sort of form a morphological continuum with the lower end of the spectrum towards with the low-grade fibromyxoid sarcomas that are characterized by the FUS rearrangement with the fusion. So the tumors which are hybrid between the LGFMS and SCF invariably display the FUS rearrangements. Then we have something high grade. We all know that clear cell sarcoma of soft tissues is a pretty high grade malignant tumor, doesn't respond to any chemotherapy, and very aggressive. And it's again characterized by a similar EWSR ATF fusion in about 90% cases. Then we have the malignant genet characterized by the EWSR CREB, and you can see this list of several publications, and it's just enormous. As I'm talking also, I think somebody's making a manuscript on these particular tumors, or maybe it's in proofing. So the other tumors that we know are peritoneal-based mesotheliomas, the EWSR FUS ATF1, and the newly described inflammatory nested testicular sex cord tumors. We also have intracranial myxoid mesenchymal tumors, primary pulmonary myxoid sarcomas, hyalinizing clear cell carcinomas of the salivary gland, completely kind of unrelated tumor carcinoma, clear cell odontogenic carcinoma, and the evolving EWSR CREM ATF positive sarcomas of the soft tissues, which have been reported in abdominal as well as now in the extra-abdominal sites. And you can again see several references alluding to these various entities. And just to bring towards, the 2 tumors, one is hardly a sarcoma, which is the high-grade sarcoma, the AFH, characterized by the same fusion and the EWSR with the CREB fusion. What we see in addition in this beautiful paper is that the TERT promoter and the CDKN2A connote a more aggressive, the mutation in the CDKN2A connote a more aggressive, the form of the clear cell sarcoma. And the tumors in in the category of the AFH, which actually metastasize. In addition to the classical fusion that they have, they also have the CDKN2AB homozygous deletion. So there are additional events that connote a more, sort of parallel behavior in these otherwise two different tumors in certain scenarios. And again, coming back to my case where I left, you see this fibromyxoid stroma with this separating these tumor nests. Certain nests, again, we see this in this very typical fibromyxoid stroma. And when I'm showing you this to bring the analogy toward these, many of these tumors showing these overlapping morphological features. And I like that quotation which Abbas says, every genotype reflects a certain phenotype. And it's interesting to see how some of these tumors show a morphological overlap. Again, looks very neuroendocrine. It was understandable that it was neuroblastoma morphologically, but clinically you don't consider neuroblastoma in an adult patient. So we resorted to immunostains, and yes, it was positive for synaptophysin, and it tells about, that this could be a neuroectodermal or a neuroendocrine tumor, but it failed chromogranin that I rely to call something as neuroendocrine. So the other stains that came positive were CD56, and it was negative for the keratins. The other differential diagnosis worth considering in a case like this, considering its superficial location, is Merkel cell carcinoma that I thought. It was negative for CK20. Superficial Ewing sarcoma, even though it's synaptophysin positive, it was negative for the NKX 2.2. And there was a thought to consider perhaps this could be an undifferentiated round cell sarcoma, could be neuroectodermal. And neuroblastoma was ruled out based on the age and also negativity for chromogranin. So simultaneously, this tumor was triaged for EWS-SAR1 and it was completely rearranged, and kind of, worried that perhaps are we dealing or missed out on any Ewing sarcoma. But it failed the fusion partners, the ETS, that's FLY1, ERG, and WT1 also. And one NGS, it showed the ATF1 fusion. So I have to thank Abbas for triaging and a good discussion about this case that we had. And this just goes to show about these tumors described in the abdomen, classically by Akihiko Yoshida and Abbas Agemi, about these fusions characterizing these tumors, including AFH, which generally has the CREB and ATF. So it also has EWSR-CREM fusion positivity. And two unclassified tumors included one with a sclerosing epithelial fibrosarcoma-like appearance, including MUC4 positivity, that I'll come to the next case as I go further. And you can see again the two cases again described by Abbas about these particular tumors in the abdomen and emphasizing these as the emerging entity. So this led on to us to collaborate with the other, the experts and forming the series of the EWSR ATF fusions characterizing extra-abdominal epithelioid tumors looking like sclerosing epithelial fibrosarcomas and characterized by these fusions. And that's one example. I have to thank Josephine for Dr. Dharmavan for collaborating on this, and this shows this very peculiar papilloid formation, and I'll come to that in a moment. Why? Because you see again this little pattern, this peculiar pattern in other tumors that I will share with you. So this was the second tumor that I was referring to with more round cell morphology, more sclerotic pattern, and this is the initial biopsy, not a very pleasing MUC4, granular to bit smudgy. And post-resection, you can see, frankly, a very high-grade areas with necrosis. This was diffusely positive for MUC4. And it was also for EWSR. So you think that this could perhaps be a sclerosing epithelial fibrosarcoma. So this is, again, the series of the extra-abdominal and intra-abdominal FET-CREM fusion-positive neoplasms, which recently hot off the press of 9 cases, again, described by Dr. Gaimi. And coming to another different tumor that we've known actually in sites like the intestine, you see this very typical round cell morphology with the papilloid pattern that I was referring to in the second case, in the case which was by Dr. Dharmavan, and it shows similar morphological appearance towards, and this is actually a GNET, we know that, malignant GNET, diffusely positive for S100 and negative for the melanoma markers, and showing EWSR1 gene rearrangement. Another tumor with this overlapping morphology between a sclerosing epithelioid and years back when I went to Mayo and Dr. Oliveira tested this case for first gene rearrangement positive, and this was a hybrid between a low-grade fibromyxoid sarcoma and a sclerosing epithelioid fibrosarcoma. So we've seen sclerosing epithelial fibrosarcoma as an unusual sites, and we know that this also exists in the GU tract. That's the kidney tumor in a 24 years old female. You see this very sclerotic pattern, polygonal epithelioid cells, a very classic morphology for a sclerosing epithelial fibrosarcoma, and reinforced with diffuse MUC4 staining pattern. Showing EWSR rearrangement. That was years back when we were writing and compiling our series of the angiomatoid fibrous histiocytomas, and you can see this very interesting example that we came across, not showing those ectatic dilated spaces, but you see this very typical lymphoid collar, in this particular example with this more solid areas composed of these round to polygonal cells with this myxoid stroma. And that's similarly what we see in these intra-abdominal mesotheliomas characterized by these particular fusions. So this case example was positive for the EWSR Krebs fusion. This was an angiomatoid fibrous histiocytoma that we called at that point in time. Finally, wrapping my talk with an interesting case example. Of late, I came across from the head neck colleagues towards trying to differentiate whether it's a mucoepidermoid or a clear cell hyalinizing carcinoma. And we see these, the epithelioid cells. Of course, it's a very obviously looking carcinoma, but you see that fibromyxoid stroma. And it was positive for CK740, P40, and P63, reinforcing, the epithelial differentiation, which morphologically it has. And further, it was EWSR rearranged, so it was a hyalinizing clear cell carcinoma. So to conclude my talk, I think PHAT Krebs fusion drives several diverse neoplasms, including soft tissues and sarcomas as we know them. They're evolving. It's important that we realize and know, and there are overlapping morphological features with the tumors characterized by these fusions. In some ways, it's important, like in any for molecular test, to interpret in a clinicopathological context, and perhaps additional genetic events will help us in knowing the clinical behavior, which could be certain aggressive tumors over the others for these other diverse neoplasms. Thank you very much for your attention.
Thank you, Bharat, for your nice presentation. Are there any questions or comments?
Any questions?
Okay, thank you, Bharat, again. So let's move on to the next speaker, is myself.
So I'm happy to introduce the next speaker, my co-chair for his talk on inflammatory abdominoplastic tumor, pulmonary inflammatory leiomyosarcoma. Dr. Lee.
Thank you, Bharat. My second talk today is about another niche type tumor called inflammatory rhabdomyoblastic tumor. And I will also touch on the so-called pulmonary inflammatory leiomyosarcoma as well. So if you read about the inflammatory rhabdomyoblastic tumor, IRMT, inflammatory leiomyosarcoma, IRMS, and histiocyte-rich rhabdomyoblastic tumor, HRMT, and you're kind of confused, this is for you. At least I will try. So I would like to start with Michael's really nice paper about inflammatory leiomyosarcoma. So the tumors tended to be intramuscular. They are well circumscribed, as you can see here. And as you can see here, is a really well circumscribed, a well circumscribed tumor with kind of a fibrous capsule. And here you can see lymphoid aggregates near the periphery. And the tumor cells are usually eosinophilic spindle cells, or sometimes more epithelial. And there are some nuclear polymorphism or atypia. And there are quite some inflammatory cells, usually lymphocyte, plasma cells, and histiocyte. And there are some multinuclear giant cells as well. And also can be seen striking features of clusters of foamy histiocytes, and sometimes also calcification. And despite all those nuclear atypia and even polymorphism, there are very few mitosis. And desmin tends to be diffusely positive, and while CD163 can stand a lot of histiocyte, more than you expect. Then SMA and MSA and caldesmon of some clone can be positive in a subset of cases. And the concept of inflammatory leiomyosarcomas was actually first proposed by Dr. Fletcher back in 1995 in a series of 12 cases of what could have been otherwise diagnosed as a so-called inflammatory MFH. On the basis of the expression of desmin and or SMA in all of the cases, while the skeletal muscle myosin staining tended to be negative. And as you can see here, the mitosis and necrosis were quite variable. And later, Paula Dachin identified a distinct karyotype pattern known as a neohaploid pattern in 2 cases of inflammatory leiomyosarcoma, including one previously diagnosed as MFH, which also harbor genomic doubling. So here is the karyotype. So you can see here, most of the chromosomes retain only 1 copy, while a handful of chromosomes, including chromosome 5, 18, 20, 21, and 22, remain 2 copies. So it turns out that this very distinct pattern of a near haploidization is quite characteristic of the so-called inflammatory leiomyosarcoma, if you check it. And so which almost always retain heterodisomy of a chromosome 5 and 22, and sometimes also chromosome 18, 20, and 21, while the remaining chromosomes are usually just lost 1 copy. And sometimes the neohaploid genome could undergo doubling and become the so-called hyperdiploid. And while most of the chromosomes, while they are, despite the 2 copies, they are actually uniparental disomic, which can be nicely shown by a copy number variation and SNP array, such as OncoScan. As you can see here, the chromosome 5, 12, 20, and 22, their copy numbers are roughly double those of the other chromosomes. And you can see here, these chromosomes tend to retain the heterozygosity, while the other chromosomes show loss of heterozygosity. And Dr. Node et al. And found that inflammatory leiomyosarcomas are distinct from ordinary leiomyosarcoma in terms of a gene expression profile. And later, importantly, the Lund group first identified the significant upregulation of a bunch of rhabdomyoblastic markers. And this challenged the very designation of leiomyosarcoma. Maybe they are instead rhabdomyoblastic tumor. But somehow they stopped there without providing any immunostaining evidence of expression of rhabdomyoblastic markers such as MyD1, myogenin, and PAC7. Then Dr. Forbes' group published a new entity called histiocyte-rich rhabdomyoblastic tumor, HRMT, and it looked like this. So it's a well circumscribed. You can see a calcification here and peripheral lymphoid aggregates. There are a lot of forming histiocyte, 210-type giant cells, and a lot of rhabdomyoblasts, positive for desmin and limited MyD1 and myogenin. I found this paper a little bit confusing to me because they look like inflammatory leiomyosarcoma to me. And back at this time point, we already knew that the inflammatory leiomyosarcoma can express at RNA level a bunch of rhabdomyoblastic markers. So maybe these so-called HRMT are actually just inflammatory leiomyosarcoma. Then came Michael's nice paper, which was actually the first paper to show by IHC the expression of these rhabdomyoblastic markers, MyD1, myogenin, and or PAC7 in IRMS. So maybe you can call it HRMT as well with that rhabdomyoblastic marker expression. I hate to say this, but Michael, you did screw up those SNP array. So we did not have a case with confirmed neohaploidization showing IGC evidence of a rhabdomyoblastic marker. So I decided we can do it. So I managed to collect 4 cases. And all of them are morphologically compatible with IRMS, but all of them express MYD1 or myogenin by IgC. And we did this kind of training fish study showing that the copy numbers of these chromosomes roughly double the other chromosomes. And then we invested in an expensive OncoScan. We're able to show near haploid genome in 3 of the 4 cases. So basically, we confirmed that near haploid inflammatory leiomyosarcomas actually usually express MYD1, myogenin by IgC. So we saw this a solid piece of evidence to support that HRMT roughly equal IRMS. So we were really excited. We wrote the paper. We thought we were the first to confirm it. And we saw Dr. Folk publish their paper first. Yeah, so it's a mixed feeling. And together, we used very similar approach and showed that both HRMT and IRMS are clinically and morphologically similar. They frequently express MYD1, myogenin, PAC7 by IgC, and they are frequently near haploid. So here's the thing. Since HRMT are like the same thing with IRMS clinically, pathologically, and genomically, they are probably the same thing. But since IRMS express those rhabdomyoplastic marker and they have an indolent course, which I will touch on later. So maybe we shouldn't call it IRMS, leiomyosarcoma anymore. So Dr. Folk proposed this term, inflammatory rhabdomyoplastic tumor, IRMT, and we agreed. So in summary, the so-called IRMT, there are about 90 cases reported so far, and about 2/3 were men. But if we focus on those with confirmed neohaploidization, there are 39 cases, and there are even more prominent male predilection. The median age is 41 years, and about half the cases occur in the thigh. And interestingly, at least 1/3 were associated with NF1 mutations and or type 1 neurofibromatosis syndrome. So in summary, those IRMT with typical morphology and the near haploid genome are encapsulated and if sometimes focal infiltrative. They have a lot of histiocytes, including foamy histiocytes, spindle histiocyte, and Tuton-type giant cells. And there are a lot of lymphoplasma cells, sometimes forming peripheral aggregates. They can sometimes be calcification. And the tumor cells are eosinophilic spindle to epithelial cells. Despite the frequent nuclear atypia and even primorphism, there are very few mitosis, and necrosis is very rare as well. And they tend to be diffusely positive for desmin, while MYD1, myogenin, PAC7, and SMA are more variable. And it's noteworthy that if you use the most specific clone, HCD, caldesmon is almost always negative. So as a group, there are low-grade tumors following benign courses. And here's a case I came across previously. It's a 59-year-old male with a huge retroperitoneal tumor. And the CT-guided biopsy was performed and showed atypical eosinophilic spindle cells in like fascicles mixed with some inflammatory cells. And as you can see, there are some maybe foamy cells here. It's not very numerous. And you can appreciate that there is these foamy cells. And there are at least a nuclear atypia with hyperchromatism and prominent nucleoli, and a notable absence of mitosis. There's no mitosis at all in this small biopsy. So we think this is a very important clue to support the possibility of IRMT. And the diagnosis was supported by the immunostaining and our draining fish studies. So we diagnosed this as probably IRMT from this small biopsy. So should we just suggest follow-up and wide excision as well, because I told you they are quite indolent tumors, right? Turns out this patient developed multiple lung metastases, and a wedge resection showed highly polymorphic sarcoma and a lot of atypical mitosis, as well as focal necrosis. The Desmin remained positive while the mild D1 staining became more limited. The P53 staining showed a signature pattern. And whole exome sequencing showed a near haploid pattern with some arm-level changes, as well as some additional gains and losses. And there were NF1, TP53 mutations, as well as CDKN2A and B deletions. And here's another case. Is a 38-year-old female with a retroperitoneal tumor. You can see on the left, the primary tumor looks just like a very typical example of RMT, whereas the rapidly recurrent tumor appears almost like a small round cell sarcoma. And interestingly, MSH6 is actually lost in this tumor. So both tumors represented a phenomenon reported by Dr. Pope as an IRMT with progression to high-grade rhabdomyosarcoma. So it's actually just areas of a typical RMT with area of a high-grade sarcoma with additional copy number gains and losses. So I managed to collect a full case again with RMT with sarcomatous transformation. You see 2 people died. And so what I cannot do with these cases, so I wrote an email to Dr. Fope, and I say that, hey, Andrew, I have 4 cases of IRMT with sarcoma transformation. I wonder if you have more cases so we can compile them for a nice series. He said, well, I had 6 cases, but our paper has just been accepted. Yeah. So it's him again. But he did forward me the pre-proof. Nice. And I think the first author is Kalina. Nice paper. Congratulations. You did have 6 cases, and 5 of them already developed lung metastasis. So these tumors are quite nasty. So this progression came in 2 major patterns. The first one, the typical area of RMT, is alongside with a high-grade rhabdomyosarcoma area. And this tumor developed a cellular nodule of small monomorphic rhabdomyoblast with diminished histiocytes. And the metastatic tumors can appear, can look like undifferentiated spindle cell sarcoma, or they can be composed of a uniform rhabdomyoblast surrounded by histiocytes. So in summary, there are about 14 confirmed cases of rhabdomyosarcoma arising in IRMT, including our unpublished cases, and that will account for about 36% of all confirmed near haploid tumor. And at least 10 patients have lung metastasis, usually to the lung, and at least 4 have died of disease. And they usually remain Desmin positive, while mild D1 and myogenic can become more limited. There are usually additional copy number alterations or mutations enriched for TP53, CDKN2AB, or perhaps MMR genes. So I urge you to read a very nice review article by Michal. It's very informative. And finally, I'd like to touch on the so-called inflammatory leiomyosarcoma in the lung. So there are a group of cases diagnosed as inflammatory leiomyosarcoma. They occur in a relatively young man, and most of them are mostly from the East Asia. So I think most of you in the room doesn't have to care. And this tumor are diploid tumor, and they follow benign courses. So there are well circumscribed tumor, usually yellowish or gray-white. You can see they are well circumscribed and sometimes with a sclerotic margin, and they are sometimes endobronchial. Oh, I forgot one thing. Some of them are smoker. Okay, So they look like a blend-looking spindle cell mixed with some foamy histiocyte. And look at that cigar-shaped nuclei and eosinophilic cytoplasm. They look like smooth muscle cells. And there are a lot of inflammatory cells, including lymphocyte plasma cell and foamy cells, sometimes also eosinophils. Also can be seen include the Tutan giant cells, and sometimes you can see up to moderate nuclear TP as well. And all the cases have been positive for desmin, at least focally, and some of them are also focally positive for SMMHC. And SMA and codesmon are mostly negative. Importantly, they are negative for MYOD1 and myogenin, and they are also negative for ALK and HMB45. So as I mentioned, they are diploid tumor. So the so-called pulmonary inflammatory leiomyosarcomas, unlike their soft tissue counterpart, they showed no rhabdomyoplastic differentiation. So they are probably distinct from the IRMT or IRMS of a soft tissue. And given that partial smooth muscle differentiation and benign clinical course, we found that not very appropriate to call it inflammatory leiomyosarcoma. So the reviewer of our paper suggests we create a term of our own. So we proposed a term called low-grade inflammatory myeloid tumor. It's not super fancy, sexy, but at least we tried. So with that, I want to thank you.
Thank you, Dr. Lee. Any questions for Dr. Lee?
Well, thank you, Dr. Lee, for the wonderful talk. For your last entity, the so-called inflammatory myotumor, are they either positive? I'm just wondering, given the Asian predilection, are they positive for EBV? Thank you.
I just have a comment. This is my most favorite tumor of all. Not only because it looks interesting, but mainly because of the amazing story behind it. Because I think it nicely shows how actually science works. Like there is a bunch of groups publishing about these neoplasms, and everybody was partially right, partially maybe wrong, or something was missing in those papers, and each group complemented each other. And over the years, at least it seems we are getting it right now. We have a new entity, and we stopped calling high-grade sarcoma something that's actually very low-grade behaving but ugly looking. So I think that's a great progress, and I just hope that meetings like this will help maybe speed it up a little bit, reduce the mistakes, and yeah, also spread the word to tell the general search path people where are we getting now. Yeah, thank you. Beautiful talk.
Thank you, Michael.
Can I ask a question, Dr. Lee? Okay. Yeah, really nice talk related to both. I can. Oh, so in the first, I think there's so much of histiocytes as a component of that inflammatory, which is going to be relocated now, probably in the next edition, from smooth to skeletal. There's so much of dense, macrophage. But when you see the immunos, desmin is all over. So I was just curious to know, are these macrophages an environment, or is there, the cells, the tumor cells are actually having some histiocytic appearance? What is your take on that?
That's a very interesting comment. There's a report about desmin standing on the foamy cells. Yeah, maybe some of the foamy-looking cells are not actually histiocytes. And there is another even more intriguing papers by Dr. Yoshida and colleagues. They reported 2 cases with a lot of mitosis in the histiocyte, but not in the tumor cells. So that can cause some confusion.
So when we call it histiocyte-rich, perhaps, it's a phenotypic alteration happening perhaps in the tumor cells. Yeah. And the next one I had a question was, you said mostly were H-Caldesmon. How many were H-Caldesmon positive to call as actually smooth muscle when you say pulmonary inflammatory leiomyosarcomas?
Yeah, so if you use the HCD clone, it's like more about just 1 or 2 cases are focally positive for them. But Michael's paper, you didn't mention the clone. It's the wrong one. It's the wrong one? Oh, I'm sorry. So if you use the wrong one, But it can be positive, yeah.
I think Dr. Falk corrected that HCD clone in that paper.
Yeah, yeah, yeah.
Thank you so much. Thank you. Yeah.
For the patients with MMR deficiency, do you think they will respond to immunotherapy?
I think we have a case with immunotherapy. It does not respond to the immunotherapy. But yeah, the case number is too small, so we still don't know which will work. Yeah.
Maybe about testing for TMB's tumor mutation burden. I don't know if that makes some. Okay. Yeah.
Very nice talk. Regarding that last category of pulmonary tumors, were the reviewers opposed to calling those low-grade leiomyosarcomas? Or they did not flat out want to call this leiomyosarcoma?
No.
I wondered about
it's actually
their reasoning.
Us saying that it's not appropriate to call it leiomyosarcoma, but we didn't, in the beginning, propose a term for it. Yeah, so there's that reactive.
Next talk by Dr. John Gross on the ossifying spindle and epithelioid cell tumor. Dr. John.
All right, let's get going. Okay, so I have nothing to disclose. I will say that our project is in the final stages of completion. So we'll start with a case, and this is the index case of this series. It was a 34-year-old male who presented with a painless 4-centimeter subcutaneous mass over his shin. Apparently the mass had been there for at least 3 years. It started small, like a little marble, and it slowly grew. Patient also denies any injury. So on x-ray, you can see this mass there right over the shin, and you'll also notice that there's an incomplete shell of bone surrounding this mass on the lateral x-ray. At low power histology, the mass is excised, and at low power histology, you see a shell of lamellar and a little bit woven bone at the periphery, and then you have a kind of a pink, somewhat myxoid, spindly tumor underneath that. At intermediate power, the cells of interest are predominantly spindled, and here they're shown intersecting fascicles. At higher power, you can see that there's a little bit of a fibromyxoid background matrix, but very bland spindle cells, as well as a subset of these kind of peculiar epithelioid cells sort of admixed. Let me just point out some of these epithelioid cells. And here again, spindled and epithelioid cells in this tumor. By IHC, this tumor is positive for CAM, CK56, CK818, and AE1A3. As you see, is a kind of discrete population within the greater mass. Importantly, this tumor is negative for things that you would have thought because it has sort of a myeloid, pink, eosinophilic, spindled appearance. So it's negative for actin, negative for desmin, myogen and S100, et cetera. Negative for ERG, has a sort of a pseudomyogenic kind of appearance to it. So I had to offer a very descriptive, kind of crappy diagnosis and said, I'm going to do molecular analysis and let's see what happens. And it was negative for fusions. More molecular, actually sent it to Michal. No fusions via his Illumina pan-cancer. He had done methylation, no match, and had a very flat copy number profile. All right, now we're going to move on to case number 2. So this is a 12-year-old male who had a 14-centimeter proximal thigh soft tissue mass. And you can see here in a AP plain film X-ray, you see it's a very large mass, but completely encased in a shell of bone. At gross, the fresh gross cut section, see a yellow friable mass encased in a shell of bone. At the top left, low power, again, you have a kind of a thick shell of lamellar bone, variably woven, and then a spindled, predominantly spindled tumor, but you also have this same subset of epithelioid cells kind of within this. You're not seeing a lot of inflammation, not a lot of giant cells, not much foamy xanthomatous inflammation within the mass. Again, by IHC, it's positive for keratin, but it kind of seems like it's a highlight in a subset. No fusions via Foundation 1, and he had done USP6 and SS18 FISH, which were both negative. He also sent it to Daniel, and Daniel did some molecular analysis, no match via the different classifiers, and is a essentially flat copy number profile. Some focal gains, focal losses were possible, he had said. And here's the profile that Daniel had shared. Now move on to case number 3. 27-year-old female, 10 centimeter axillary mass. And here's a formalin fixed specimen. See, now it's a little bit dehydrated and more tan, somewhat like firm. And then again, a shell of bone on the outside by Gross. And here's the specimen X-ray. You can again see that shell of bone there perfectly. By histology, at very low power, again, you got a shell of lamellar bone, somewhat woven. Then you have a pink tumor. It looks clearly mesenchymal. At higher power, spindled, but you also have a subset of epithelioid cells within this mass. There's more of the epithelioid and spindled morphology. Dr. Rosenberg's case is positive for keratin, CAM5.2, CK5.6, negative for these other things. Again, it has sort of that myoid, to me, appearance, where it's pink spindled tumor, yet it doesn't stain like you would think it would. No fusions via Foundation 1, and someone had done, actually the initial contributor had done PHF1 FISH for an ossified fibromyxoid tumor, and that was negative. Okay, so case number 4, 47-year-old male, 8 centimeter proximal thigh mass. Here we see a mass, relatively large, I think it was 8 centimeters, encased in a shell of bone on CT. At morphology, again, spindled and epithelioid pattern, kind of myoid pink cells. Again, and at higher power, you're clearly seeing these population of epithelioid cells within a background of largely spindled, bland. Keratin is positive. Positive for CK183, CK5.6, negative for these other markers that one would have expected, negative for the Archer multiplex at Stanford, also sent it to Michal, negative, no fusions there, no match, and a flat copy number profile. So that led to, we had 4 cases, that led to our initial project that was presented at USCAP last year. It's actually a little poster. And you can see here, again, at that time, we didn't really have any molecular information here, so this is really a morphologic, radiographic, and IHC diagnosis. And we have decided to use the term ossifying spindled and epithelioid tumor, kind of descriptive, but sort of giving homage to ossifying fibromyxoid tumor with the shell of bone, et cetera. Since then, we now have 10 cases. We have 6 males, 4 females. Average age is 32. The mean size is 6 centimeters or 5.7, but with a range quite, between 1.8 and 14. So a fairly significant range. Most patients presented with dull, painless masses from several months to at least 10 years. All had a peripheral complete or partial shell of bone. Most of these tumors arose in the extremity. One of the cases was in the axilla, fiber superficial and fiber deep. And then in the follow-up 9 of our 10 patients, no evidence of recurrence after primary excision. And with a mean of 20 months, we have a relatively recent case at 5 months, which I'll show later. Again, morphology, uniform, eosinophilic, myoid appearing spindle cells, vague intersecting fascicles, surrounded by mature lamellar woven bone. Again, the subset of keratin-positive epithelioid cells, generally very low mitotic activity. And osteoclast type giant cells is a focal finding in 1. That's a nonspecific feature, but we did see it in 1. But all lacked prominent histocytic or xanthomatous inflammation. Here's some low power pictures from our upcoming manuscript. Again, see, all these cases are completely surrounded by bone, or completely or partially surrounded by bone. And at higher power, predominantly spindled, eosinophilic, myeloid appearing cells kind of grown in vague intersecting fascicles with an admixed population of epithelioid cells that are positive for keratins. So the IHC profile for what we have, again, all of the cases were positive for CK56, and they were positive for A1A3, CAM, and EMA. They're all negative for actin, desmin, ERG, 34, S100, SOX10, et cetera. Molecular analysis had all been negative at Archer, Foundation 1, and in Michal's cases. And we're currently undergoing additional evaluation with methylation and RNA sequence whole transcriptome analysis at Hopkins, and actually received a phone call yesterday and talked to our genetics team at Hopkins. And so I'll give you a very quick little sneak peek, because again, this tumor didn't come out from a molecular perspective. It was a morphology, radiology, and IHC perspective. We do have a recurrent novel fusion in 4 of them. Two of the cases have some other novel fusion, and 2 cases had other novel fusions, C and D. But these aren't fusions that are on most panels. This is a case that actually, the most recent case, just 5 months ago, and actually Caris was the only commercial assay, or the only assay, outside of like a research setting that detected the same fusion. So this was a novel fusion A. We have 4 of these. So the differential diagnosis of ossifying spindle and epithelioid tumor certainly would include tumors that are encased by a shell of bone. So you'd think ossifying fibromyxoid tumor, myositis ossificans, a subset of xanthogranulomatous epithelioid tumor, or keratin-positive giant cell-rich tumor can be encased by a shell of bone. Of those, ossifying fibromyxoid tumor kind of cords, chains, epithelioid cells, variably S100 and desmin positive, wouldn't expect any keratin there. So it doesn't really look like ossifying fibromyxoid tumor. Myositis ossificans will have USP6 fusions in the majority and positivity for actin. Pseudomyogenic hemangioendothelioma is another consideration, but that's going to be positive for 31 and ERG. The xanthogranulomatous epithelioid tumor has a HMG A2, I think, N-core fusion. None of our tumors have that. Synovial sarcoma, again, spindle tumor, and the keratin expression may make one think that. Again, that's going to have a different genetic abnormality. And as well as epithelioid sarcoma, it doesn't have INI1 loss or anything like that. So in conclusion, we believe ossifying spindle and epithelioid tumor is a distinctive soft tissue tumor. It's characterized by complete peripheral or partial or complete shell of bone, intersecting fascicles of cytologically bland pink myeloid appearing spindle cells, and then a subset of keratin-positive epithelioid cells. So far, we have equal gender distribution, but generally arises in younger adults, superficial and deep sites, mostly in the extremities. And then finally, we believe it's unrelated to other ossifying or keratin-positive soft tissue tumors. An awareness of this entity in which we stress the importance of like pathologist direct radiographic correlation, as well as an application of limited panel of IHCs, including CK56, A1A3, and CAM, would help with this diagnosis, which is very favorable and benign. All patients are alive and disease-free after surgical excision. So I'd like to thank my co-authors, Abbas and Michael, Dr. Rosenberg. A lot of them are here in this audience, Daniel. And any questions? Josephine? I'd like to take any questions. Yeah.
Thank you, Dr. John. Questions? Yeah, Kamal.
Thank you for this, sharing this very interesting case. You know, I think I have seen such a case, but I probably misdiagnosed as, I think, synovial sarcoma. I don't know. But I know it's outdated, but what about the TLE1 in this case? Have you ever tested any cases? I mean, TLE1.
Yeah.
Because, I mean, you have a keratin positive, and if it's TLE1 diffuse positive, I would call, without genetics, of course, I would call, because you have a calcification or ossification, and you had it in the limb and or in a young patient, you know.
I think synovial sarcoma is a reasonable differential diagnosis, but I think there's a lot of differences in that. One of the pathologists did do SS18 FISH.
Any other questions?
I'll tell you, it's a fusion that you guys know, sort of the family, but you may not know this actual, well, it's novel, so. But it's a family.
I think sometimes uncertainty is serenity, and I think it's very reinforcing to see still as pathologists we can describe entities on morphology.
That's exactly right. This is a
Yes.
morphology, radiology, and IHC. That's where we've put these together. Molecular is completely unrelated to our series. But now we have some fusions, so it's cool.
Some fusions. Thank you very much. Yeah.
Okay, thanks everybody. Regarding the fusions, I think since we are going to brewery, I think we need to focus on John specifically, make sure that he enjoys a lot of beer. And then, you know, keep it among ourselves. Okay, so I think we've heard some amazing talks today. I'm sure everybody has a headache, so again, I repeat, all the talks have been recorded and they will be provided to everybody in this room as well as online 1 or 2 weeks, 3 weeks, I don't know, after this course, so you can watch again what you've maybe missed. So thank you everybody. We finish now and we meet at 5:20 in the hotel and 5:30 in the brewery.